Good morning, everyone. We heartily welcome you, all the delegates and the faculties to the 5th East Zone Neuropedicon. So we are going to start our first morning session on infant neurology and general neurology. For that, I would like to welcome our chairpersons for this session. May I welcome Dr. Santosh Agarwal, Senior Consultant, Manipal Hospital. Welcome, sir, on the stage. Dr. Sharvani Mishra, Associate Professor, Malda Medical College. Dr. Sabyasachi Ray, Consultant Pediatrician, Divine Child Care. Dr. B.K. Manocha, Senior Consultant, Bhagirathi Neotia and Clinic.
Hello. A very good morning to all and a warm welcome. I know it's a Saturday morning, so gradually we are going to fill up. But for the next 2 days, I'm so glad that we've got an excellent scientific agenda. And our first speaker is no other than Dr. Suchandra Mukherjee, who will be talking on neonatal encephalopathy beyond hypoxic ischemic insults. Dr. Mukherjee, please.
Very good morning. Good morning, sir and madam, my respected chairpersons and the delegate. And at the outset, my wholehearted thanks to the organizer for giving me the opportunity to start the session. And it's my duty as an opening batter. It's not the batswoman. So now we will go to our topic, that is a neonatal encephalopathy beyond HIE. So for next 25 minutes, we briefly discuss about the definition, etiology, approach to diagnosis, brief discussion of individual conditions, a few diagnostic clues, treatment and conclusions. So neonatal encephalopathy, why they have, it is the first session because neonatal encephalopathy is not very uncommon. Secondly, it is the commonest CNS emergency in newborn and infants. Thirdly, it is the predictor of long-term neurodevelopmental outcome. So neonatal encephalopathy is defined as a condition occurring in babies born over 35 weeks because it is defined in the late preterm and near-term infants to term, because in premature infants, these this nervous system is very dynamic and every hours will change the neurological functions. So to define with a categorical some criteria, if we have to put, so the baby must be near term. The key features definitely the disturbed neurological function because it is encephalopathy, and with that it will be associated with quality of consciousness. It may be side stupor to deep coma. Other features may be present like seizure, cardiorespiratory compromise, and abnormal tone and reflexes. So if we go to the etiology of neonatal encephalopathy, there are various factors and sometimes they are working together, sometimes there is one factor upon other, like preconception risk factor, maternal risk factor, placental pathology. It is very important, especially for perinatal stroke, hypoxia, ischemia, perinatal infection, neonatal stroke, thrombophilia, metabolic and genetic epigenetics in epileptic encephalopathy. So always, though my topic is beyond HIE, but HIE is the commonest cause of neonatal encephalopathy, and sometimes the other causes like metabolic encephalopathy, structural epileptic encephalopathy, they just mimic hypoxic ischemic encephalopathy unless we are very sure that the pathology and the from history that it is not the perinatal hypoxia that causes the encephalopathy. So 50 to 80% of cases based on clinical EEG and MRI criteria, it's HIE. The incidence in LMIC is quite high. In the developed population, it is 1.7 to 1,000, but here it is 1.5 to sometimes 20 per 1,000 live birth. And with more severe encephalopathy, that will be definitely higher case fatality and definitely adverse neurological outcome. So etiology, again, there is another entity that is known as double trouble. Very commonly, we are getting across such type of situation where the baby is suffering from any genetic disorder, or sometimes it is not very infrequent, the babies with a birth trauma may present with upper cervical cord injury, presenting like floppiness. And these conditions, sometimes congenital myopathy, they are complicated with secondary hypoxic ischemia. So it is actually the double trouble. So looking like it is a HIE, hypoxic ischemic encephalopathy, but background is something else. So this is the approach, how to approach for any baby presenting in the NICU with stupor, lethargy, apnea, sometimes they are throwing seizure. So the history, thorough history and examination in detail, including neurological examination, is very important and it is very crucial. First line investigation, mainly the excluding sepsis, coagulation disorder, HIE, inflammatory markers, if available, glucose, lactate, blood gas, and definitely HIE, EEG. Then we will go for the exclusion of HIE. If it is not present, then the second tier, like we have to exclude the metabolic encephalopathy and some type genetic epilepsy. So maternal history, if we start with the history proper, then you have to start from the maternal and family history. So maternal history is important because it is sometimes acute sentinel event for HIE, fetal growth restriction, multiple pregnancy, twin transfusion is very important for perinatal stroke, maternal infection, TORCH infection, and some maternal hypertension, HELP syndrome, preeclampsia, PPROM. These are very important history for knowing the cause of encephalopathy. Past medical history, again multiple miscarriage, stillbirth, and neonatal death, unexplained neonatal death will give a clue about the metabolic encephalopathy, thrombophilia. Diabetes, deep vein thrombosis in family, acute ischemic stroke, sometimes it runs in the family if there is collagen 4A1 gene mutation, thrombophilia if it is familial, sometimes cataract may present with this myotonic dystrophy, we all know, and sometimes there is genetic mutation if it is present, and pedigree chart, 3-generation pedigree chart. This is very important not only for the geneticist but for us pediatrician, neonatologist, and the students for pediatrics. And family history and examination of the parents. Sometimes we have to do the parental examination when we are suspecting neuropathy, myopathy, especially the myotonic dystrophy, neuromuscular junctional disorder, myasthenia gravis, and maternal myotonia. We always look for if we are suspecting myotonic dystrophy in newborn or infant. Neonatal examination, again the size of head is very important, dysmorphism, rashes for neurocutaneous disorders, spinal involvement, birth trauma may cause cervical injury, external internal ophthalmoplegia, especially in myasthenia gravis, facial weakness, and neonatal hypertonia. So for the second tier, we have to exclude sepsis, hemolysis, if it is bilirubin encephalopathy, severe anemia, again for any collection of blood in brain, that is intracranial hemorrhage, increased ICP, secondarily due to hydrocephalus, persistent weakness, contracture, if it is neuromuscular disorder, and secondary causes without persistent weakness, it is extraneural causes causing encephalopathy due to severe hypoxia, lung and cardiac causes, and again another entity is refractory seizure. So there is some seizure presenting with some vitamin deficiency, these are treatable. So early diagnosis for this kind of refractory seizure, because there is a targeted therapy with pyridoxine, biotin, folinic acid. So this is very important along with your anti-seizure medications. So if it is hypoxic ischemic encephalopathy, then there should be perinatal events, sentinel events like uterine rupture, cord prolapse, sudden bleeding of the mother, abruptio, fetal heart rate abnormalities in CTG, acidosis, multi-organ impairment supported by EEG or AEG. So we can tell that the baby is suffering from hypoxic ischemic encephalopathy because all these criteria are fulfilled. Now, again, there is a HIE mimic in perinatal stroke, especially in the venous thrombosis, and if it is associated with intracranial hemorrhage. So, perinatal stroke has been defined a group of heterogeneous condition, definitely, because there is ischemia, there is hemorrhage, and their etiology may be artery, maybe vein, and sometimes there is sinus, venous thrombosis in the sinuses, secondary to arterial and venous thrombosis, embolization, but the time period is very important. It's between 20 weeks fetal life through 28 postnatal day. Approximately 80% neonatal stroke are ischemic, rest 20% are sinovenous thrombosis and hemorrhage. So, there are three kinds of perinatal stroke. One is definitely fetal. Fetal stroke presents with chronic encephalopathy like microcephaly. Sometimes baby is showing very early neurological changes like hypotonia, abnormal eye movement. So, these are chronic encephalopathy if the baby suffered from fetal stroke. Neonatal stroke is perinatal period to 28 days of life. So, they present with acute encephalopathy like stupor, coma, and sometimes seizure, but mainly seizure occurs more than 12 hours of age. But commonest presentation is perinatal arterial ischemic stroke is seizure. And if they present with seizure, there will be 3 times higher chances of epilepsy in future. Another entity is presumed perinatal ischemic stroke, that is PPIS, when the baby present in later half of infancy, but we are not sure the time of onset, but usually it is perinatal, but the baby presents late with asymmetry of neurological function and sometimes with seizure. So, it is PPIS. So, clinical presentation, that is a chronic encephalopathy in fetal, neonatal is acute, and PPI present with early hand preference and sometimes developmental delay, motor impairment or congenital hemiplegia. Ischemic perinatal stroke, it is a arterial origin, may be venous, and perinatal hemorrhagic stroke may be associated with venous infarct, and sometimes we are getting simultaneously with neonatal or preterm babies IVH with hemorrhagic parenchymal infarct in preterm baby. So, it is hemorrhagic stroke, venous origin, and there will be associated with intraventricular hemorrhage. So, again, if the causes of stroke is maternal cause, very important, chorioamnitis, preeclampsia, and it is PPROM. For infants, it is sepsis. Again, meningitis, ventriculitis are important for venous stroke and sometimes arterials as well. And sometimes twin transfusion, if it is MCD or MCMA, twin is very common twin transfusion. Hypoglycemia, dehydration, hypernatremia, they are commonest cause of neonatal stroke. But thrombophilia, it's very rare, it's not very common, and routine thrombophilic profile is very difficult to do in newborn because there is physiologically low protein C and protein S and physiologically high factor 5. So, if the protein C is less, then factor 5 accumulation will be more, and so there will be physiological thrombophilia. Unless there is definite family history, then there will be not much yield in doing routine thrombophilic profile. But yes, if you can do if it is a strong suspicion, but again the repeatability or recurrence risk is less. So, placental factor, again thrombosis and infarct in placenta, especially FGR, IUGR cases, that is very important, and we often miss out because we are not looking for placenta while the baby is suffering from neonatal encephalopathy. So, these are the picture of the perinatal stroke. It is very important, and it is arterial stroke. This is a wedge-shaped infarct. This baby presented to us at 8 months of life with a asymmetry, one side weakness and abnormal eye movement. So, it is a ocular dyskinesia. So, previously we thought that it may be a case of PPIS, but when we took history from the mother told that she knew before in the fetal profile scan that the baby is having ventriculomegaly. So, it is actually perinatal or maybe the fetal stroke. That's why baby presented very early infancy with abnormal eye movement. It is a horizontal roving eye movement, and there is a evolving hemiplegia and the global developmental delay, and classically there was ventriculomegaly and is a perinatal infarct it's in the left side. It may be a venous infarct because it's very difficult to say what is the causative pathology because it is the term baby. So it is not PPIS, but it was a fetal stroke. Again, it is another entity, especially in the premature infant, that is encephalopathy of prematurity. So hallmark of encephalopathy of prematurity is cerebral white matter injury, and classical is the periventricular leukomalacia. So insult is cerebral ischemia and systemic infection and inflammation. Again, there is a time period. It's very important. So two things are important, either infection and or inflammation. So there may be chorioamniotis, amniotic infection leading to systemic inflammation, HIE, in utero, mechanical ventilation, it is after birth, ex utero, neonatal sepsis, shock, necrotizing encephalitis, enterocolitis. This will again give rise to systemic inflammation. Pro-inflammatory cytokines will be raised, activation of this marker, activation of microglia, neuroinflammation, microglia astrocyte, oligodendrocyte desmaturation. This is very important because there is an important cell lineage in brain. This is oligodendrocytes. So these are the myelin forming cell from the progenitor cell. It is pre-OL, that is pre-myelinating oligodendrocytes, and that will give rise to oligodendrocytes. So if there is any injury, so why injury is very common in pre-OL, that is pre-oligodendrocytes or pre-myelinating oligodendrocytes, because they are the most vulnerable population of the cell lineage to ischemia and inflammation. When it is mature, to mature oligodendrocytes, then the this injury due to inflammation and infection will be less. So this cell will be less susceptible to injury than this pre-OL. And there is time period because the developmental period is from 23 to 32 weeks. So in that period, if there is in utero inflammation or infection, then this pre-OL will be damaged. There will be arrest in maturation and differentiation to the next generation, and there will be pre-OL cell loss. So pathology-wise, there is oxidative stress from the inflammation and infection from the maternal side as well as from the baby's side, fetal. So there will be mild and too severe. It is a spectrum of injury rather, white matter immaturity. So there will be diffuse white matter injury or white matter necrosis, and there is two types of injury. One I have already discussed, this pre-OL injury and maturational arrest or loss. Secondly, there will be actional injury. So in both ways, either it is pre-OL injury or if action is damaged due to ischemia and inflammation, in both ways there will be injury to the developing action and myelin formation will be disturbed. So at the end result, there will be less myelin. So hypomyelination is hallmark due to this ischemic inflammatory injury of premature infant, and in the fetus, remember the time period, it is from 23 to around 32 to 34 weeks of life. So pre-OL injury and death and this hypomyelination, it is the central feature of cerebral white matter injury and hallmark of PVL. So it is not only the white matter injury, though we call always that PVL means white matter, but it is not like that because there is transsynaptic degeneration of the deep nuclei like basal ganglia, putamen, thalamus, especially thalamus and basal ganglia. So they gets damaged due to these ischemia and inflammation in utero, and there will be neuronal loss and gliosis, or sometimes both, in hippocampus and cerebellar dentate nucleus. So in long term, the baby definitely will suffer from CP, spastic diplegic CP, because of the white matter injury, but they will suffer from cognitive delay, atypical behavior, visuospatial memory loss, and loss of executive function. So these are very important in long-term follow-up for PVL. So this is the classical picture, ultrasound picture of cystic PVL. Nowadays cystic PVL is less. More common is punctate PVL. It is less severe, and sometimes it is a diffuse white matter hyperintensity DESI. but there will be no degeneration or the encephalomalacia. And this MRI findings is typical site of the PVL cyst. Often it is bilateral, and it's the periventricular white matter to the frontal horn. So diagnostic clues: maternal fetal infection, inflammation, cerebral white matter injury, hypomyelination, and there is a spastic diplegia, most common motor impairment due to PVL. So now we are moving towards the inborn error of metabolism. If these are not found and there is some classical presenting features, that is metabolic encephalopathy. So clinical hallmark of the condition are poor feeding. We all know how we are suspecting metabolic encephalopathy: vomiting, seizure, stupor, lethargy, rapidly leading to deep coma, and subsequently it is very fatal sometimes, or it may lead to severe neurological impairment in the survivor, but there is some diagnostic clues. So we can divide these three groups of this metabolic disorder: group 1 and group 2, they are micromolecular, and group 3 is macromolecular. So group 1 and group 2 will lead to encephalopathy. Group 1 disorder, there will be either proximal to the block, some toxic metabolites are accumulated in brain, and sometimes there is deficiency like pyruvate decarboxylase or this TCA cycle mitochondrial disorder, where the ATP formation will be defective, and so there will be encephalopathy. So in both ways, either due to accumulation of toxic proximal to the block or due to deficiency of ATP. And group 3 is macromolecular, so it presents late with developmental delay and other disorder. So very classical is phenylketonuria, so phenylalanine, and it is the phenylalanine hydroxylase, and BH4 is the cofactor, so it gives rise to tyrosine. So if there is block and deficient enzyme of PAH, that is phenylalanine hydroxylase, so proximally there will be accumulation of phenylalanine, phenyl pyruvic acid, phenyl acetate and phenyl lactate. They will cause brain damage, and on the other hand there will be deficiency of neurotransmitter, because phenylalanine hydroxylase will form tyrosine from phenylalanine, and that will give rise to dopa and menaline. So if there is a block in PAH level, then there will be low tyrosine, low dopa and melanin, so there will be again neurological features. And pyruvate metabolic pathway is a hallmark of group 2 disorder, when there is deficiency of ATP formation, and the baby will suffer from again encephalopathy and myopathic features, and there will be metabolic acidosis and seizure. So urea cycle disorder, we all know it is a very common metabolic disorder, and it is a very common cause of encephalopathy in newborn, and especially it present around the end of the first week of life, depending upon the severity and enzyme block, site of enzyme block. So here the glutamate and glutamyl is the culprit for encephalopathy. So if it is excess ammonia, because there is a glutamate and ammonia will form excess glutamine in brain, that will cause swelling of the astrocytes, and there will be a depletion of alpha ketoglutarate, so decreased ATP formation, and these excess ammonia will form NMDA receptor excitotoxicity, more calcium influx into the cell, and that will cause mitochondrial damage. So this is the cause of encephalopathy of urea cycle disorder, and there is a number of enzymes which are responsible, mainly autosomal recessive, and OTC is X-linked. So you have to know the cycle proper for going to final diagnosis. Phenylketonuria, I have already described why there is encephalopathy. So there is some marker like microcephaly, facial dysmorphism, pars hypopigment, hypertrichosis, skin rashes. So these are the neonatal marker, so you can know the cause of encephalopathy. So biochemical evaluation is lactic acidosis with hypoglycemia, lactic acidosis with normoglycemia, ketosis with hypoglycemia, mainly the isovaleric, it is organic acidemia mainly, propionic and methyl malonic acidemia. And for diagnosis, you have to do GCMS in urine for abnormal metabolite and amino acid all carnitine profile in LC-MS in blood. So this is urea cycle disorder, this cerebral edema, and there is peak of glutamine. This is MSUD because this leucine, isoleucine, valine, this branch and amino acid disorder, there will be more white matter damage because of this leucine encephalopathy, and branch and amino acid peak you can see in MRS, and there is a typical this comb-like 3 Hz pattern of EEG. It's quite different from our conventional HIE EEG. And this is glycine encephalopathy where hypomyelination and this glycine peak, typical there is a bus suppression pattern. It's looking like HIE, but in MRI there is a faulty myelination. Diagnostic clue, deterioration after a period of apparent normalcy, parental consanguinity, family history of neonatal death, that's why pedigree chart is important, rapidly progressive encephalopathy, severe metabolic acidosis, persistent vomiting, and peculiar order, because MSUD at 12 hours of life we can get this cerumen because it is a end product of isoleucine, so it's very early you will get the abnormal odor in cerumen at 12 hours of life, and the positive uric metabolite comes at the end of the first week of life. So the last is the developmental epileptic encephalopathy. So these are not very common, but you have to diagnose to know the targeted therapy. Most commonly they are genetic, some structural like lissencephaly, metabolic disorder. Seizure onset must be within first 3 months of height. Usually they are not present in the first half. If it is present in the first few days then and family history is present, then we have to suspect the self-limiting neonatal seizure, but developmental or epileptic encephalopathy usually present 3 months onwards, and the seizure are frequent and refractory. The interrectal EEG is highly abnormal and showing bus suppression pattern, diffuse slowing and multifocal discharges, and very important is the neurological examination. Most cases the neurological examination is not normal, unlike the self-limiting epilepsy in newborn where the baby is normal neurologically and neurodevelopment wise normal, and mostly the self-limited epilepsy subsides within 1 year of life. So children presenting with epilepsy, it's high burden of cognitive behavioral comorbidity, higher rates of drug resistance and mortality, 50% showing global developmental delay by 2 years of life. And why we are this neonatologist and pediatrician have to know this entity, because there is targeted therapy with carbamazepine and phenytoin. So these are the investigation and the channel blocker drugs, and now cannabidiol is available in India, CDSCO approval, so the pediatrician and pediatric neurologist they can use because it is marketed in India. Diagnostic clues I have already described. So key message is optimal perinatal neonatal care is very important, because remote seizure and epilepsy after perinatal stroke there is 3 times chance of epilepsy, strong index of suspicion for metabolic encephalopathy, early genetic structure and metabolic diagnosis is crucial to diagnose or to differentiate metabolic encephalopathy or DEE from HIE. Thank you. Sorry sir for exceeding the time limit.
Thank you very much, Professor Mukherjee, for talking on a subject which is so difficult and complex beyond HIE. So if there are any comments or questions, I think we'll take at the end of the session. Is that all right?
Hello. Our next speaker is Dr. Vibhan Shah. I'll welcome Dr. Shah and request him to deliver his speech.
Can I just add something about Vibhan, please? He's our friend from Manchester, and he has more than 35 members of the IAP in the UK. Now I'm sure the figure has gone up.
52.
52 now. And he bridges the gap between India and the UK. Thank you, Vibhan.
Next, So, thanks very much. I think it was quite a hectic tour to India this time and had a lot of family commitments, but altogether, something to give back to where I was trained. Dr. Agarwal was one of my consultants when I was a registrar here. So quickly into a very sort of a debatable topic after listening to Professor Mukherjee. So the topic for today is therapeutic hypothermia, to cool or not to cool, balancing decision and ethics. So I come from a place and trained in UK in a place which is an active center for cooling. And I'm sure there are a few centers in India which are currently practicing cooling. So I'm not going into the details of cooling. What we are going to discuss in the next 20-25 minutes is probably how do you balance your decision in regards to cooling, and what do you do when you receive a baby or you have to make a decision about whether we should be going for the cooling or whether we should just continue with normal standard care. So just consider this case. This is Sarah, who's a term baby, born by section, initially born flat, as you say, IPPV for 3 minutes. Upgars were 1, 6, and 8. Now, cord pH was 7.08 and base excess of -12. Stayed with mom as was breathing normally and pink. So it is quite a common scenario that you get in your practice, basically, isn't it? And then at 1 hour of life was found to be slightly hypotonic, and at 4 hours, yes, still hypotonic, slight poor feeder. I think this is a common scenario anyway. All of a sudden, this child ceases at 10 hours of life. Yeah? And then, down the line, at 7 days of life, when you do an MR, we see extensive changes which are consistent with the HIE. So this is a common scenario, a common thing that this is just a background to what I'm going to discuss today. A common scenario which probably every practitioner faces, whether they're in a small hospital, big hospital, tertiary hospital, corporate hospital, wherever it is, basically. So let's talk about this. So I think we had a sort of a idea of what the burden is like. If you look here, the burden is nearly 10 times in developing countries as compared to developed countries. Yeah? And if you look a quick slide on the pathophysiology, if you look at it, so when a baby suffers an hypoxic insult, there are 2 or 3 stages of this insult, basically. There's a primary energy failure and a secondary energy failure. Yeah? So the primary energy failure will give you all the increased lactate, pump failure, reduced flow, and there is cell death. However, in between the primary and the secondary, there is a latent phase of reperfusion, which we all know about. So the entire talk is probably catching that phase, and that is why it is time critical. Because once seizures start, you have gone into secondary failure already. So whatever you do after that is probably might help you, but may not alter the course of the illness or the further neurodevelopmental outcome. So you are concentrating on that phase. The problem is the baby will not tell you whether I'm in primary or secondary energy failure, basically. That's the problem. So you have to be very meticulous. And the only meticulous thing that you can do is, yes, there'll be some numbers to work on. However, there has to be some clinical acumen and clinical examination acumen as well, which will tell you that this baby probably may qualify for cooling. So this was the biggest trial that was done in UK, the TOBE, which had about 500 babies in both the cooling arm and the non-cooling arm. And it is quite a comprehensive criteria. They have broken it down into criteria A, B, and C. So if you look at the criteria A, this is more than 36 weeks, Apgar score less than 5, continued resuscitation, acidosis. So this is very important because a lot of babies may not have the cord blood done. Yeah? So it is not the cord pH. It is the worst pH within the first 1 hour. So within 60 minutes, either it's the cord pH or the worst pH. It can be venous, it can be arterial, it can be capillary. So you have to take the worst pH within the first 60 minutes of life. Yeah? And a base deficit gas within 60 minutes. So similar, the last 2. So these are pretty objective, isn't it? Pretty objective criteria. And then to be defined it, that next one is criteria B. The problem with the criteria B is, this is a neurological examination done by different people at different time, which will evolve. This is, again, subjective. So if you look here, altered state of consciousness, abnormal tone. So my SHO goes and examines, tells me it's a bit hypotonic. I go 2 hours later and see, no, this looks to be hypertonic. So again, this is very subjective again, isn't it? So if you look at it, so if any of the criteria A is satisfied, it doesn't need to be all the criteria. If any one criteria is satisfied, you should be going to criteria B. Okay? And then again, if any of this criteria is satisfied, Toby defined that if A and B are satisfied, then you should be thinking of cooling. However, there will be some gray areas where you cannot decide for sure that whether this is a proper neurology, abnormal neurology, based on a background of acidosis, or whether this is a normal neurology. And that is why Toby defined in places who have got a cerebral function monitor, if criteria A and B are satisfied, then a criteria C comes into place, which is a amplitude integrated EEG bedside. So this gives you probably another objective method. It is not always decision making, but for those gray cases, you can make a decision based on that, basically. So at least 30 minutes of amplitude integrated EEG, which shows either moderate or severely abnormal. As of now, there is no evidence for cooling in mild encephalopathy. It is just the moderate and the severe. The maximum result is with moderate, if you can catch them. The severe, the cooling doesn't make that much of a difference because the severe ischemic things do not respond that much to cooling as a moderate will do. The best results are from the moderate encephalopathy, which I'll come to in a minute when you are scoring these children. Duration cooling, we all know, is 72 hours plus 6 to 12 hours of rewarming. I'm not going into the details of cooling. These were the exclusion criteria. Older than 6 hours. However, there is a pragmatic approach in if you are, say, if you transfer from a distance, you can make a therapeutic decision between 6 to 12 hours. So it can be extended to 12 hours. So, but based on a case-by-case approach, based on what? Contraindications, major congenital abnormality, but bear in mind, Down syndrome is not a contraindication. So Down syndromes should get the benefit of cooling if parents agree. Okay? Any condition that demand immediate surgery, imperforate anus. Why imperforate anus? Can anyone tell me? Because you can't insert the thermometer, because you have to do a central core monitoring of temperature. So that is very important because you have to keep your temperature between 33 and 34, basically. So cooling less than 33 is bad, and warming more than 34 is bad as well. So the central temperature has to be maintained all the time. So that's why imperforate anus is not going to help you, basically, yeah? And if it is a moribund infant, keep in mind, NRP takes priority. Resuscitation takes priority. So while you are resuscitating, if the baby is not stable, please do not start passive cooling. Temperature comes first. Once the baby is stabilized with temperature, airway, breathing, circulation, then you can think about cooling. So if there is a moribund baby going ongoing resuscitation and you know this baby is probably hypoxic, you shouldn't be switching off the radiant warmer. So temperature, because the baby will die from hypothermia anyway during resuscitation. Okay? So now the question comes back to Sarah now. Now that baby was probably mildly encephalopathic, isn't it? Now is it unreasonable to cool a newborn with mild? Sarah has lost the critical window because of the absence of criteria. If you remember properly, Sarah's pH was 7.08. So he didn't qualify because the COT pH that tells us which is satisfied criteria is less than 7. So that pH was 7.08. So he didn't qualify for criteria. However, and then there was a mild hypotonia at 1 and 4 hours of life, isn't it? So whether time is there to think, these were the entry criteria for Toby at that point of time. Time to think now, is it irrational to probably cool babies who have got mild encephalopathy? I'll come to that with the COMET trial in a minute. Limiting factors, Apgar scores are again subjective. Yeah, inter-observer bias, COT pH can be misleading, as Toby criteria as pH less than 7.1, we said with abnormal area can be more suggestive of HIE. But Toby described it at less than 7. But between 7 and 7.1 is always that gray zone. Okay? Dynamic continuum, as I told you, evolving and regressing with time because the neurology changes. And neurology assessment is intrinsically subjective. So the most important thing is the senior most person present on the unit should be doing this examination. Okay? We know about Sarnath scoring. Again, slightly subjective again, which is again mild, moderate, severe, but I think we should be moving to Thomson now, because Thomson is more objective. I'm sure a lot of your units are currently doing Thomsons. So it is more objective. It has a score between 1 and 12. If you look here, maximum score is 22, mild is 1 to 10, moderate 11 to 14, and severe is 15 to 22. So there is a statistical application. If you look at the p-value, morbidity was, so this Thomson score was actually developed in Delhi. So causes a median score of 9, Thomson score greater than 12 associated with death, basically. So this is our guideline. I'm not sure whether you can see it very well. If a COT pH is less than 7.1, that should be repeated neurological examination, which I'm going to come to in a minute. Let's come to this case again. A new case, baby HL, 39 plus 3, what we've learned as of now. 4 kg, difficult instrumented delivery. Apgar score is 6 and 8. COT gases 6.98, base excess minus 8.6, lactate 6.1. Gas at 1 hour, pH is 7.28. Base excess minus 4, lactate 7.7. Let us get it a bit more interactive. So if you look here, the COT gas, that is the worst gas that we have at the moment, isn't it? It is less than, COT pH less than 7. Now, we have examined the baby at 1 hour, moderate suck, slightly agitated, hyper alert. Morose is incomplete, stable hemodynamically, otherwise blood sugar is 2.2. So that is about, how much is 2.2? About, just about 50, 40, 45 probably, isn't it? So that's where we are. So look at this case again. That's where we are. So this baby has satisfied criteria A according to the TOBI, isn't it? Because his COT pH is less than 7. Any of the criteria is positive, basically. Now, this is examination at 1 hour. What do we do? Correct hypoglycemia monitor, re-examine at 4 hours, admit to NICU and monitor, admit to NICU and start CFM. Anyone? 15 seconds, sorry. Okay. So we'll keep the patient in the postnatal ward and correct hypoglycemia there, or do you want to admit to NICU? Sorry? Absolutely. So we have to admit to NICU. If you have CFM, well and good. So either 3 or 4, basically. If you have CFM, it's 4. If you have cerebral function monitoring, it's 4, because this is the gray area, because this child is otherwise well hemodynamically, isn't it? It's just a bit of moderate suck, mildly agitated. So probably we'll classify for mild encephalopathy, isn't it? So probably admit to NICU and monitor. If you have CFM, start CFM. Yeah? So this is the CFM, just a brief idea. So if you look at it, this CFM, this part, what we look at is the lower limit, and this is the upper limit of the CFM. This is the CFM, and this is the raw EEG here. So this is known as the sleep-wake cycling. So I'm not going to go into the details of CFM. This is a normal CFM in the baby. So if you look here, this is a sleep-wake cycling. You have thick, thick, thin, thick, thin. Lower limit more than 5, upper limit more than 10. So that's our normal CFM basically. So this is a continuous normal CFM. So Thomson score is 5 on examination at 4 hours, diagnosis and management. What do we do? Thomson score 5 with a normal CFM. This is mild encephalopathy basically, isn't it? On the lower side of the Thomson score. This is at 4 hours. The window is till 6 hours, but 1 and 4 hours, because if you make a decision at 4 hours, you still have got 2 hours if you have to transfer the baby out, or if you have to set up the cooling apparatus basically. So the 1 and 4 hours, these 2 examinations are of utmost importance. That neurology, if it has changed between 1 and 4 hours, then the baby moves towards the cooling side. If neurology is getting normal, it moves to the non-cooling side. So it's a mild encephalopathy. There's not much evidence. Do not cool. Normalize. Yeah? Consider the second case now. Baby K, 39 plus 1. Sorry. 39 plus 1, delivered emergency section. Apgar 5 at 1 minute, 7 at 5 minutes. COT gas is 7, bang. Yeah? Minus 15.6. Gas at 2 hours, now pH is 7.25. And a base excess minus. So the pH has improved now. Yeah? Staring with a partial moro, poor grasp and suck, full fontanelle. Okay? That's the CFM again. Pretty much similar to the previous one. If you look at it, lower limit is you consider the thick parts only, you disregard the overshoots. The thick part is more than 5, so it's a normal functioning brain. The thick part on the upper limit is more than 10. So that's the CFM on admission. Yeah, this is a Again, a gray case, which is evolving with time. So look at this. So this is a normal continuous CFM. At 4 hours, this baby starts cyclical movements. For 1 minute, lip smacking lasting less than 1 minute, stable hemodynamically still. Diagnosis, and now the CFM, how the CFM has changed. Look at those. This is the pyramidal pattern. So the baby is seizing there. So those are the seizures. And if you look at, this is the raw EEG. From the wiggly pattern, it has changed into a rhythmic pattern. Yeah? So at 4 hours, if you have seizures, within the first 6 hours, it goes into the moderate encephalopathy, irrespective of the rest of the findings. So your decision is easy. So this CFM has given us an idea that this baby is seizing. So it is moderate encephalopathy, which may not be. So yes, there was clinical seizures, but the CFM has picked up as well. Here, the baby is moderately encephalopathic. So we have to cool. Okay? Outside the criteria, quickly, because we said it was 36 less than 36 and above. No evidence of benefit, but clear evidence of safety profile. So if parents agree, you have to offer, if you have got the facility. There is very less evidence below 35 weeks, because cooling has got its own complications. So we shouldn't be cooling less than 35 weeks. Again, not offered between 6 to 12 hours. Again, for a developing country like India, I think if the parents are in agreement, we should be offering, because the parents might be coming from a periphery, and it might take some time to reach. So 6 to 12 hours, if they can maintain passive cooling, keeping all the, if the baby is hemodynamically stable, because if you have successfully resuscitated, hemodynamically stable, then you can start passive cooling and transfer the baby. Within 6 to 12 hours, you can still make the decision to cool. Okay? This is another one. This is quite a common scenario, postnatal collapse. All of a sudden, at 4 hours of life, mom fell off asleep, baby was on the breast, the baby collapsed, basically. Yeah, this was a BPSU study many, many years ago, which showed the commonest cause for this collapse was upper airway obstruction. Yes, there were few conditions which turned out to be metabolic, turned out to be cardiac, but then again, a postnatal collapse at any time within the first 72 hours qualifies for cooling. But your cooling time starts, or your time of 6 hours starts from the time of the collapse, not from time of birth. So you will be called at 4 hours into the postnatal ward, baby has collapsed, you go and see the baby blue. You don't know what has happened really. So you resuscitate the baby, you make a quick examination, similar again, do a gas. If that gas is less than 7, that time starts from there. Yeah? And then you do neurology at 1 hour and 4 hours. This baby should be offered, whether we do it or not. If there is a facility for cooling, you should be doing it. Now comes the important consideration. Decision to consider hypothermia by endangered substance. Now, if we, because we have a lot of our obstetric friends, we have to sometimes work with them, isn't it? The things about litigation come in. That when did this injury occur, sir? When did this injury occur? That will be a pertinent question with the, when did this hypoxic injury occur? That will be a pertinent question with the mom and dad will be asking you. Kokhon holo eta? When you tell them. So it is very, very hard to define. I think it may be an antenatal factor, it may be a perinatal factor, or it may be a postnatal factor. Yeah? But failure to offer treatment which has got a therapeutic value, you have to discuss with them if facilities exist. You cannot predict what 18 months down the line will give this child. But if there is a facility and if the baby qualifies, you have to give them, because it is therapeutically proven. Provided you have a proper NICU. Without an NICU, you shouldn't be, without a level 3 NICU, you shouldn't be offering cooling. Yeah? COMET trial, this is currently going on in UK. The first COMET said there was no benefit. The second COMET is currently on for mild encephalopathy. I'll skip through this. I'm sure all of you are aware of the HELIX. Yeah, the HELIX trial, which was the biggest trial across the low, medium incoming countries, Bangladesh, Sri Lanka, India. So that proved that cooling shouldn't be practiced. However, there were a lot of confounding factors there. If you look at it, there was more. So if you look at what Dr. Mukherjee, Professor Mukherjee just said, the hypoxic insults are usually located to the basal ganglia, thalamus, whereas the MRI which showed the helix trial was mainly white matter injury. So those babies had, most of them had other, or the babies were already seizing by the time they came. So already the secondary energy failure and other problems were there associated, which was not a typically hypoxia alone. Yeah? So there was lack of sentinel events in helix trial, only 13% as compared to 48% Toby. There was no immediate peripartum events. They were all acute on chronic hypoxia. These babies were chronically hypoxic intrauterine. That's why the MRI changes involve the white matter as well. And not really, because if it is an acute event, it will be mainly located in the basal ganglia. Okay? Seizures within few hours of blood, resuscitation and care of babies who were admitted to centers were ill documented. So it was very difficult to quantify helix. So that's my last take home message. Document a full neurologic examination by the most senior person if you do not have CFM. Criteria B can be subjective. CFM can be used in these gray areas as an important objective adjunct, and meticulous neuroexamination with senior advice following mild HI to make a pragmatic decision of cooling. Thank you.
Dr. Saha's practical knowledge, first-hand knowledge, he's explained such a difficult subject in such a simple language. But about this cooling, is it still controversial, like subject? Like, is it done only?
It is in Western countries. Yeah. This is a standard therapy of care. If they are objectively satisfy all the criteria, it is a standard subject. What I try to bring about here is, in a low and medium incoming country, there are few centers who have started cooling. So selection of the case is very important. So unless you select the cases, you won't have a good result, because a lot of the helix trial, the selection of the cases, if you look at the, if you go through the synopsis and the considerations which helix took, a lot of these cases wouldn't have fit into the trial, but they were cooled, and thereafter the mortality was 48%, whereas Toby mortality was only 20%. So which means that the babies, that there were other factors, or they were all in NICU. So I think it is so, because it is so time critical, the passive cooling should start as soon as you have established that this baby will be satisfying for cooling. So the earlier you start it, the best it is.
The 6 hours period is set?
6 hours, but it can be extended to 12
24 hours also?
No, up to 12
hours.
So evidence is only up to 12 hours.
Dr. Saha, what is the cost of cooling in the UK? The cost of cooling?
Cost of cooling, that's a good question, because everyone gets it free. So, I mean, there is a center in Siliguri which has started it at the moment, and I think it is not more than what you would spend if you have admitted a patient with myocardial infarction in an adult ICU.
Dr. Saha.
But the concept is not there in the sense that a neonate needs intensive care as well, and they are not insured. I think those are the drawbacks sometimes.
Dr. Saha, are you practicing whole body cooling, or some centers are still doing selective head cooling?
No, whole body.
Whole body.
Total body.
So selective head cooling is out of fashion, is that right?
Out of fashion, totally.
Yeah, that is also what I found in the internet. So that is, you agree with that?
Yes.
So this is, I was just talking to Dr. Saha before this session started. This is the only condition in neonatology or in ICU where you shun the warmer.
Yes, but then again, you have to stop the warmer once you have established airway breathing circulation.
Yeah.
Prior to that, temperature, resuscitation takes priority. So there are contraindications. If there is a PPHN, if there is a bleeding, if there is anemia, if there is severe, baby is pale and severely anemic, on the cord gas you see a hemoglobin less than 6, you shouldn't be going for bleeding.
So you have to stabilize the baby first and then go for
resuscitation
cooling.
takes priority always.
Yeah.
Because of resuscitation, temperature is a very important factor.
Yeah.
So unless you can maintain normothermia, baby, you cannot resuscitate.
Yeah, I agree. Thank you.
Thank you. Please. Yes, please. Sorry, can someone give him the mic, please?
So, thank you, Dr. Shah. Any
got
questions?
one question,
Can
but
we
I can
allow
take it
any
outside.
one or two questions?
Mother is sleeping in postpartum ward. Neonates is collapse. It is one of the cause of infant death.
Yes, it is SIDS, but if it is in a hospital, most of the times they will get resuscitated. If it's in the ward, if it's at home, they may die. But hospital, because you are under a medical supervision, you will get resuscitated. What I wanted to say was postnatal collapse is an indication for cooling. But the time starts from the collapse, not from the birth. So 6 hours following the collapse, you follow the same principles of criteria A, called gas, neurological examination, and if the baby is satisfied criteria A and B, you put the CFM on if you have facility, and then you make a decision for cooling.
Thank you.
Thanks.
Thank you, Dr. Shah. We are going through a very interesting session and may call it brainstorming too. So our next speaker in this interesting session is Dr. V. Jayakumar. He will speak about clinical clues, that is, diagnose them early, find them early, and think about them early. Don't miss them.
Good morning, everybody. At the outset, I would like to thank the organizers for having given me the wonderful opportunity to speak on this simple topic. I say it is simple. Bedside tests are useful. This is the transillumination test, which we have forgotten from our MBBS days, because if you say transillumination, you remember only hydrocele. And this transillumination is very useful in pediatrics also. You can just see if you place a bright torch on the parietal region, normally you get a rim of glow for about 1 centimeter beyond the circumference of the torch. But if you see something like this is not hydrocephalus. A child with a large head with this type of, brilliant transillumination is suggestive of a condition called hydranencephaly. You can also see that in this child, where the entire brain is liquefied. No amount of shunt is going to be useful in these children. And look at this child. This is a very interesting case. This 1.5-year child was treated for recurrent congestive cardiac failure. And the echocardiogram was found to be normal. And the diagnosis was, when everything is normal and the child has got failure, what is the diagnosis usually cardiologists make? Cardiomyopathy. But interestingly, what happened was, cardiologist did not auscultate over the skull, because his area of territory is only in the chest. But the neurologists, they are very clever, very pride of carrying the knee hammer. The house surgeon will carry a short knee hammer. The professor will carry a long queen square knee hammer. Size seemed to matter there. And, the neurologist did not carry the stethoscope. And that is why the whole thing failed. And sometimes you would have heard patients asking you to put the stent when there is a pain in the knee on that. They may be true. And that is what was not done in this child. And subsequently, the CT showed the obvious diagnosis, aneurysm of great vein of Galen, which has been totally missed. Simple thing. Large head with congestive cardiac failure. Remember that. This is a pride father and the very proud son standing, and the father is balancing the child happily on one hand. Unfortunately, this happiness did not last for a long period, and gradually child lost the developmental milestones, became bedridden. Can we hear the audio? You can just see the child has got large head and involuntary movements. Look at the involuntary movements. This combination of large head with involuntary movements should make you to think of one important condition which is treatable. You can just see how much of involuntary movements are there. CT was reported as cerebral atrophy by the radiologist. But you can obviously see there is a bitemporal arachnoid cyst, and if you look at the Sylvian cistern, that has got the typical bat wing appearance, and that is a classical CT picture of glutaric aciduria, and the child was treated with a high dose of riboflavin. Just see, within few months, the child who was totally bedridden started sitting and gradually started improving. So again, a simple clinical clue, large head with involuntary movement. Think of this possibility. And sometimes glutaric aciduria may present in a different way also. These two children have large head, and they were initially referred to neurosurgeon for some surgical intervention. And because one surgery was suggested, the parents were they choose other option, and they somehow or other came to me, and what is the diagnosis? Again, large head with the involuntary movements. One more finding which you see in glutaric aciduria is subdural hematoma. See, this can be easily mistaken for battered baby syndrome. And in fact, after having seen the subdural hematoma, neurosurgeon wanted to make it as a medico-legal case. And fortunately, once he said that the police is going to be informed and all, the parents absconded and landed with us. Look at this boy. Smile and laughter are supposed to be the best medicine, but at the same time, they give lot of clues. This child used to laugh suddenly for no reason and then stops after some time. He used to become normal in between. That is a classical presentation of gelastic seizures. When you see gelastic seizure, always try to exclude hypothalamic hamartoma, especially tuberossenareal hamartoma. You can just see that here, and you can just see the beautiful tuberossenareal hamartoma. Look at this boy. This boy is also getting repeated seizures. She is describing that he has been getting repeated seizures, sometimes vacant spell. Look at that boy, very happy. Whatever you say, he is very happy. He says he has got headache in a very happy mood. For everything he is happy. That's a very interesting case. When you see somebody who is very happy about everything, which you see very rarely, think about one condition, that is happy puppet syndrome, that is otherwise known as Angelman syndrome. Why should we know about this? Because this child was treated with the multiple anticonvulsants without much of benefit. And the drug of choice for Angelman syndrome is clobazam. Once we started him on clobazam, all his seizures subsided completely. That is the beauty. Again, I will come to smile. All of us know about the famous smile of Mona Lisa, but sometimes we get to certain other smiles also. This may be a romantic smile which we would have experienced once upon a time earlier in our life, and this is a smile which you get from your spouse whenever you introduce some beautiful girl to her, and I don't know how to interpret this smile. But there are other varieties of smile. Each type of smile has its own signature, and it all depends on the source from which it comes, and it also depends on the interpreter. But as pediatricians and neurologists, we should not fail to interpret this smile. Mind you, these children were not asked to smile. They were asked to I just asked their name. They just let out a smile. And this is called, doesn't convey anything at all. This is called vacant smile, vacuous smile, empty smile. And this is what we are very familiar with when we go as an examiner. When you ask some difficult question, when the candidate lets out a smile, you can easily experience this smile. This vacant smile is the very signature of one important condition, because by the time when they smile like this, if you miss the diagnosis, they may land up with the severe dystonic posturing, dystonic hand, dystonic deformity, and that is the classical case of Wilson's disease. So this is one more smile which we should never miss. And look at this boy. Again, his mother says, can you just increase the audio? The mother says that for anything and everything he is smiling. So when somebody smiles for no reason, just to take a torch and look at their eyes, you may get a calf ring. That's an important point to remember. This is the typical presentation of Wilson's disease, where you get the classical wing beating tremor, almost like a beating of the wing, very typical of wing beating. Wilson's disease. This child also had a calf ring. Once we started her on penicillamine, you can just see how nicely she has improved, and the tremor has. This is not a vacant smile. This is a meaningful smile of being relieved from the problem. And this boy was brought by his father for a very interesting complaint. On the day of examination, this boy started walking like this and refused to go to the school. So he thought that he was intentionally doing it. But just see, he falls down. Looks like almost acute Parkinson in a child, isn't it? Almost like he has got a mild tremor. So before the psychiatrist arrived, so I was asked to see this child, and when I saw that, you can just see a beautiful KF ring. And the CT was reported as normal, although there is some hypotenuse area in the basal ganglia. The MRI was very classical, and you can just see the typical appearance of the MRI of the brainstem, especially the superior collicular level, which is supposed to resemble the face of giant panda. And the neurologists stretch their imagination, and they try to identify, certain other things also. In the ponds, they have identified cub of panda. So the neurologists, the neuroradiologists don't seem to have any other work except identifying several things in the MRI. And probably, if you allow them, they may find out the entire family of the panda, daughter-in-law, grandchildren and all. They may be hiding somewhere. Probably in the next few years, we may get some interesting papers on this. And same boy, after we started him on penicillamine, you can just see how nicely he has improved. I have been following him for decades. Just see how nicely he walks. No tremors. He is able to run, climb, jump. He has become little older. He has become an auditor now. So he got married a few years before. Now he has got a child also. KF ring also will disappear in due course of time with the treatment. Of course, there are certain other rings which we should differentiate from KF ring, and I will not go into the details of that, but I would like you to just concentrate that in KF ring, there is no space between the limbus and the ring, because the deposition of copper occurs at the decimus membrane, and that is why you don't see any gap. And I would also like you to remember that in a hepatic, the copper gets deposited in Wilson's in a sequential manner, first in the liver, then in the RBC, then in cornea, and finally in the brain. So the moral is, whenever there is a neurological Wilson, KF ring will almost always be present, and in hepatic Wilson, you may not be able to see the KF ring. That's a point I would like you to remember. So, in summary, never miss an abnormal smile, never misinterpret a normal smile, and never misconstrue a smile from a miss, and otherwise you may miss that miss also. So, a smile has so much of meaning. And you just look at this child. This child was brought for recurrent seizures. Look at his scalp hair and compare with his father's scalp hair. You would have made the diagnosis by now. That's a very typical phenylketonuria, blonde hair. You can just see. At the bedside, you can do a very simple test. I would like you to just see this. You just take samples of urine and add few drops of freshly prepared 10% ferric chloride, and you can just see how the color changes. This can be done in any lab. You don't need anything at all. You can just see look at the color change here. It has become almost dark green in color. That's a very classical test for phenylketonuria, and you have the dietary therapy for that. Look at this child. This girl was can you increase the audio? This girl was brought for abnormal gait, and if you just listen to the way in which she walks, I will just show you that again. What is this gait? Stamping gait. You just hear the sound. What does that indicate? That indicates there is a foot drop. The child is not able to feel the ground properly. And look at this. This child came from US. Child was treated as cerebral palsy there. And look at this girl. Any diagnosis? Very, very typical case. Pardon me? I'm sorry, I'm not able to hear. Anyhow, this hair, curly hair, is very, very typical of one particular condition associated with the peripheral neuropathy. So I told the parents that it's a typical giant axonal neuropathy. They did not believe because they never had any trust on Indian doctors. They always believed in US only. So finally, I had a call from the US neurologist who was treating her, and he was surprised and so happy and excited and congratulated me for making the diagnosis clinically, because subsequently electron microscopy was done there, and that showed the typical giant axonal neuropathy. Again, a very simple clue. Hair, skin, so many things are giving. They are all waiting to give you clues. We have to pick up. And the biopsy also confirmed that as giant axonal neuropathy. This is another boy, a male child who was presented with developmental retardation and occasional seizures. What could be the diagnosis? Very classical. Coarse, sparse hair. Yeah, coarse, sparse hair. And X-ray showed typical picture of scurvy. That's very interesting. This combination is very characteristic of Menkes kinky hair, and we see quite a lot of them. You can just see the another child with the sparse hair, and this is typical twisted hair you can see. And it's very interesting to know that if you look at the MRI, the vessels also are, twisted. You get lot of twisted vessels, multiple vessels will be seen, and you can just see they are very tortuous. That's a very typical picture of Menkes kinky hair disease. And unfortunately, these things I had seen about 40 years before. I did not report. That's what I was appreciating Lokesh. And so whatever you see, you publish first. Then you examine the patient later. That's very important. And it's very interesting to know that the treatment option of copper histidinate came from veterinary surgeon. See, veterinary surgeons, they observed that the sheep which are deficient of copper had hair changes which are exactly identical to Menkes kinky hair disease. So they were treating them with copper histidinate. Subsequently, and the same medicine is being tried for human beings also, and they have found out some successful results with that. Look at this child. This child, watch this child. You can just see the sudden spasm, epileptic spasm. When any child with infantile spasms or epileptic spasms, always look at the skin for what? Specifically leafy macule, because tuberous sclerosis has got a very high association with, infantile spasms. But sometimes we may not be able to make it up, even though the suspicion is strong. There you can use what? So-called Wood's lamp. How many of you have seen Wood's lamp? How big it is? I tell you, we have found out a very simple method to make a diagnosis. I'll just show you a video of that. Watch this video. This child did not have any macule at all clinically. Just see that. See, like a magic it appears. You can just see that. No, with this light you are able to make it up. And what is this light? This is a simple ultraviolet light which is available at a very low price in Amazon, and we found out that this is very useful screening tool for tuberous sclerosis in patients with infantile spasm. And this child had a classical features of tuberous sclerosis with the typical intracardiac phacoma and classical CT and MRI signs, and we published this in Indian Academy of Neurology journal sometime earlier, because now only I started realizing that just observation is not enough, you will have to publish. So, and I started stimulating my son, who is also a neurologist and epileptologist. He was very keen to publish this, and he published it. And so this is a very simple thing at the bedside. And of course, you can see all the other varieties of manifestations of tuberous sclerosis. You just see the typical classical leaf-shaped leafy macule and retinal phacoma, subungual fibroma. Sometimes you get clues from the parents or the siblings. The child may not have any future, but the parents may have the typical adenoma sebaceum. So always look at the parents whenever you have a high suspicion of tuberous sclerosis. Watch this sign. What does this child do? Oculomotor apraxia. The child is not following the object with the eyes, instead follows it with the head. And look at his face. there is a mid-facial hypoplasia. These two classically constitute the typical syndrome of Joubert syndrome, where you get a molar tooth appearance of the midbrain and you see the bullet-shaped fourth ventricle. This child, again, see, terribly ataxic. He was normal earlier. Now again oculomotor apraxia. When you ask him to look up and look down, he is not doing that. He is just instead moving his head up and down, side to side. And sometimes oculomotor apraxia may be the earliest sign before the conjunctival telangiectasia appear. That is the point to remember in ataxia telangiectasia. You can also see the typical telangiectasia in the ear. Look at this boy. Again, oculomotor apraxia. Can we have the audio? Again oculomotor apraxia, but here reduce the volume bit. Now what is the diagnosis? Huge hepatosplenomegaly with oculomotor apraxia is very characteristic of Gaucher's disease. Again, now the treatment is available. Again, we have to concentrate on the back, whether it is beautiful or otherwise. We have to just look at the back in every child who comes with abnormal gait. This is very vital, and watch this child. This child was referred to me as spastic CP for Botox injection by a pediatrician and also by an adult neurologist who had seen this child. But unfortunately, nobody unstripped the child. Now you have the clue. That's a very classical tuft of hair in the back, and we did a MRI that showed the typical diastematomyelia, and the child was operated, became all right after that. So never forget to look at the back. Remember, even if you don't remember this video, remember the cartoon picture there, which I hope you will not forget. And sometimes I used to say that instead of falling at the feet of the examiner at the exam time to get a pass, it's better to fall at the feet of the patient to get a diagnosis. And this child was kept in our DM exam for ataxia, deafness, and no doubt the child has got, you can observe the bilateral congenital cataract in her. What else will you do? Fall at the feet of the patient. The patient was not able, the student was not able to make a diagnosis. So in fact, I gave a clue. So don't look at me. Why don't you fall at the feet of the patient? He did not get the clue at all, even though I gave the frank clue. And the diagnosis is obvious. That's a typical cerebrotendinous xanthomatosis. Nothing else is required. Sometimes even if they wear a shoe, just ask them to remove the shoe and look at it. Never forget about this. This is a very interesting case. This child happened to be a child of one famous politician in Madurai, and he was seen at several places for a very interesting complaint. The complaint is, whenever the mother used to offer head bath, after vigorous toweling, the child used to become flail and collapse, and he used to remain in that state for about 3 to 4 days, and then subsequently used to recover. So the child was initially seen by pediatrician, and he was able to make a diagnosis of Down syndrome, and because he was somebody in that pediatrician group heard my talk on hot water bath epilepsy. So he thought that because after bath only he used to have this, so he thought it was hot water bath epilepsy, and the child was put on anticonvulsant and all, nothing happened. And subsequently the child was seen by neurosurgeon who had done extensive investigation of MRI brain, MRI of the spine, and finally he came to a conclusion that it's a classical case of cryptic AVM in the brainstem. It was so small that it could not be found out in the MRI. So he referred him to take the child to US for good surgery, and so this man entered to my consultation room with a big suitcase. We have only gone with the suitcase to the politician. That was the first time that politician was coming with the suitcase. So I was a bit afraid of seeing that. And I asked him, sir, you examine my child. I have seen best doctors in Tamil Nadu. I have gone to Chennai. I have even seen doctors in Apollo Hospital. And then I have come here, and then I told him, I need to have one in. Sir, don't ask for any investigation. This suitcase contains all investigations you want. You have any MRI? See, they have taken MRI of me also. I don't know why. That is also there. You can just see, we have seen the whole body MRI. The whole family MRI was taken. So I didn't know what was going on. Then I just told him, don't worry, we'll just take only one X-ray. X-ray? Sir, MRI has been done. It doesn't matter, we'll just have one X-ray. So the X-ray was taken, and just see the gap between the atlas and axis, such a wide one. So what was really happening was, after the head bath, mother was flexing the child's head and then started vigorously toweling. And that started giving compression to the spinal cord, and he developed the typical what is known as transitory attack. The transitory attack is very characteristic. I don't know how many of you have read the beautiful article by late Professor N.H. Wadia on Atlant axis subluxation. This is what he used to mention very clearly, this transitory attack. So subsequently I asked the parents to just ask the child to wear only a cervical collar, and thereafter there was no recurrence at all. Unfortunately, in the subsequent election, that politician defeated, so I was also not benefited in any way. That's a different matter. Watch this child. This child was brought to me, he was referred by a pediatrician to me for an interesting symptom. After repeated bouts of vomiting and fever, child became drowsy and started having, drowsy look, and then altered behavior, and then involuntary movements. So the pediatrician felt it was a case of encephalitis, and so whenever they feel that they are not able to treat, they just simply refer the child to a neurologist for so-called terminal care. And what happened was, he just told me, sir, I have a patient with encephalitis. Sir, surprisingly, CT is normal, sir. See, when something is normal, only neurologists are getting referrals nowadays. So, what happened was, you just look at this child. Watch this child. Some of the older people here, I don't know whether anybody is here who have read the textbook of pathology by Boyd. Just see. You can just see, boy has got ophthalmoplegia, involuntary movements, mild alteration of sensorium, classical triad, which you see commonly in what? Wernicke's encephalopathy in alcoholic. So I just told the pediatrician, don't worry, he will survive. But mind you, those days we did not have this methylcobalamin and all. We had one injection called Berin. That was also stopped after some time because of certain anaphylactic reaction. So we had to give the preparation of, highest containing B1, B complex injection. So what I did was, I just told the parents as well as the pediatrician that this boy requires MRI. Then he was not very comfortable. Then I told him, we will just have a free MRI done. Then immediately accepted. Anything that is free, people love it. So, and that is what was done. You see, no doubt the CT is normal. You can just see the MRI showing a very classical features of Wernicke's encephalopathy, periaqueductal gray lesion, mammillary body lesion. Few days later, you can just see. Trust me, this is not a storehouse or a godown. This is my consultation room. Sometimes it used to be much worse than this. And just bear with me. And you can just see how nicely this boy has improved. All the features improved very well. Again, simple clinical thinking. This combination is very characteristic, very, very characteristic. In textbook of Boyd, pathology by Boyd, can just see if there is a lesion in amygdala, basal ganglia, and in periaqueductal gray, the diagnosis is 100% certain. And all these lesions obviously correlate exactly with the clinical findings. You can just see how these mammillary body lesions have disappeared after treatment, and you can just see. Was this child? This is another child who was brought to me with the diagnosis of epileptic encephalopathy. No doubt that the child was having altered sensory. Can I just take a few more minutes? Because we are almost nearing completion now. You can just see the child started losing hair, scalp hair, and then I just asked the father whether the child has got any skin lesion. Immediately he got excited. Sir, there is a lesion here, sir. Then I also got immediately excited. Why? Because the diagnosis is very obvious. Mind you, in those days, to get the diagnosis confirmed, we were finding it very difficult. We had to send the blood sample to Mayo Clinic, which was costing nearly about 2 lakhs those days. And we did not have biotin freely available those days also. So at that time, and after having seen this, I just contacted, who discovered biotinase deficiency? Professor Barry Wolf. So I contacted him through email, and then I just wanted to see his case report, and he was very happy to send his case report. Just see that. This is the case report. Of course, this child and his case, they all resemble each other exactly. Of course, in Tirupati, everybody will resemble each other. That is different. But, the same way, this is Professor Barry Wolf, and he has written a beautiful book, and I wish everyone should read this book about how he has found out this biotinase deficiency, and with simple treatment of biotin supplementation, you can just see how nicely the child has improved, and all skin lesion also completely disappeared, and you just see the child is growing hair in a very proud manner. You look at the amount of growth of hair. Now Professor Kadilkar has come, and I don't want to go into his territory. I'll just show you one important, finding when any neuromuscular case comes, especially when they suspect myasthenia. This is a very simple sign. Ask him to look down and look up. Just see a sudden flickering of eyelid. That is Kogan's eyeliditis sign, which is very, very useful at the bedside, and quite useful. And watch this child. This child was treated with the prostaglandin without much of benefit for the diagnosis of myasthenia. But just see that. You cannot have an age-matched control study like this. Exact twin. Just see. Give a crispy snack. That the whole thing disappears. So-called myasthenia treated with crispy snack. This is not myasthenia at all. That's a typical Marcus gun phenomenon. You can just see how nicely the child is showing the movement. This girl was referred as Duchenne muscular dystrophy in a female with the diagnosis of that. But every child with the muscle hypertrophy, never forget to tap the muscle. If you tap the muscle, otherwise you will miss the myotonia. So you can just see the classical myotonic features in this child. And I still remember late Professor Anil Desai from Bombay, he used to fail candidates if they don't put the strength on the muscle in a neuromuscular case. That times we used to, wonder why he was so particular. Now that with the neuromuscular ultrasound, you see, you can do wonders. I have become a great fan of neuromuscular ultrasound. The last few years I have been almost daily doing it, and I am learning a lot. When at the age of 72 I am able to do that, why not all of you? It's very simple technique. And you can just see in this child the very classical die bomber sound, very typical of myotonic discharge. And this is an interesting case. This child was admitted in the tetanus ward as tetanus. So when everybody else in the tetanus ward was almost bedridden with spasm, this boy alone used to go run and used to help the staff nurse. So the staff nurse said to the house surgeon, I don't know why these people have made this boy as a tetanus case. You just see this boy is running and all. Staff nurse was correct, but unfortunately the assistant professor who admitted the child in tetanus not correct. And you can just see, one day the boy complained of some dysuria, so the assistant professor asked the house surgeon to get the urologist opinion. Unfortunately, house surgeon mistook that for neurologist, and that is how I went there. When I just saw this, immediately I was excited, because this is a very classical Schwartz-Jampel syndrome, where you get a blepharophimosis, joint contractions, and myotonia. We just transferred the patient to our neurology ward. Interestingly, the same house surgeon who was working in the tetanus ward subsequently got posted to neurology ward also. And he said, see, what is this? So one day they make a diagnosis of tetanus, the other day they make a diagnosis of something else. If the child gets transferred to cardiology, I think they will make some other diagnosis also. He got frustrated with this case. And this boy was referred as a case of cerebral palsy, but he was having a progressive weakness. That's very important. But look at his limbs. They are so thin. He has got, no doubt, he has got severe weakness. But look at the limbs. Limbs are disproportionately thin. And as usual, the MRI was done first. The MRI brain was done. And interestingly, for reasons known to the radiologist only, he had done MR spectroscopy and reported as normal. And that MR spectroscopy was very interesting. I will just show you that. This is the patient's MR spectroscopy. Look at the creatine peak. Normally creatine peak should be like this. Now here it is totally absent. That excited me. So I just wanted to have the genetic test done, and genetic test confirmed that it is a cerebral creatine deficiency, and we treated the child with the creatine monohydrate. Just see how nicely he has been improving. He has started running now. The so-called myopathy or the so-called cerebral palsy completely improved. Now, this is a very interesting case. This child happened to be a child of one of our postgraduate students. One day, he brought his child with a sad face. Sir, my child seems to have cerebral palsy, which I have not diagnosed so far because I was very busy with preparing for this DM and all. Initially, I thought I should leave DM and then look after only my child. But somehow or other, I have come halfway between. I don't have any other option. And please look at this child, my son, and just see what can be done. This is the diagnosis. I was shocked because he had been seeing the child daily. His eyes failed to recognize that classical condition. And you just see the diagnosis written on the face. You don't need any test at all for diagnosis. And I put the child on, of course we confirmed it, and we put the child on thyroid supplementation. You can just see how nicely he improves. Just see. And this boy has become an ENT surgeon now. That is why I just showed you. Initially, don't take any videos and all. And despite that, I have seen few people taking it up. But anyhow, I hope they don't reach anywhere else. And now you will understand the difference between nearly right and exactly right makes lot of sense. And that is why I always believe that the God has given the human being the best computer that is possible, our own brain and nervous system. So I feel strongly that unless we exhaust our clinical knowledge, there is no point in going for man-made computers like CT, MRI and so-called artificial intelligence. Human intelligence is still the best, and that is the main conclusion I would like to thank you so much.
Thank you, Dr. Jayakumar. You have only proved that clinical medicine is alive and kicking. So before ordering any investigation, just think about the diagnosis. And so we didn't mind you taking some extra time because everybody was enjoying and everybody seems to have been enriched by your enormous observation and very strong so-called clinical eye. Thank you. Anybody, anything from anybody? So can we declare that this session has ended now?
Thank you, sir, and our wonderful chairpersons for chairing the first session. I would request our faculties, chairpersons, and speakers to kindly collect their mementos from the memento corner outside. Our next session is on pediatric epilepsy and demyelinating disorders. I would invite on stage our moderator, cum chairperson, Dr. Amit Haldar, senior neonatologist and epileptologist, Fortis, Kolkata. Our other chairpersons are Dr. Gautam Guha, Associate Professor Neurology, Burdwan Medical College, Dr. Pranab Kumar Datto, Consultant Pediatrician, and Dr. Shapon Mukherjee. I request Dr. Amit Haldar, Dr. Gautam Guha, Dr. Pranab Kumar Datto, and Dr. Shapon Mukherjee to kindly grace the stage.
Good morning, everyone. So, after this interesting case-based sessions by Dr. Jayakumar, we have the next session. This is on demyelinating disorders and pediatric epilepsy. Now, at the outset, I will invite Dr. Lokesh Lingappa to talk on pediatric MS and aquaporin 4 and NMOSD. Dr. have his introduction, please.
Thank you. Thank you, everyone. I think after Professor Jayakumar's talk, every talk until next afternoon will be very pale. So at least let us have one or two learning points as to next. Yeah. So pediatric MS and neuromyelitis optica spectrum disorders are very rare as compared to what is the most common demyelinating disorder in children? ADM and MOG-related demyelinating disorder. They are much more common than the NMOSD and pediatric multiple sclerosis, because thankfully they are rare, because they have more devastating consequences as compared to your NMOSD. So what are the different presentations, quick epidemiology, what are the markers for diagnosis and acute management and long-term options we'll go through with few case examples. This is a 8-month-old girl who presented with recurrent neurological events from the age of 4 years, and there are no adverse perinatal history. She presented in 22 with walking difficulties and recurrent falls of over 15 days, along with retention of urine, looking at a spinal cord pathology, and there are no cerebral complaints. So it is a diagnosis of acute transverse myelitis. You can see there is a long segment cord which is involved from the cervical, predominantly the cervical. It's a long segment involved. More than 2 segments if it is involved, it's a long segment. Whole of the cord is involved. So you need to look at length of the segment and also whether it's a partial cord or a complete cord involvement. There is also a lesion in the white matter in the brain as well. This was not symptomatic. So the child was only symptomatic for the spinal cord presentation. And the CSF showed 17 cells. There was some inflammation which was going on, and the serum NMO was strongly positive. So once you have NMO positive, you will have to have very high aggressive immunomodulation. IV, MP and IVIG both were given at that time, and maintenance therapy of mycophenolate mofetil was also started. So they can also have this kind of, if you can see this optic nerves, hyperintense. They are hyperintense and thinned out, and they also have a long segment, and they involve until the optic chiasma. So it is a different child who has this significant optic nerve involvement. So optic nerve bilateral and involvement of the chiasma is more in favor of neuromyelitis optica spectrum as compared to the MOG-related disorders, where they have more ventral involvement, and they are also bilateral but more ventral involvement, and perineural sheath enhancement is more common in the MOG. So what are the diagnostic criteria? Because a lot of these children, not all of them will have the antibody positivity. So there you have to have some diagnostic criteria. The prevalence, thankfully, is not very common in pediatric age group. In children, it's around 0.06 to 0.22 per lakh population. And there is a various racial differences exist. In East Asians, it is around 3.5 per lakh, but slightly more common in the blacks. So the International Panel for NMOSD in 2023 has updated this thing. So what are the criteria? You should have optic neuritis, which is predominantly bilateral, or you can have myelitis, or area postrema syndrome, that is around the fourth ventricle when you have the lesions. So the children become very rigid, they have myoclonus. So those are the manifestations which can be part of the neuromyelitis optica spectrum disorder or acute brainstem syndrome. They can have rarely symptomatic narcolepsy as well, and also the symptomatic cerebral syndromes which can be typical of NMOSD. All these things can be there. So once you have this clinical pattern, you have a aquaporin IgG positive, then it is easy to diagnose. So it is a one core clinical feature. You have optic neuritis with NMOSD positivity, and you have excluded alternative diagnosis. Your treatment principles is according to the neuromyelitic spectrum disorder. And you can have similar manifestation, but aquaporin antibodies might be negative. That is where you have clinical dilemma as to how to treat them. So there, to diagnose, you have at least two core clinical features should be there. One core clinical criteria, that is in the form of optic neuritis, long segment transverse myelitis, or a acute area postrema syndrome. One of these things should be there. There should be dissemination in space, that you have a spinal cord pathology, but you can have a asymptomatic or symptomatic brain lesion as well, or on the optic neuritis. So dissemination in space is there, and you'll have to exclude other diagnoses. We'll come to what are the diagnoses we should exclude in children. So pediatric onset neuromyelitis optica spectrum disorder, as compared to if you have 100 diagnoses of NMOSD, only 3 to 5% of them will be children. Thankfully, it is rare in pediatric age group, and usually it is more common towards adolescence. So 10 to 14 years is more common onset, and it is around 4:1 female is to male. It's more common in girls. And the common presentations is bilateral optic neuritis in almost half of them, acute myelitis, and cerebral presentation is only 30%. Endocrinopathies can also be seen in these children. But do you need to be aware of any of the mimics? Yes, in pediatric age group, what are the common mimics we need to rule out in neuromyelitis optica spectrum disorder? What is it was also called as Devick's disease earlier. It was earlier terminology before we got to know of this. So there are a lot of conditions, can be MOGAD you should differentiate, ADEM you need to differentiate, but they are easy based on the radiology and also the antibodies. Rarely SLE can be a varied manifestation, but I will not go through these details. So in children, it's more often the viral myelitis and IEMs. Vitamin B12 deficiency can have optic nerve involvement, can have spinal cord involvement. So that is one thing we should not miss. Biotinidase deficiency can have opticospinal presentation. When they have early age presentation, you have skin manifestation, cerebral manifestation, hypomyelination, all those things. But when they have a later onset manifestation, they can typically behave like a opticospinal form of NMOSD. So that's why if the things are not clear, especially in consanguineous families, make sure not missing out on biotinidase deficiency. So we had a family of 4 children affected coming from Africa, all of them having progressive spastic paraplegia. And on the genetic examination, we diagnosed biotinidase deficiency and had to be treated. Vitamin E deficiency can also cause a similar presentation. Close mimics once again can be viral myelitis, secondary to influenza, enterovirus, H1N1, spinal cord infarctions. So these are all close differential diagnosis of NMO spectrum disorders, which you need to be differentiating, especially when the antibodies are negative. So how are you going to manage? Once you have diagnosed, you have ruled out your differential diagnosis of NMO spectrum disorder, what are the acute treatment? Acute treatment, most of them, as a standard, you have 5 days of IV methylprednisolone, and then plasma exchange or IVIG. Plasma exchange can be difficult in some certain centers, so you might have to at least do a IVIG, followed by oral glucocorticoid steroid treatment, along with you can use longer term management, will come to later. So whether IVIG versus total plasma exchange, IVIG is obviously much easier to administer, total plasma exchange is going to be challenging. But sometimes if they have very severe visual loss, very severe spinal cord involvement, they suggest to do the total plasma exchange, but better efficacy. So consider TPE whenever is possible in NMO spectrum disorder over IVIG because of better efficacy and quickness of the action. So in this child, later on there is leukopenia with MMF. She had a second event in May 2023 with dysarthria, choking episodes, irritable crying episodes, and mild cerebellar ataxia. Once again, acute treatment was done. You can see now there is a significant increase in the cerebral lesions. Earlier it was spinal cord, the cerebral lesion was very minimal. Now there is a florid cerebral lesions which is manifesting, and some spinal cord residual lesion is there still. So the patterns in the pediatric age group NMOSD can involve the optic nerves, as we discussed earlier. You can see the enhancement of the proximal part of the optic nerve, and you have area posterior involvement here. You can see the hyperintensities, cervical cord, long segment involvement. You can have blotchy, diffuse blotchy lesions as well in this age group. So this child continued to have antibody positivity, MOG is negative, and ANA profile was also negative. So here the rituximab infusion was started. So because there is a second relapse while on mycophenolate meflotil maintenance as well. So you'll have to continue to give every 6 months until you keep doing the CD19 counts and continue to give that infusions. So long-term treatment, what are the various medications that have been used? So they can be the common ones, what we use because of the availability and the cost effectiveness is rituximab. Other things are not easily available, and then the second choice would be azathioprine, mycophenolate or tocilizumab. So depending on what you have used, if you have used rituximab first and you have failed, then you can try the tocilizumab. So that is what the usual course in this. And in adult practice, they keep using it quite regularly. Currently, the treatment of care is you should continue immunomodulation for life in NMO spectrum disorder, because the disability is quite significant in this group of children. Even in double seronegative NMOSD spectrum disorder also, similar principles are followed. So maintenance therapies, so lifelong immunotherapy is currently recommended. So that is very important for us, that you cannot drop your guard in these children, that okay, this acute event is controlled, then okay, I'll reduce my immunomodulation. You need to continue to give a very high dosage of immunomodulation. So you can choose what medications you are going to give, either azathioprine, MMF or some other tocilizumab on a regular basis. So various monitorings that needs to be done because of the long-term effects. So what are the long-term this one? Permanent disability is seen in up to 58% of these children. That is very high for a demyelinating disorder, because the MOG-related diseases, the disability, long-term disability is probably around 10%, 15% long-term disability, even in recurrent attacks, whereas here it is around 60%. And 20% there is an increasing disability. Even after single attack as well, they can have 20% long-term disability. Visual disability is seen up to 35 to 40%, and motor disability is up to 50%, and cognitive impairment as well. So it's in general of the most of the pediatric demyelinating disorder, NMOSD has a significantly poor long-term outcome despite multiple medications, but you need to be very aggressive in your treatment to give what are the best possible outcomes. Next, I'll go to the pediatric onset multiple sclerosis. Once again, thankfully, the incidence is less in pediatric age group. It's only 2 to 10% of individuals with MS. In NMOSD, it's around 3 to 5% of adult NMOSD. Pediatric onset MS, once again, 2 to 10% of individuals with overall MS. The global incidence is around 0.85 per lakh individuals. and prevalence is around 8.11 per lakh individuals in the pediatric age group. So I'm not going too much into the POMS, that is the pediatric onset multiple sclerosis, because most of them, they have a single episode, that is a clinically isolated syndrome. So that is what we are going to deal most often as pediatricians or pediatric neurologists. So what is a clinical attack of clinical isolated syndrome? You have a monofocal, that is optic neuritis. Just one eye, there is a visual impairment and pain on moving, and then there is no preceding fever, no infection, no encephalopathy. You start looking at whether it is multiple sclerosis. This is a 14-year-old adolescent girl coming with unilateral optic neuritis. Your diagnosis is clinically isolated syndrome. They can have spinal cord, patchy spinal cord involvement. So that is once again a symptom of multiple sclerosis. The child will just present with tingling. They will present with numbness of one arm. So that is all the symptom, initial manifestation might be, especially when it comes in adolescent with just patchy tingling numbness, not much of weakness. So you are looking at a patchy spinal cord involvement. That will bring me to a suspicion of whether it is a first episode of multiple sclerosis. So clinically isolated syndrome may be the first manifestation of multiple sclerosis. Thankfully, not all of them might have a relapse. That is why we need to be very critical of diagnosing the clinically isolated syndrome. And this episode should last at least for 24 hours and should occur in absence of fever, absence of infection, and absence of encephalopathy. Then you call it as clinically isolated syndrome. So you have optic neuritis unilateral or a spinal cord patchy involvement, urinary urgency, or mild walking difficulties, ataxias, then you are looking at clinically isolated syndrome. So that is your symptom based. So when you do an MRI, you can have patchy white matter changes. You can see this vertically oriented white matter lesion. So this is something very classically what you see in the multiple sclerosis. This is in a child who had the clinically isolated syndrome. And you can have this spinal cord involvement. You can see it's very patchy. It is not, and a very short segment as compared to the lesion, which was a long segment lesion in the NMOSD what we saw. You can see this very patchy involvement of the spinal cord. So this child had just a tingling sensation in the hand. So that is how the MRI will look in a multiple sclerosis as compared to large long segment lesions, transcord lesions in the NMOSD or MOG. You can have a patchy contrast enhancement. You can see these ovoid lesions here in the periventricular lesions. These are all very classical manifestations of demyelination associated with your multiple sclerosis or clinically isolated syndrome. What investigations are you going to do? I have not written anything here. It is for the audience to tell me what investigations you want to do in this girl who had presented with tingling numbness and that MRI where there is a patchy signal changes. What are the investigations? CSF oligoclonal bands, very good, yes. And also look for any viruses. If there are significant pleocytosis, make sure you have a sample enough to do for viral panel as well. Other testings? Not EMG, your VEPs, SSCPs. If the child presents with numbness, you have a VEP which is abnormal, then you know that it is two different areas are involved. So there is a dissemination in space. Okay, so that is indicating that it is more and more likely to be a multiple sclerosis, evolving towards multiple sclerosis. What else? So your vitamin D levels. So low vitamin D levels are high risk for pediatric onset multiple sclerosis. Okay, your EBV serology. So EBV serology is almost 100% of these children with pediatric MS have EBV serology positive. So that is something as will be a clue. If you have a clinically isolated syndrome, you have done this, then you are going to be able to say to the family that this is very likely going to progress into pediatric onset multiple sclerosis later. So these are the things we don't think of as to associations. Apart from your standard neurological investigations, you should think of these things as well. So this child had a relapse after 10 months, initially treated with steroids, improved and was stable. Then after 10 months with tingling and numbness of right hand, and then Earlier it was left hand, now it is right hand. You can see this periventricular patchy lesions, but you will not know whether it's an active lesion or an inactive lesion. So when you give a contrast, there is a clear contrast enhancement which you can see here in the periventricular region. That means the lesion is active lesion. So it is an active disease now. So here we need to think of definitely disease modifying agents for a longer term, because she already had a second episode of this one after the clinically isolated syndrome. Now there is a dissemination in time. Earlier there was dissemination in space. Now you have dissemination in time. So it is fulfilling the McDonald's criteria for pediatric onset MS. So there are various things, studies which have shown as to whether what is the risk of progression. One of the most important for most of the pediatricians, the thing is when they have a clinical isolated syndrome, the parents want to know what is the risk of progression to MS. What are the risk factors which will tell me there is a higher risk of progression? So that is something we need to look at. So on the mean follow-up of up to around 1.28 to 1.31 years, almost 30% had progressed to pediatric onset MS after a clinically isolated syndrome. So that is on an average. And then oligoclonal band positivity increased the odds ratio by around 7 times. If a strong clinically isolated event, your oligoclonal bands are positive. 7 times increased risk of progression to pediatric onset multiple sclerosis. And the follow-up data in adults after the clinical isolated event, they showed there are a lot of medications which reduce the recurrence risk. Cladribine has been something which has been used quite frequently. There are other drugs as well, gliatramerestate, interferon beta-1b, beta-1a and other things, but cladribine has been promoted as one of the most beneficial agent. But for the pediatric clinically isolated event, in 770 patients, a retrospective analysis, what are the things when follow-up of 10 years which increases the risk of recurrences? So if there is an isolated spinal cord or optic neuritic attacks in comparison to those with initial supratentorial brainstem syndrome, the risk of recurrence is slightly higher. So if you have isolated spinal cord or optic neuritis involvement. So here, if you have these kind of presentations, early disease modifying treatment exposure prevented the second attack and reduces the worsening disability. So you need to have what are the poor prognostic factors, what are the high risk of the recurrences. Good prognosis, if you have unilateral optic neuritis, isolated sensory symptoms like you had a tingling and numbness rather than a motor weakness. Long interval to second relapse. So you have had at 10 years first episode and then at 16 years there is a second episode. That is also a good prognostic factor. No disability after 5 years after the clinically isolated event. That is also a good prognostic factor. Normal interval MRI is a good prognosis because these children require a surveillance MRI. Even though they might be asymptomatic, you need to do a surveillance MRI. And poor prognosis if you have a multifocal clinically isolated syndrome, spinal cord and brain together, or efferent system affected, that is like motor weakness, bladder abnormalities, then your risk of long-term disability is high. And high relapse rate in first 2 to 5 years, you had already 3 episodes of optic neuritis, 1 episode of spinal cord involvement, their disability is significantly high. So what are the high risk factors? Multiple baseline lesions, odds ratio is 3 times higher risk. Positive oligoclonal bands, 5 to 6 times higher risk, and subclinical evoked potential abnormalities. That is, this child presented with a spinal cord pathology. You did a VEP, VEP showed abnormality, which means that is a subclinical evoked potential abnormalities. Their odds ratio is 14 times higher risk of progression to pediatric onset MS. And presence of asymptomatic gadolinium enhancing lesions is also a high risk factor. So these are the various things. I will not go into too much of details of this. I think the same, we have talked about these things, what are the typically clinical features seen typically in MS. But as a pediatrician, one of the important thing what we are going to look at is, go through this medications. Okay. So just, okay. So these are the things we should be aware. As a pediatrician, we can change. Pediatric onset, are there preventable factors? Can we prevent certain aspects? Breastfeeding. Breastfeeding reduces the odds ratio of developing MS by 4.4 times. So that is something we should advocate to all families. EBV exposure, it is a potentially modifiable unless you have a vaccine. Vitamin D, definitely, there is a almost 0.72 times odds risk of developing this one. Sun exposure, once again, reduced risk of developing the multiple sclerosis. You are obese, higher risk of developing multiple sclerosis. Passive smoking, higher risk of developing this one. So as a pediatrician, I think you can interfere by promoting breastfeeding. Mother taking milk, 2 to 3 glasses during the pregnancy also reduces the risk. So it has an intrauterine exposure to good amount of calcium and good vitamin D levels reduces the risk of multiple sclerosis. I think as pediatricians, all of us can attempt to promote this and reduce the risk of development of multiple sclerosis. Thank you.
We received a very detailed discussion on pediatric multiple sclerosis and neuromyelitis optica, and any question may be asked somehow later. And the next session is navigating drug-resistant epilepsy, medical alternative. The moderator, Dr. Jain Goswami, Dr. Amit Allar will moderate. And the panelists are Dr. Devopriya Rai, Dr. Durga Datta Patnaik, Dr. Chandan Rai Barman is probably absent, Dr. Jivan Silwal, and Dr. Indrasis Rai Chaudhuri. Suparna, Dr. Aparajita Chatterjee, instead of Chandan Rai Barman. Dr. Aparajita.
We will now have our panel to be moderated by Dr. Amit Haldar, sir. Our panelists are Dr. Devopriya Roy, Dr. Durga Datta Patnaik, Dr. Aparajita Chatterjee, Dr. Jivan Silwal, and Dr. Indrashish Rai Chaudhuri.
Yes. Good morning, everyone. Now the session from multiple sclerosis, we are moving to epilepsy. And this panel discussion is mainly on drug-resistant epilepsy. And we will review what are the medical alternatives. So for panel discussion, I'll ask certain questions and then we'll also, So first thing I will ask to Dr. Devopriya, you want to say, how do you define drug-resistant epilepsy?
Thank you for the question, sir. As per ILA 2010 report, drug-resistant epilepsy has been defined as the failure of adequate trial of 2 appropriate and well-tolerated anti-seizure medications. Appropriate means appropriate to the epileptic syndrome which we are dealing with, or with the semiology of the seizures, or with the cause. The anti-epileptic medications, they can be given as a sequential monotherapy or polypharmacy. And if they fail to maintain a sustained seizure freedom, then we call it to be a drug-resistant epilepsy. Sustained seizure freedom means it should be either 12 months or more than 3 times the pre-treatment inter-seizure interval, whichever is longer.
Longest inter-seizure.
Yes, sir. Yeah. Whichever is longer among them, that should be considered.
Yes. So, you have a patient with epilepsy. I'll just, what is this? Yeah, it's not clear. So, for example, in this patient, this is a 16-year-old boy who is having epilepsy for the last 3-4 years, and he has got epigastric aura, and at times followed by complex partial seizure. In spite of being on adequate doses of 2 anticonvulsants, he continues to have 2 seizures per month. And if you look at the MRI of this, you can see there is a temporal cortical dysplasia on the right side. This is in the coronal section. So in this case, how long? Will you wait for 1 year or will you refer early?
So this drug-resistant epilepsy, this definition, it stands at the point of assessment. A drug-resistant epilepsy in the time course, it might become drug-responsive, and the vice versa is also true. If we come to the case, we have a 16-year-old boy who is having seizures with epigastric aura, and here we see that the lesion is in the right temporal regions, involving the superior temporal gyrus. So, sir, the semiology is matching with the lesion. We have 2 drugs and 2 anticonvulsant medications, which I think has been given appropriate. I think one broad spectrum and one drug like oxcarbazepine or something, which is working on the local focal epilepsy. In spite of that, the child is having 3 to 4 seizures per month. There is no sustained seizure freedom. And here we are seeing a definite circumscribed lesion. So here we will not wait and we will refer the child for pre-surgical evaluation and further epilepsy surgery, lesionectomy.
Yes, because if there is a clear-cut lesion, which is, you can explain the seizure semiology, then we may not wait for 1 year. So 2 appropriate drugs, if in some cases they are saying that even 1 drug in adequate dose, you might try another drug, but in such cases it's always better to refer the patients for epilepsy surgery early, because waiting for another year, the later you operate, the more resistant the seizure becomes. Yeah, so to the next question. Now, all patients of drug-resistant epilepsy, they may not have true drug resistance. So my question is to Dr. Patnaik. So in what cases do you consider it to be pseudo-resistant? Or what are the factors that you take into account?
Thank you, sir. Good morning, everyone. As sir has asked, what is about pseudo-resistance? So persistence of that epilepsy, despite taking appropriately chosen or appropriately dose anti-seizure medications, either it is a failure of our correction of the diagnosis or failure of the finding of true potentially reversible causes for the epilepsy. So nearly 20 to 30% of the cases that have been diagnosed with drug-resistant epilepsy are actually having pseudo-resistance.
Yes. So basically what we do in clinical practice is remember 3 Ds. You may have wrong diagnosis, or you may have wrong drugs, or you may be using in wrong dose. So first, when you are encountering someone who is having seizures in spite of being on adequate treatment, first remember these 3 Ds. And only after these 3 Ds are excluded, then you consider for epilepsy surgery. Just someone is being treated and continues to have seizures, don't refer the patient for epilepsy surgery immediately. So I will give you an example. This was a 2-year girl who was referred to me and with diagnosis of epilepsy which is not responding to medicine. And what I asked them is to video the event, because every day this girl was having this repeated episodes where she would rub her legs with flushing of face and would remain partly responsive. Later, when exhausted, she would fall asleep. And this is what she was doing. This will continue for 10-15 minutes. Yes. So basically, this was self-stimulatory behavior or self-gratification. So in such cases, you first rule out any local pathology which is causing irritation. Okay. Yes, but reassurance is the only treatment. No need for any anti-seizure medication. Another which Dr. Patnaik mentioned was the wrong diagnosis and again giving the wrong drug. So this young girl was diagnosed as complaint of twitching of the angle of the twitching of the chin. So he was diagnosed as case of EEG during the interictal events were normal, MRI was normal. started on oxcarbazepine, and the events continued to increase. So then what we did was doing a video EEG, because this is where video EEG, only recording the event may not always help. So here, during the video EEG, she had an event. If you look carefully, first look at the girl. She is having twitching of the chin here, and there also she is unresponsive for a brief period. But if you again, and then she becomes responsive. So now if you look at the EEG behind, you will clearly see that when the twitching starts, although it looks like a focal twitch at the outside, the EEG is showing clearly generalized spike and wave. So this was basically a case of the generalized spike and wave, and when it goes away, she becomes responsive. Perimoral myoclonia with absence. So unless you do video EEG, you are going to miss this. So now my third question is to Dr. Aparajita. So now in such cases, when the patient is drug resistant, what are the medical options that you consider, and what are the drugs you choose? Is there any algorithm for it?
Thank you, sir, for the question. Good morning, everyone. So, as has been repeatedly mentioned by both the panelists and the chairperson, whenever a child comes to me with drug-resistant epilepsy and for another opinion, the first thing that I go through is to make sure that the child, in fact, does actually have epilepsy, and then make sure that we are not missing any factors which are leading to pseudo-resistance. That said, moving on, then we look at what is the kind of epilepsy that the child has, right? So we look as to whether it's a focal epilepsy, it's a generalized epilepsy syndrome, whether it's a combination of both, or whether it's one of the developmental epileptic encephalopathies. Because this will further guide us in choosing what is the appropriate drug. Now, once that is done, also looking at the medicines that the child is already on, what is very important to see is are the medications at the right dosage. Often we see that the child is on 3 or 4 medicines, but all these medicines are in subtherapeutic doses, and you don't really expect them to be effective at that. Just adjusting the doses might actually lead to a sustained seizure freedom in these cases. The other thing to see before you start changing the drugs, in looking at the drugs, are they antagonistic to each other, the drugs that the child is on? You cannot, there is no point combining, say, 2 sodium channel blockers, or you're giving one side, you're giving, something like carbamazepine. Along with that, you're giving something like lamotrigine, both of them, again, sodium channel blockers, and as we know, carbamazepine will reduce the doses of lamotrigine. Now, once we have ruled all this out, and we are pretty sure as to what kind of epilepsy syndrome, epilepsy type, rather, we are dealing with, the other thing to look for is what is the epilepsy syndrome we are looking at. Because if you can fit your patient into a particular epilepsy syndrome, that often can give you a more precision-guided therapy. For example, if you have a child who has something like a GLUT1 deficiency, rather than chasing the child with a lot of drugs, what would be far more sensible would be to put the child on ketogenic diet, which is extremely effective. Okay, now suppose we don't have an epilepsy syndrome here, we have drugs which the child is on, they are on the right doses. Next is to see what are the mechanisms that we will use. In a focal epilepsy, I think all of us know, we usually tend to start with a sodium channel blocker. So sodium channel blockers that we have available would be something like oxcarbazepine, carbamazepine, phenytoin, lacosamide, lamotrigine, cenobamate, and sometime we hopefully will have, and along with that, of course, you can use things like levetiracetam. In focal epilepsy also, brivaracetam. You can use clobazam also. In case of generalized epilepsy syndromes, valproate would always be the first drug of choice. Along with that, the next drug we often choose is levetiracetam or lamotrigine. We can add something like a topiramate. Clobazam would be a good add-on. Perampanel would also be a good add-on in these cases. Specifically, when you have syndromes like Dravet syndrome, we usually, the first combination is valproate with the clobazam. If possible, we can try the patient if not controlled, and if they are affordable, on something like CBD, and then you mix and match the medicines and go along with it. Obviously, if it is tuberous sclerosis related, you would want to put the child, at least try the child on vigabatrin or everolimus, along with whatever other ASMs. Now, suppose you have the epilepsy syndrome that you have decided. Now, when you are adding, a third drug or a fourth drug, you have to see what are the mechanisms that are not being, targeted in this child. You have a child, suppose in focal epilepsy, you've given a sodium channel blocker, you've given a clobazam. So what would you want to add? Makes sense to use a novel mechanism. So what mechanism we are not targeting? So if the child is not an SV2A modulator, so you would want to add something like a levetiracetam or a brivaracetam. If the child is already on a sodium channel blocker and SV2A, you want to add something like a clobazam on it, right? There is no point combining 2 or 3 sodium channel blockers. Use different mechanisms because we know epilepsy is like a network. So if you're targeting with one kind of mechanism, with one drug, one kind of mechanism, the second or the third drug should have a different kind of mechanism. Always also when we are adding the new medicines, we should remember that we don't want to increase the number of pills. So make sure that we monitor for the side effects, make sure that we actually, and then the other thing that I tend to do is, if the third or the fourth drug that we have added is helping the child, I go back and ask the parents, what was the medicine that you felt out of the 3 or 4 that the child is on, which helped the child the least. And then I try tapering that if that is possible. So that is basically the rationale with which I tend to go, and then at the same time, the child should still be being worked up for pre-surgical evaluation if the drugs are not doing their
Yes. I think Aparajita has extensively deliberated on this topic. So any new molecule which you feel that is going to come in the next few months or few years that can change?
Sir, I mean, we are all a little excited about cenobamate, even though it's not really licensed for use in pediatric epilepsy. The results from the adult trials are really, really, promising because, as we know that, when you give a first medicine in any patient with epilepsy, there's a 50% chance of, seizure freedom. The second one adds 10 to 15%. The third and so on, drugs usually only add around 5% for the seizure freedom. Whereas with cenobamate, at least for whatever data is available up to, 18 months, 24 months, the chances of seizure freedom have gone up to as much as 50 to even 80% in selected, patient populations. Even in childhood epilepsy, pediatric epilepsy, in specific, Lennox-Gastaut syndromes, or even in SN8A mutations, 80% up to seizure freedom has been shown lasting up to 9-10 months. So that is a novel mechanism because it has a dual mechanism actually. It works on the slow sodium channel inactivation and GABA modulation.
Yes.
So that's hopefully going to be available by the end of the year. I don't know, I mean, because right now it's still not licensed to be used in children. It's off-label use only, so I'm not entirely sure what will the situation in India be like.
Yeah, because there's a lot of warnings before using cenobamate. It's not approved for pediatric use. You have to monitor the ECG. You have to very slowly titrate the dose up like lamotrigine, and it can cause DRESS syndrome. So all 3 things you have to keep. If you are using it in refractory cases, you have to keep it in mind. And another molecule, I don't know why it is not available, because when we were students, we used to read it in pharma books, fenfluramine. This is another molecule which needs to be emphasized because fenfluramine is useful in treatment of Dravet syndrome. We don't have stiripentol, so fenfluramine can be a good molecule which we can use. Cannabidiol, we have used it in Dravet and Lennox-Gastaut with mixed results. So I think what she has said, I just give a summary of what she has said. So if it is a focal seizure, first is coming to a proper diagnosis. If it's a focal seizure, if you are because nowadays what happens is someone with a focal seizure comes to the emergency, the first drug given is levetiracetam. Whether it's pediatrics, whether it's adult, no one bothers to think whether what should be the drug. Because if someone comes to the emergency, first drug should be either lorazepam or midazolam. Then you evaluate and then you start the patient on a drug. But unfortunately, we are starting levetiracetam. So if there is insufficient control in a focal seizure and the treatment does not contain a sodium channel blocker, first thing to do is start a sodium channel blocker. And if there is insufficient control despite use of sodium channel blocker drugs, you can use adjunctive drugs with different mechanisms of actions like topiramate or zonisamide or levetiracetam, and even valproate can be used as well. On the other hand, if you are dealing with a generalized seizure, then if there is insufficient control with valproate or ethosuximide, then first check whether the patient is taking any other drug. For example, sometimes the patient is on phenytoin or lacosamide. That I showed in that case that where you give oxcarbazepine and the seizures increase. So best thing is to withdraw that sodium channel blocker. And if there is insufficient control despite use of treatment, but it lacks valproate, valproate should be given in cases of IgE. Now there is a problem of teratogenicity in girls of childbearing age, and now even in males there is some warning going on in Europe. But there are some cases where you have to give sodium valproate, otherwise whatever you give won't work. And valproate, even given in a low doses of say in 600 milligrams per day, is definitely less teratogenic. Third sense is where there is insufficient control with sodium channel blocker plus another drug, then you have to bring in a GABAergic drug, benzodiazepine, especially clobazam. So if you are to use a third drug, you are using, for example, lacosamide plus levetiracetam. If you are used in a focal seizure, the third drug has to be clobazam, or even in some cases, phenobarbital. Phenobarbital is a drug which gives very good results. On the other hand, if it is a generalized epilepsy and you are using valproate, but still the seizures control, in juvenile absence epilepsy, lamotrigine can be used. Some cases benzodiazepines. In juvenile myoclonic epilepsy, levetiracetam, zonisamide, and in epilepsy on getting up in the morning, lamotrigine is useful, and zonisamide, topiramate can be used, and benzodiazepines can be used also. So from here I will go to the fourth question. So when do you refer a patient of drug-resistant epilepsy for pre-surgical evaluation? I think we briefly touched upon it in the first question, but is there any time frame that you look at?
Thank you, sir, for the question. So, especially if there is a very clear-cut lesion that we discussed in the first case, that there was a clear-cut dysplasia already on 2 drugs. So, in such situations, as you mentioned, even with 1 drug also, if they are not doing well, so we should start thinking of referring.
Yes.
So, if there is a clear-cut lesion in the brain like dysplasia, you have a ganglioma or DNET or some very focal lesion is there and not responding to 2 drugs, that is the immediate have to be shifted, because that will give a very good response. So in such situation, no second thought, no further thing, you have to refer the child.
Yes.
And in general also, as we are discussing from very beginning, that any child who is not responding to 2 anti-epileptics, then you should start thinking of doing a good pre-surgical workup. So where if previously if only 1.5 Tesla MRI is done, in a pre-surgical workup, they will do a very good clinical history where they will see the seizure, semiology, triggers, frequency, everything, neurological, good examination not to miss out anything. Then a good MRI to not to miss out any very subtle lesions in the pre-surgical workup. And then doing a good video EEG where you don't miss out those non-epileptic cases. And semiology and the EEG match, and if needed further tests like PET scan or other for further localization. So all these are part of pre-surgical. So we need to refer at least after 2 to 3 drugs if they are not responding, definitely. But in some MRI negative cases, we need to do genetics prior, definitely, in especially MRI negative refractory cases, because some of the precision medicines is now, the time, so we can give good response with pyridoxine or folinic acid. So some medicines can do really wonders in especially epileptic encephalopathies, channelopathies. So ruling out those, we need to definitely refer.
Yes, I think if MRI and the EEG are the basic investigations now. So if you find it's a lesional epilepsy, then you need not wait for a year. You refer to the epilepsy surgeon if both are concordant. But if they are discordant, or if the lesion is suppose in an eloquent area of the cortex, it's in the motor area. So there you have to be a bit circumspect. You try with medicines. So either if it is non-lesional, as Dr. Jivan mentioned, or if it is in the eloquent area of the cortex, then you have to try with medicines. So now in pediatrics, there is another option. suppose you have done the patient is drug resistant, you have done the pre-surgical evaluation is negative, the genetic studies are also negative. So any other form of therapy you can think of?
So whenever they are, so because in pediatric, I think compared to adults, what we deal very commonly is are like cerebral palsy children, or especially hypoglycemic injury children coming with Lennox-Gastaut. Is a very, very common scenarios we see, more common than Dravet and tuberous sclerosis. So I think practically what I think is, first is what we miss out is using steroid in some of the Lennox-Gastaut cases. The role of steroid has really been, I think, coming up. So good trial of steroid is one thing that we should never miss out, I think, because there are many studies with monthly methylprednisolone or giving a long dose of omnacotil, this Visolone. So this we should not miss it out. And apart from this juggling the medicines and other thing, we should start ketogenic, this dietary therapy especially, very important. Dietary therapy and neuromodulation. These are two other things that we should not miss out. In dietary therapy, especially starting with, if not ketogenic diet, then we may start with a low glycemic index diet, or a modified Atkins kind of a diet, or you just add a simil MCT diet. When you just restrict some carb and you just add some MCT oil, we need to take a help of dietitian, give a trial for at least 3 months and see if the child is taking or not, because we face many parents who are not motivated to start ketogenic diet. They cannot sustain it because it's a very tedious job. And many of the children who are like cerebral palsy children who are not able to take it properly. So it's a very big challenge. And I think that role of steroid is very practical, and juggling, as Madam mentioned, rational therapy. And because neuromodulation, I think, is very, it's a costly affair.
It's
Vagus nerve stimulation and all. In our Indian setup, we have less centers doing that. Recently, one child, they went to Chennai for, tuberous sclerosis, very complex, gone to multiple places, 25 lakhs. So it's very difficult, for a VNS doing 25 lakhs, and the result is also not like, very magical. So it's practically very difficult. I think neuromodulation is not very practical at this point of time, but yes, if parents are affording, that is one of the options where vagus nerve stimulation is recommended for children more than 4 years.
Yeah. It's VNS, actually it's more like a palliative procedure where you can't do much. At least in most cases it brings down the seizure frequency or the seizure intensity, but it doesn't make the patient seizure free in most cases. So if there is a lesional case, I'll just give you an example of this. So this was a 10-year-old boy who started having seizures at the age of 6 years. And seizures were nocturnal, classical like frontal lobe seizures with dystonic posturing, hyperkinetic movements. And this boy, in spite of being on 3-4 drugs, used to have 9 to 10 seizures every night. So he is, for the last 4 years, he has not slept. Now he had a this was in 2008-9. So he had a 1.5 Tesla MRI, which was inconclusive. So basically it was diagnosed as nocturnal frontal lobe epilepsy, although there was no family history, and he was continued. But then, and there was a talk of putting this boy on at that point of time. This was in US, they were putting in VNS at that point of time. But VNS, I don't know whether the new machines work. Earlier the old machines were not compatible with 3 Tesla MRI. So that is another thing we have to consider. So this was the 3 Tesla MRI. So when it came, so if you can see clearly, this is a depth of sulcus cortical dysplasia, and it's in the frontal lobe. So this was what was causing the epilepsy, and it was missed on the 1.5 Tesla machine, but picked clearly in the 3 Tesla machine. And this boy, from having 10 seizures every night, underwent, here you will need phase 2 studies, means you have to put in depth electrodes. You can't do based on only scalp EEG. This cortical dysplasia was removed and the boy became seizure free. And from last I remember, from 4 anticonvulsants, the medicines have also been reduced to 2 anticonvulsants. So if you, that's where the pre-surgical evaluation has to be done properly. Now for here we'll go back to genetics. So Indrashish, what's the role of genetic testing? Because nowadays when you are finding drug-resistant epilepsy, we do MRI, we don't find anything on MRI, we send for clinical exome, whole exome, and then we get a report, we don't know what to deal with it.
Good morning, thank you sir. I think this question has got social relevance because in Indian perspective, when we are ordering a costly investigation, it's still costly, genetic investigation, and parents have exhausted their money finding cure or symptomatic treatment with so many medications, cannabidiol, and all the medications are exhausted. So there is a ILA genetic task for 2023 recommendations on genetic testing in epilepsy. So highly recommended genetic testing is in 4 scenarios where first one is the early onset, very drug resistant epilepsies like the developmental epileptic encephalopathies, epilepsy that is present along with autism spectrum disorder or intellectual impairment, disability or any behavioral issues. There are some progressive myoclonic epilepsies or progressive epilepsy syndromes and non-acquired familial focal epilepsies. They have, these 4 are the clinical scenarios where they have asked for this genetic testing is highly recommended and can be done in scenarios like where pre-surgical workup has been done for a structural focal lesion and we are planning the patient for surgery. In that case, we have to keep in mind the blood testing might be negative because there is a condition called as somatic mosaicism where the tissue biopsy is taken, then we can send that for genetic testing. And also in non-acquired focal lesions, also we can plan a genetic testing. The burden of genetic epilepsy is 30 to 40% of all unexplained causes of epilepsy, and in familial epilepsy syndromes like non-acquired syndromes, the yield of genetic testing is near about 76%, sir. So mainly in the early infantile neonatal period, if the epilepsies are drug resistant, that genetic testing is most relevant. And for genetic testing, we usually prefer exome sequencing, because next generation sequencing that can detect both single nucleotide variant and copy number variant.
Yes, I think if in some of the cases what we have encountered is we get a report as variant of uncertain significance. Now, what to do in such cases?
So in this case, I would say that we have to be doubly sure before ordering a genetic testing. When we are dealing with drug resistant epilepsy, we have to have a high pre-test probability before ordering a genetic test, and there should be a counseling done when we are of pre-test counseling done before ordering a genetic testing. And when we land up with a variant of unknown significance, as you showed, sir, the case, so in that case it might be that variant of unknown significance only means that the testing report or the tested variant doesn't explain the phenotype. It doesn't mean that it will not explain in the next few years, because it is just like you are going to a library and you are describing the book and asking the librarian to give that book. If that book is not there in the similar looking book is not there in the library, that doesn't mean it doesn't happen in the other libraries.
Yes,
so it has there is a genome library from where they are searching for that genomic variant is whether explaining that disease. It doesn't mean that in the next couple of years it will not come.
Yes.
Some groups are reporting, then you have to take help of search in any other places away from India. There are any groups, working groups who have reported similar occurrences. Or you can go back, retrospective deep phenotyping you can do and try to match whether the genotype explains the phenotype. You can ask from the company that the CleanVar data is there, whether that whatever you have told is matching with the phenotype or not. And also, before ordering a genetic test, you have to clearly have a working diagnosis, or the phenotypic diagnosis has to be there. Yes. Like non-specific symptoms like global developmental delay, macrocephaly, and epilepsy will give you a lot of views. If you are very non-specific in your the clinical history what you are ordering before genetic testing, then there are chances that you are getting more than one VUS in that.
Yes.
So that is there. And one more is there, that the case, sir, as if you can show, sir, that case.
Yeah, so.
So the SCN1B, so in cases of SCN1A or SCN1B, in some of the early infantile epilepsy syndromes, there we can do what is called as a functional testing. Functional testing is available in many research groups are there for different genetic families. Like SCN1A, there is a research group who are doing functional classification. So we can take help of them, collaborate with them, and find whether this variant is affecting that gene, and whether it is a duplication or a deletion. That thing.
Yes, I think, for example, here the phenotype was matching, because there was a mutation in this boy, continued to have febrile seizures even at the age of 9 years. So, and there was a mutation in the SCN1B. Now, what was interesting, I thought, let's test the parents, because the the father was my original patient. Now, he didn't have any history of febrile seizure. So, he had epilepsy which is very well controlled with one drug. So, father had the exact same mutation. So, this is the interesting part, that you get things, the mother didn't have this mutation, father is having one phenotype, the same mutation, and the son is having a different mutation. So, this is basically a subject which is still in evolution. I think we need to collaborate and
it's a gray zone actually, sir.
A gray zone. And just whether it has changed outcome or not, genetic testing, because these are expensive tests, and sometimes it leaves more questions than answers. So, these are some of the epilepsy syndromes where I think having a clear genetic diagnosis probably helps in precision medicine and tailor-made drugs, like pyridoxine-dependent epilepsy, focal epilepsy with speech disorder involving the green, then early infantile epileptic encephalopathy involving the KCNA. And these are, again, although there are potassium channel and sodium channel, in some cases even arrhythmics, antiarrhythmics have been tried, Dravet's obviously, you should avoid a sodium channel blocker, so it's on the other way. And GLUT deficiency, obviously ketogenic diet is the treatment of choice. And in cases of tuberous sclerosis, everolimus and the mTOR pathways are coming up. I think so. This brings our session to the end. Any questions? Sir, you want?
Thank you, Dr. Halder, for moderating this wonderful session. The session is now open for the audience for any one or two questions. We are already beyond our time. So one or two questions can be asked to the panelists.
Not exactly drug-resistant epilepsy, but drug-resistant seizures, secondary seizures in cerebral palsy. So that makes our life hell.
Yes.
So can you give us a small suggestion, because the time is time constraint?
Yes. So if it is not responding to one drug, I think the approach should be the same what Dr. Aparajita was saying, that if first try to find out whether it's a focal seizure or a generalized seizure. If it's a focal seizure, start with a sodium channel blocker. If it's a generalized seizure, start with sodium valproate.
No, but in the CP, most cases are generalized seizures. Not, I was talking about generalized resistant seizures, which was not responding even to two drugs. So I started 3 drugs, started topiramate, and I faced flack from my colleagues. Why are you going against the practice of not giving more than 2 anticonvulsants?
No, yes.
But it gave results. So what is your take on that? Should we count the number of drugs I am prescribing, or should we concentrate on the results?
Yeah, so if suppose you are added A plus B and then you are going to C, and the C, after adding C you get seizure control, then after some time you try to reduce either A or B. So at that point you may need 3 drugs, but later you try to reduce it.
I would like to add on. Sir, in proven case of epilepsy also, first question is whatever we are dealing with, that paroxysmal event, is it truly seizure or not? Even in epilepsy patients, non-epileptic events are very common. What we are chasing, we have to be sure about.
Yeah, so obviously we need a video, preferably a video EEG.
Yes.
One more question, please.
Yeah.
I have one question, if there is no other question from the audience. Nowadays, this pharmacogenetics is coming up very highly. So there are many genetic companies which are coming up with genetic tests with the claim that these drugs will be effective in a certain patients or not. I'm not talking about the syndromic genetic analysis, but nowadays there are many genetic companies coming with pharmacogenetics with a panel of gene tests which are predicting some drug to be effective or not, which includes the anti-epileptic drugs also. We use in adult medicine for anticoagulants.
Yeah,
But
anticoagulant
is there
like-
any role of these anti-epileptic drugs with this genetic testing of, whether it will be effective or not?
No,
how far that is justifiable to do?
I am not aware of it
I
very
also
well
not, yeah.
because antiplatelet tropidural resistance,
Those
we
things
know
we do,
anticoagulation is well described. In anti-seizure medications, it's basically the mechanism and of the epilepsy which determines. Now, whether this
Now,
drug
there
will...
are many genetic companies with these claims they are coming up. I
I'm
don't
not
think
sure
so.
how
Yeah,
proven.
yeah.
No, that helps. For example, Steven Johnson's with carbamazepine, that is
is a
okay.
separate thing, yeah.
But these other cases, whether levetiracetam will work in patient A or not, I don't think you can't predict it at this point. Yeah.
Yeah, the only place where it might be recommended is to predict side effects. Steven Johnson's to carbamazepine. Everywhere else in the world they do it. So that is the only place where we can still recommend.
Specific, this pharmacogenetics you told, sir, pharmacogenetic testing, some companies are claiming that they are doing some panel where they can predict whether that ring containing compound like the carbamazepine, oxcarbazepine, lacosamide will be harmful for the patient, will cause any Steven Johnson syndrome. In that way it is helpful, but for efficacy wise it is not, there is not enough good evidence to support that kind of.
Yeah, I think
we'll closer. Thank you. Thank you, Dr. Halder, and thank you to the panelists.
Thank you. Thanks to the panelists and chairperson.
Good morning to the august audience. Now it is the time for oration. So the memento for the previous session will be distributed after the oration. Now we would request no one to leave the hall, please. So now we call upon the chairpersons for the oration. I call Dr. Shashmita Agarwal, President East Zone, to chair the session. I call upon Dr. Arijit Chatterjee, President, Society of Pediatric Neurology, Bengal. I call Professor Kalpana Datto, ex-President, Academy of Pediatric Neurology. I call Dr. Vinit Vankare, the Secretary General, AOPN. I call Dr. Shudip Saha, Vice President of Society of Pediatric Neurology, Bengal, and Dr. Dipankar Gupta, the Scientific Chairperson of Society of Pediatric Neurology, Bengal.
Good morning, everyone. Still morning. From the organizing committee of the 5th East Zone and the 6th West Bengal Neuropedicon, I would like to welcome all of you who are spending the day with us for this excellent CME that has been organized, hopefully. So we go ahead with this prestigious Professor P.M. Kunju oration, and Dr. Josodhar will do the needful.
I request Dr. Vinit Vankare to say a few lines about Professor P.M. Kunju.
Slides. So a very good morning to all of you. It's my privilege and honor to be here as the National Secretary of Academy of Pediatric Neurology, and even more privilege to be a student of Dr. Professor Kunju, whom we lost last year, but he was our constant teacher and the guidance. So he was my guide, he was my teacher, he was my mentor and advisor, and a lot of you must be, must heard him in the past. So I first of all congratulate this organizing team for coming up with this oration in his memory. So this was the last year of conference when, and I was very fortunate that I was secretary during his chairmanship of Academy of Pediatric Neurology. And this was the pictures of when we got installed at Trivandrum last year. This was our installation team. And he categorically, because he was a very He was a very good teacher, administrator, as an organizer, as a chairman. He was the best. So he drawn a presidential action plan last year, a 100-point agenda, out of which in 1 year we completed 97 of it. So that's how we did a lot of, he assigned the roles and responsibility to all. He published a lot of books. You must be reading those books. And I think this is the recent one. Before 1 month he passed, he released that book, A Simplified Pediatric Neurology. This was released when we got installed. He was our chief controller of the fellowship program. So we have AOPN fellowships working very nicely since last 13 years, and he was a pioneer in establishing, and now we are proud to say more than 50 fellows who are working as a pediatric neurologist across the country because of his mentorship. So he was a teacher par excellence. I mean, I have witnessed his mentorship and so many of you as well. He was so popular that hoardings were there in the state of Kerala that he's our professor, he's such a good doctor. He was an awardee of several awards. He was a writer. He has written so many books, academic, non-academic. He was a prolific orator. He was a leader. He was an astute clinician. He was a thorough academician. He was a public speaker. He has received the Lifetime Achievement Award by so many organizations, including IN. He was a writer. He was the chief editor of IAP textbook of Pediatric Neurology. He was a visionary leader, and he has also directed a movie as well. So what all roles can a single person can serve during his lifetime, I think he was the best example of that. He was a good organizer, as an administrator, as an author, was an ideal family man. So in short, he was a man with the vision, man with the passion, and man with the dedication. And this was a small video which was released last year. Just switch on the audio. In his loving memory, we released this last year before he passed away. So he saw this video and he was very happy to see the work which is going on with our vibrant team last year. So I again thank the East Neuropedicon committee to come up with this wonderful oration. And I'm equally happy that it has been conferred to one of the legend in neurology, Dr. Khadilkar sir. Thank you so much. So, and this was a spotlight, a huge volume which were released, 200 pages of the work what has been done under Academy of Pediatric Neurology. Thank you so much.
Thank you, sir. Now we request Professor Satish Khadilkar sir to come up on the stage and ask the dignitaries to felicitate sir before the oration.
Good morning. Just an introduction for our orator today, Dr. S.V. Khadilkar. He has done his MD, DNB and FRCP from London. Sir is at present the professor and head Department of Neurology, Bombay Hospital, Institute of Medical Sciences. Sir was an ex-professor and head Department of Neurology, Grant Medical College, Mumbai. He was a consultant neurologist, Bombay Hospital, Institute of Medical Sciences. He's presently the consultant. He is the editor-in-chief Annals of Indian Academy of Pediatric Neurology in 2012 to 2017. Sir was the convener of neuromuscular subsection of Indian Academy of Neurology. Sir was the president of Indian Academy of Neurology in 2018 to 2019. Also the president of Nerve Muscle Society of India 2018-19. President Maharashtra Association of Neurology in 2013. President Bombay Neurological Association in 2015. Sir was the treasurer and secretary of the Asia-Oceania Myology Center in 2017 to 2026. Sir is the fellow of Royal College of Physicians. He has written 9 books, 87 book chapters, and over 250 publications in national and international and peer-reviewed journal. Sir is the teacher and examiner for DM Neurology. So I invite Sir to give us the talk.
Right. So good morning, everyone. Firstly, let me thank the organizers, particularly Dr. Jasodhara, for asking me to be here and to award this oration to me. I mean, you heard about Dr. Kunju. My interaction with him was through the Indian Academy of Neurology when I was office bearer at various stages in the Indian Academy. We interacted quite a bit, and his expertise and exuberance was very, very evident in Indian Academy work as well. So, firstly, let me accept this oration, not as a recognition of what I have done, but as a tribute to my mentors, my students, my collaborators, my family, and above all, my patients, because all of them gave me a career far richer than I ever imagined. So, as some of you know, I sort of trained at the Grant Medical College with legendary figures like Noshir Wadia, Bhim Singhal, Sarosh Katrak, Nadir Barucha, and then went on to train in nerve and muscle disease. This is the EM Scopy training with Martin Pollock. And then with a very big myologist called Byron Kakulas, who actually made me spend 6 months in neuropathology. Because the trend at that time was that a neurologist is not complete till he is a neuropathologist. And example was Ray Adams, and Byron was trained with Ray. They had written books together. So I ended up spending 6 months cutting brains. And this is the brain of the Australian rugby captain, Greg Brehout, who died on the field. And that was the only center where postmortems were done. And then I spent a little time in France and a little in England. So these are my mentors, Sarosh Katrak, Bhim Singhal, Noshir Wadia, Anil Desai, who Dr. Jaykumar talked about, Darabsha Dastur, Martin and Byron. I'll come back to them towards the end of the talk. But this talk is not about my mentors, it's not about my work, it's about my patients, who are my actual teachers. So the theme of this talk is my patients, my teachers. Because they taught me to listen, to observe, to recognize patterns, trust my clinical instincts, persist, accept uncertainty, and some more things that I will tell you along the way. So I'm using my daughter's pictures, she's an artist, as section breaks. So in '93 I returned from my training, and actually I'll take you along these 35, 40 years along with me as to how it happened. So I returned so-called trained in neuromuscular disease, but not confident, of course not famous, but just curious as to what am I going to see now. And Dr. Anil Desai was very kind to me, and he sort of put me onto the muscle clinic unsupervised from the beginning and said, you do one day, I'll do one day. And what really hit me was the number of myopathies that I was seeing, dozens of everything, but I really did not have a diagnosis for most of them. It was just an amorphous mass of myopathies, some very young, some very old, and there was just a CPK and a little bit of electrophysiology. I had no idea what these diseases were, so the first reaction actually was confusion and fright. What am I seeing? Because the work in myopathy in India at that time wasn't much. So it actually frightened me. So I started working. So lesson number one that the patient taught me, listen. Listen carefully, because diseases whisper before they shout. So this was a 43-year-old man who told this symptom to me, which I had never heard before. When I am driving, I cannot move my foot from the accelerator to the brake. Accelerator to the brake, adduction. Also, it was a very interesting time that this man was in Ahmedabad. In 1993, you could not collect your new car from Ahmedabad. You had to collect it from Mumbai. So he had come to collect his fancy car to Mumbai. And he was also very well placed, so many people knew him. So he said, I can't move my foot from the accelerator to the brake. And he only had weakness of the hip adductors and iliopsoas muscles. Then I kept tracking him. Over the next few years, he developed weakness of the hamstring, shoulder girdle, then distal weakness, and became a so-called common myopathy. So I was taught till that time that myopathy is waddle. Waddle means hip abductor weakness, and the pelvis goes like that. But this patient had an adductor weakness and not much of abductor weakness. So I thought there's something different here. And this observation, I began looking out for this pattern of weakness. Every patient who came to the clinic, test the adductors, test the abductors, go ahead. And one great thing about medicine is younger neurology students working with you. So R.K. Singh, who is now professor of neurology at the Grant Medical College, I gave him this thesis topic, that let's look at the phenotype of myopathies that we're seeing. And we collected 37 families who had this adductor weakness as the presenting manifestations. And in fact, naive as I was, I put this paper up in Reviews in Neurology. Does early adductor weakness mark the Indian phenotype? Not realizing that it's not the Indian phenotype, it's all over the world. But you learn, you go and you learn. So we had these families with this adductor weakness. The observation was adductor weakness. So the first lesson this patient taught me, listen carefully. You may be onto something that is not that commonly known. Diseases whisper before they shout. So a little bit of anecdote. This is in World Federation of Neurology meeting in Kyoto. I don't know whether some of you were there in that meeting. There's Sarosh Katrak, his wife, Ravi, whom a lot of you know, the extremely well-known headache specialist. And this was at the dinner at the World Federation where this was served. Shrimp and adductor muscle mayonnaise sauce pasta. Now you see, all four of us took it, but only I noticed it because I was interested in the word adductor. So why adductor pasta? Because adductor is the strongest muscle in shrimp to hold the shell together. So that's the only muscle from which they can make a pasta. So that's just an anecdote. Right, so the lesson 2 is observe and translate. Clinical observations become hypothesis. Hypothesis moves to the lab to become a disease. So I had this pattern of adductor weakness, then becoming a limb-girdle dystrophy. I didn't know what they were. And I realized that I therefore now need to find out how to study them. Study methodology. I mean, clinical electrophysiology, CPK, all right, what next? And this sort of a limb-girdle muscular dystrophy paradigm was available at that time, with some proteins on the muscle membrane being discovered, and now the diagram has become much more complex. This was in 95 or so. So, sorry, can you talk a little less, please? It's hitting my ears. Yeah. Right. So I realized that I have to go and get the methodology. So I went to Salpatrier. I was deputed for 2 weeks, but I ended up staying there for 6 weeks. And it's a beautiful place if you go there. I mean, the history of neurology, fascinating about. I learned about Duchenne and Babinski through the history there. So they were studying immunostains. So this is Andoni Artis-Beria, who was the research director of the European Union at that time. And I think he's expected in India for the summer school in myology next week or the next month or the month after. So I requested him, I need sarcoglycans, I need to study these. They were 300 pounds for 10 samples. So there was no way I could purchase them. So I requested, can you give it to me? So beg, borrow. He gave me worth, there was another lady whom he contacted, she gave me worth about 60 patients. So that's how I got the stains. The methodology to see, to investigate what you are seeing. And out of that came our first paper on sarcoglycanopathies. And that's where the immunostaining was losing ground. People were saying that, look, it's cross-reactive, so on and so forth. So you need the gene. So luckily, Madhuri had worked in the same institute where I worked and then went across. And today, actually, she is one of the 3 or 4 best neuromuscular geneticists in the world. So she agreed to collaborate along with Andoni. And then we carried the immuno work further to spectrum mutations in sarcoglycan genes in the Mumbai region. So we completed that thing from the clinical observation to the immunocytochemistry to the genetics. And then there was one interesting gene which seemed to have come from Africa. So from an observation, to translate the observation, your hypothesis, you have to go to the lab. And in the lab, you can define it better. But I learned another lesson, that you need a group of people with different skill sets. If you want to move ahead, it cannot be only you. It has to be a group of people, different people having different skill sets and working together with the same mindset. So same mindset, but different skill sets. That was my next lesson. Third lesson is if you recognize a pattern, you stick to the pattern. And this is the most famous. How many of you read Sherlock Holmes? Just out of curiosity. A lot of neurologists read Sherlock Holmes. I think maybe the connection with William Gowers and Charles Bell. Right, so it's the unbiased observation. Mark the word unbiased, I'm going to come back to that. Yeah, that's the philosophy of bedside medicine. So I'm showing you a video here. These patients who had adductor weakness, when you ask them to do the Gowers sign, in some of them, this is what used to happen. See that? The weak adductors and the strong abductors will pull the thighs apart and then they will get up. So that was a kind of modification of the Gowers maneuver. Now, I know this is an old video. Why I have put that up is for the new people to realize that just taking a video required a very good large video camera, which was not available commonplace. So this video camera belonged to Mohit, whom some of you know. So I requested him come to JJ with the big machine, and I want this video. Today we can take anything we like without anyone knowing about it. Right. So then we collated this pattern of getting up into hip abduction sign, which was published in Journal of Clinical Neuromuscular Disease, and is also included in the Larner's Dictionary of Science. So the lesson 3 is recognize patterns. Clinical signs result from pattern recognition. The way the patients got up told me about a pattern. Right. Now you need very good friends. When I concluded about this hip abduction sign, I had only studied sarcoglycans with immunostains and genes. And there was a 60-70% association with the sarcoglycanopathy, so I thought this sign means sarcoglycanopathy. So, Dr. Jimmy Lalkaka, whom some of you know, is a movement disorder specialist in Mumbai, and he's my friend from MBBS. So, he's somebody who's forthright, and what he thinks, he says. So, I always speak to Jimmy about the things that I'm doing. He's that kind of a friend. So I asked him, Jimmy, there is this sign, there is this sarcoglycan, and I'm writing it up. He said, look, Baba, this is just a sign. AD ductors are weak, AB ductors are strong, that's all. Nothing more, it's just a sign. When they are weak, they get up like that. So I said, Arey, but I have found them in 70% of this particular disease, so I'm going to write it up like that. He said, you do what you like, but this is what I think. And he was absolutely right, because when we then studied other limb girdle dystrophies like calpainopathies and others, the sign is positive in many, not only sarcoglycan. But he denotes just a pattern of weakness, and this is what he said, even though completely against what I was doing at that time. So I was not wrong. It is a sign in sarcoglycanopathy, but it's not the only disease that produces it. Now, what's the importance of the sign? If many diseases produce it, I think it still allows you to differentiate inherited myopathies from acquired myopathies of various types, because they don't seem to have preferential weakness. So you need very good friends. Actually, you need, just like you need a group with different skill sets, you need people who can constructively criticize you and say, look, you're not doing the right things, or this is how it should be done. The next lesson is lesson from a community. You know Professor Singhal. He is one of the legend in neurology, and he was director of neurosciences in the hospital where I worked, and head of the department in the medical college I worked. So I think, being pediatric neurologist, you will know that he diagnosed, rather he told about the megalencephalic leukodystrophy in children with large head and others. So he's another person who always gives very sound advice, very practical and sound advice. So in all these LGMDs, just like the AD ductor weakness, there were some who had scapular winging. So I was keeping the scapular winging ones aside. So amongst those with a scapular winging, some had facial weakness. They were the FSHDs. But there were some others who did not have face weakness, but had a scapular phenotype. So I was keeping them aside. After a year or two of keeping them aside, I realized that a lot of them are having the surname Agarwal. So why a particular community is having this particular distribution? So I showed you Dr. Singhal's photo. Megalencephalic leukoencephalopathy he described was also in Agarwals. A lot of Agarwals come to the hospital where we work because traditionally they have been coming. So these are the phenotypic features: the abdominal hardening, the scapular winging, and normal face. So I started looking into Agarwal's clinical observation that upper body limb girdle muscular dystrophy is seen more commonly in Agarwal's. It's a bedside observation, nothing too special about it. But when I started looking at the Agarwals, I realized that it's a very interesting community that practices they have 18 gotras. And the folklore is that the king Agrasen had 4 or 5 wives and 18 sons. Each son carries one gotra. If there is Agarwal amongst you, you can tell me more about it. Yeah, because every medical gathering there are Agarwals. So they look at girls' father's gotra, boys' father's gotra, but they don't look at where the mothers have come from. And when I inquired with them, why do you do that? They said that if we look at all 4, we will never find a match because there are only 18 and it's a smallish community. But this is from Manu Smriti. It says you should avoid marriage in the same subgroup and in 7 generations of mother's lineage. So somehow at the moment they didn't practice it. It's intracommunal exogamy actually, scientifically. So when we again tracked them and tested them, now see, calpain need to be blotted. Calpain cannot be stained. So it was more difficult and we had to take the help of hematology department to allow us the Western blotting machine to be used for calpain. And calpain blots at 3 different molecular weights, 30, 60 and 94. So it took us a lot of trouble to get that going. But then we followed that up with the genetic testing. And we found 2 founder mutations in Agarwal, which are ancestral founder mutation because of this, the way their lineage is. So this paper talks about the ancestral founder mutation. There's one other thing that I want to point out, even though it was sort of my clinical observation, so to say. I was the clinician in the group. Clinicians usually are the leaders in the group. Arun said that if I become first author on this paper, it gives a huge boost to my career. So again, group activity. Madhuri and I thought, no harm in doing that. So Arun is the first, before PhD, he is the first author on this paper. And then we did an experiment where when an Agarwal came with a scapular winging, we just did this 2 founder mutation, which cost 7,000 rupees. We did not even do a CPK, did not do anything, just do these founder mutations. And there's a 90% yield. So what did we learn from this? That if you have a small community in which you decipher a useful thing, the direct community awareness today has led to antenatal diagnosis, prenatal diagnosis, at-risk counseling, and the number of patients who have limb girdle muscular dystrophy and their progeny having limb girdle dystrophy is remarkably reduced. So it's direct benefit. It's unbelievable how it spreads and how rapidly it spreads. Last week one Agarwal came to me and told me about this research as if it was someone else's. He said, "Are you aware, doctor, that there is this?" I said, "Thank you very much, I am aware." So the lesson from this community work, see, India is a huge country, but there are little genetic Indias within India. Because we are all sort of, thousands of years we've been marrying within the community, within the region, within the whatever. So rather than having a big blanket project to say all genes for all LGMDs in India and we'll find an answer, you won't find. You will only write a paper. It won't be of help. But here, I think in the Indian situation, what I learned from this is small, well-directed efforts for a small group can actually pay rich dividends than putting up a blanket work which will just make a paper. Like the MRC put in India. You know, MRC put a paper with 5 centers in India looking at all the genes of limb girdle muscular dystrophies. Papers have come out of it, but that's not translating into anything useful. Right. So up till now what I learned was 1 patient, 1 observation, 1 hypothesis, 1 thesis, 1 publication, 1 citation, 1 book. That's the journey. everything starts with that one patient where you make an observation. And I think 2017 we did this book on neuromuscular disorders, which Springer seems to like quite a lot. Right. The next is data keeping. Ashish was working with me doing his DM in 2013, I think. And he was working on limb-girdle muscular dystrophy. So by this time, Excel and the so-called, well, it's not modern anymore. In fact, you hear ads now that Excel is old people's thing. But we started using Excel decently at that time. And he kept about 80 columns in which he was filling data. And one of the column was the region and the ethnicity. So he kept that. So why did we keep that column? We did not know, but we kept it. And he realized that this 1706T, he was looking at GNE genes, and 2 genes were common, out of which 1706T to C came. He said, okay, match this 1706. On the left column, everybody with 1706 was coming from Rajasthan. And they were all homozygous. So just the Excel helped us to say that this particular gene is in a certain area. Not only that, now the web helps you so much that in a week's time we knew that it was a Roma gene. So then we worked on that and we tied it together. And actually this is one more link. There's several links, but this is one more link that suggests that all the Roma of Europe, all the gypsies of Europe originated in first central India and then northwest India from where they went out. So that's the migration route shown here, and that Ashish converted into a paper. So the lesson is data keeping. When you're not knowing what you're searching, keep as much data as you can. You don't know which of that will be useful to you. And the web really has made things so much easy. Just now I think we published some paper about a myopathy that has not been described previously from India. To know that it has not been previously described was just 2 days' work, which earlier would have been 6 months' work. Now I'll show you something that is interesting. You know, this boy saw me at the age of 5 or 6 with a CK elevation, nothing else. So young boy, elevated CK, you would think of a dystrophin-related problem, some kind of Duchenne-like problem. So I did his Duchenne genes, they were negative. Then as he started going to school, he started saying, I'm not able to run like others. I have to stop earlier, then I wait, then I start again. So I thought, is this exercise intolerance? So I investigated him for a metabolic myopathy with a muscle biopsy and ORO and all that. I turned negative. Then around 17 or 18 years of age, he started having distal lower limb weakness. Then he had proximal lower limb weakness, and then he had upper limb weakness by the time he was around 35. So, depending on when I saw him, the diagnosis evolved from a Duchenne-like condition to a metabolic myopathy-like condition to a distal myopathy to a limb-girdle dystrophy. And finally, we sort of pinned it down to the DMAT variant of dysferlinopathy, which is quite an uncommon variant. But the point I'm making is, if we think that we will see a patient once and have all our judgments right, that's not going to be there. You may have to see over years. So the lesson 7 is persist and accept uncertainty. And I think uncertainty is one of the issues in medicine which plagues medicine. We really are so imperfect that it's uncertainty everywhere. Right. This is our current work about reframing genetic myopathy classification. Right. So in these years, with these lessons, what have I seen? I think everything changes. Everything changes. Myology in front of my eyes in Mumbai changed from clinical examinations, CK, EMG, to then CK, EMG, biopsy, histology, immunocytochemistry, then immunoblotting, then came genetics, then came MRI, then came NGS. Now NGS is everywhere. Now the problems are NGS is done, it's not matching, now what? And now we're talking about therapeutics, gene editing, AI. So in that sense, everything is changing. Technologies change, genes change, classification change. But I think some things do not change. And they are curiosity, observation, compassion, and humility. Now, compassion and humility comes because of the uncertainty. I think the uncertainty makes you realize that, look, what's going to happen to this guy tomorrow, I don't know. Let me be compassionate, let me be, let my feet be on the ground. So I think even though things are changing, some things don't change. That is what I learned. When I started also, an ALS patient was coming to whom I couldn't do anything. Today also an ALS patient comes to whom I can't do anything. Right. So with those things, let me come to my last few slides. These are the first three are bosses at the Grant Medical College. Dr. Noshir Wadia started the department, then Bhim Singhal followed, then Sarosh Katrak followed. Then there was a little gap with Dr. Neeta Mehta, then I followed. So over 50 years, over 60 years, 4 of us carried the department. In that sense, it's a very unique department. And Nadir Barucha, very highly qualified neurologist and neuroepidemiologist. So Sarosh taught me discipline and honesty. Dr. Bhim Singhal taught me persistence. Noshir Wadia taught me elegance of thought. I think those of you who have seen him will appreciate this statement. Elegance of thought. How does one think elegantly? And Nadir taught me harmonious group work. I mean, in Bombay Hospital, Nadir is a senior consultant where I am a junior consultant. And Dr. Singhal is still working, Nadir is still working, so I really thank them because it doesn't make me feel old. And that's Anil Desai, whose clinical neurology is extremely good. And how to get interested in a subject, Anil Desai, Anil D as he was called, told me. Darab was a neuropathologist of absolutely terrific reputation. He is one of the 29 neuropathologists of this century in the world. Just his presence and sitting with him on the slides was phenomenal. Martin taught me that if you know the language, E.M. organelles can talk to you. And Byron made me do neuropathology, which became obsolete actually. When a neurologist is not a neurologist till he's a neuropathologist, gone. Neurologist is not a neurologist till he's not a neurogeneticist now. And tomorrow I don't know what it will be. And these are some of my friends with whom I interacted a lot. That's Mohit Bhatt, that is Roop Gursani, Vrajesh Udani, Sudhir Kothari, who is president-elect for the Indian Academy now, Subhash, Ashok. And these are all the people, some of the people whom sort of, into inverted commas, I trained. But actually, just like your patients teach you, your students teach you. So, some of them, you know, Pawan is the president of the Indian Stroke Association now. Krishe is professor in Toledo. Shripad is in neuroimmunology. So, a lot of them have done extremely well. And that in itself is a very nice thing to see. These are the two institutions where I work, the Grant Medical College and the Bombay Hospital. Luckily, Maharashtra had this part-timer services, that you could do 4 hours in the medical college and you could do 4 hours in the private setting, which I think was phenomenal, but the current administrators don't think so. These are my parents, my wife and children, and now grandchildren. So tomorrow actually is my duty to take that fellow for swimming. Now this family is away, but the other one is, they live very close to me. In 1 second I'll mention one other dilemma, a big dilemma that I had. I was a sportsman. I did not want to be a doctor. I did not want to be a doctor. I wanted to play badminton. I was selected in the national team at the age of 15 and a half, and I thought I could have done very well. But my mother said, that's stupid. You know, middle class convention of that time. Unless you are a doctor or, if at all, an engineer, you are nobody. So I came into medicine. But there is a lesson here. If you apply yourself to what you're doing, you can do well. This is what I convinced myself, because I didn't want to become a doctor initially. Right. So I think, even though I've had mentors, students, everything, I think my greatest teachers have been my patients. They never wrote textbooks, they never delivered lectures, they never chaired conferences. They simply came to my clinic with weakness. But they taught me to observe before I investigated, to think before I tested, to question before I concluded, and to remain humble before every diagnosis. Patients were really my teachers, and I remain their student. And I think lastly, there are a lot of young people that I see, so I put this slide up. I made it here now. Do not worry about making discoveries. Worry about making observations. Do not chase publications. You see that all the time. We'll write this up, we'll write this up, we'll write this up. Don't chase a publication, chase unanswered questions. Unanswered questions make publications. But your aim is not to write, your aim is to answer that question. Do not try to become famous, but try to become curious. If fame is going to come to you, it will come. So the rest will follow. So I think I'll stop here. Patients were my teachers and I remain their student. Thank you so much.
I will request all the chairpersons from the previous sessions and the speaker to collect their mementos from the memento corner. Next we will, from bench to bedside, real-world case discussion on plexiform neurofibroma by Dr. Lokesh Lingappa. This session is sponsored by AstraZeneca. The dais is yours, sir.
Good afternoon. I think after Professor Katrak's oration, I'm just starting this with this slide. Although the talk is on different thing, but I'm just showing this slide. How long does it take to develop a genetic treatment for these genetic disorders? So if you can see, the steroids were started as research in 1970s and became a standard of care in 1990s. Vamorolone it was a concept in 2010, and then 2025, 15 years for a UK approval. It's going to come to India probably end of this year as a part of trial. Givinostat started as research in 2004, and it took 20 years for an approval. Exon skipping as a concept is still a concept. Most of the centers in Europe have not approved. It's on trial basis. They come and go because they're quite expensive, and it's a lifelong exon therapies. Gene therapy, 1990s, now 2023, first approved, but approved only in US. Europe has still not agreed to that because of the expense and the efficacy they have not proved. So that is how it takes the years of research and anything for a molecule to, from the concept to come a treatment. It takes anywhere between 20 to 25 years, if you are lucky. But there are certain molecules where you can probably get it faster. So that is one of the molecule I'm going to talk about. That's selumetinib for the treatment of PN and NF1 associated plexiform neurofibroma. I will go through the mechanism of action, the spin trial efficacy and safety, and some case scenarios. So as you all know, NF1 can be associated with plexiform neurofibroma, which causes significant deformity, pain, and also other complications depending on where they are coming from. If they are coming from the behind the airway, they can cause breathing difficulties. If they are in the around the abdomen, they can have urinary disturbances, radiating pains. If it is in the limbs, significant dysmorphism and pains as well. So it can be quite disabling, and some of them can have a malignant transformation. Around 8 to 13% have a lifetime risk of developing a malignant transformation of the plexiform neurofibroma. So these are the ones which cause significant long-term issues to them. So depending on the place where they are, if it is around the eyes, they can cause significant swelling and visual impairment. If it is in the pharyngeal area, they can cause stridor. And if it is in the pelvic region, they can cause urinary disturbances and pains. So all these things can be a manifestation, all depending on where the lesion is and what is the size of the lesion. If there are very small lesions, obviously they wouldn't cause much of this one other than disfigurement. But if there are large lesions increasing in size, pain, and because of the nature of the lesion, they can cause significant pain. So in one of the studies, when they have looked at the longitudinal data of around 7 years, and they were at 13 years at enrollment, they have followed up for 7 years. And what they have seen is the bowel and bladder abnormalities increased by almost 50% in that 7 years. There was a significant increase, almost 50%, doubling of the motor difficulties over that period. And surgery was required in 25 of them, and significant pain increased in another 50%. So it's a slowly progressive process in a lot of these children. And the plexiform neurofibroma is seen in almost around 30 to 50%. In India, we see a little bit less incidence. More in the Western world, it is more towards 50. In our country, it's around 20 to 30% of them develop plexiform neurofibroma. So that's why when at the diagnosis of NF1, we ask them to get a whole body MRI to see if there is a plexiform neurofibroma at the diagnosis, and then you keep following that area over a period of time, because if it is there at that time, then they keep growing. If they don't have anything, they are probably that 70% of those children where they are not going to develop the plexiform neurofibroma. So many of them can remain asymptomatic, just you will have to follow up the size and the symptoms, and almost 60% can become symptomatic over a period of their lifetime. And depending on which organ it is affecting, you can have head and face, neck, chest, abdomen, extremity, and spinal cord. So you'll have to look at whether it's progressively increasing. Second question is whether it's completely operable without causing too much of complication. So if it is completely operable, go for surgical involvement. If it is inoperable, then you have to look at the targeted therapy, which you are going to look at. So NF1 is, as you know, is caused by the loss of neurofibromin gene, which causes significant loss of control of growth pathways and unregulated, unstimulated this one. If you can look at this cartoon, As you can see, neurofibramin modulates the RS and GTP pathway, which in turn modulates the RAF, MEK and ERK pathway. This is the mitogen activated protein kinase. So this is the pathway where the cell control is unregulated when the neurofibramin is missing. So there is a increased cellular proliferation and survival. So the selumetinib is going to target the MEK, mitogen activated kinase. Inhibiting the MEK causes significant reduction in the cell turnover and cellular survival as well. So that is how the selumetinib is going to improve the plexiform neurofibroma growth, reduce the plexiform neurofibroma growth. So the sprint trial was designed for patients aged between 2 to 18 years, which were NF1, and they are inoperable. If you are able to operate surgically, just operate it so that the complications can be taken care of quickly, because the duration it takes for these medications to help can take anywhere between 6 months to 1 year. Once you start the medication, for it to have a significant effect might take 6 months to 1 year in many of these children. So the study design was almost in phase 1 there are 50, and then in striatum 2 there are 25 children who were enrolled. 25 milligram per meter square orally twice daily was the dosage which was used. And primary outcome measures were objective response rate, secondary outcomes were long-term tolerability and safety, which was looked into. And the morbidities which were there at the baseline is almost 90% of them. Obviously, it's a plexiform neurofibroma. Deformity or disfigurement is one of the prominent problem what they find. And motor dysfunction in almost 65%, and pain in around 50% was seen in this group of children who were started on treatment. So the primary efficacy analysis, the partial response was seen in 34 of 50, that is almost 68% of them had the partial response to the medication, which was the primary endpoint. And achieved a reduction in the volume. Volume reduction is by around 20% volume reduction or more was noted in almost 60% of these patients. So one of the important thing what it has shown is, somebody who was on selumetinib, there is a progression-free survival was noted in almost 85% of them once you started selumetinib. But who didn't receive selumetinib, the natural history is in 3 years' time, almost only 15% remains progression-free. Almost 85% continued to have progressive symptoms when they were not using the selumetinib. So that is a significant improvement in the quality of life and the showing the efficacy of the selumetinib in improving multiple quality of life index. So if you look at the various clinical outcome measures which have been shown, the light blue is which is showing the improvement. So overall pediatric quality of life index, pain interference index, and mobility index, and all the different indices have been significantly improved with the use of selumetinib over cycles. Each cycle is 28 days. When they assessed at the end of 13 cycles, so they could find significant improvement in most of the quality of life measures and the pain measures after starting the selumetinib. And the pain intensity score also had reduced significantly in the patients by around -2.14. So if you look at the overall global impression of change, the tumor-related complications, parents felt that there was a significant, almost 70% of the parents felt that there was a good improvement. When you ask the children, around 29 children were asked, how did they feel, whether it is much better, and this one, very much improved to much improved was noted in 60%. That is quite a good response for a condition where it couldn't be cured by surgery, and you have a medication which can help to improve the overall outcome of these children. And so the quality of life measures, once again, overall there is a significant improvement, more than 50% better from prior to starting and the prior to cycle 13, which is almost more than a year of treatment. So the physical problem had improved, emotional domains, because if you are seeing a reduction in the shrinkage of your tumor, you are going to feel better. So the emotional domain had significantly improved as compared to the physical domain. The social domain had also improved, but they couldn't manifest any significant change in the school domain. So apart from all the quality of life measures, pain measures, the strength and range of motions also had improved in 33 children who had received this medication. And so initially there are around 21 of them who had abnormal muscle strength at baseline, which increased average strength was noted after the 13 cycles, which was statistically significant. And range of motion also had improved significantly, which was statistically significant at the end of 1 year of treatment. So that is quite a significant improvement for these inoperable tumors. Is it safe? So if you are going to use it for long period, of any new drug, we want to know that it is safe. So what it has been saying is these things are safe, but there are a lot of side effects which you need to monitor for. What are the side effects which are saying? Dry skin and acneiform dermatitis is quite significant, especially in girls it becomes quite difficult. Asymptomatic CPK elevation can be seen. Nausea and vomiting are common complaints, can be managed easily. Diarrhea can be seen, significant paronychias or other complications which are seen. So including all kind of side effects, it's around 49, almost 98% of them had some or other side effect. But grade 3 and above, that is grade 3 is severe life-threatening effects, were seen in around 60%. So it is not free of side effects. You have to monitor them carefully. Dose adjustments have to be done if they are manifesting any of the significant side effects. That needs to be carefully monitored. So now it is approved in around 64 countries, and more than 5,000 patients are enrolled on this medication. In India, the problem is obviously the cost of the drug. They have actually trying to provide some concessions. If you buy for 3 months, they are going to provide for another 3 months or 6 months as a free of cost. So they are trying to help them, but still it's prohibitively expensive. The primary problem is any genetic disease, Indian insurance companies refuse treatment. I think that's something all of us should fight together with the help of parent communities to change that, because they shouldn't be blanketly refuse the treatment options available for the genetic disease, which is no fault of them. So I think I'll stop there. So it is a good drug which helps to reduce the size of the lesions, improve the pain in non-operable plexiform neurofibromas, and it is a game changer in many of these patient families. But the problem when we are counseling the families is it going to cure it for the money I am spending? No, it is not going to cure, it's not going to take away the complete lesion, but it's going to help you to make your life better, reduce the size of the lesion, have a progression-free survival for a significant period of time. So that is a thing which can help significantly in these patients. But until we have a balance of where for the money the patient is going to spend out of pocket and the benefit matches, it's going to be difficult for all of them to accept this medication at this point in India. But hopefully if the insurance coverage improves, it can be used with much more families. Thank you.
So for the next session, I would like to welcome our chairpersons, Dr. Prabhavati Banerjee, former President WBAP. Welcome ma'am on the stage. Dr. Shopna Chakraborty, former HOD Pediatrics, Medical College, Kolkata. Dr. Karthik Ghosh, HOD Neuromedicine, NRS.
Good evening. Good afternoon. I must thank the organizers for inviting me in this important session. I will call Madam Dr. Ekta Agarwal. Madam, please come. She will discuss on autoimmune encephalitis, the red flags and the diagnostic workup. Madam Dr. Ekta Agarwal, she is the Director and Consultant Pediatric Neurologist, Shambhav Pediatric Neurology Development and Intervention Center, Jamshedpur, Kolkata. Her major achievements that she has won awards for platform and poster presentations and with different national and international levels, faculty at several conferences and CME, and reviewer of peer-reviewed national and international journals. And she had publications in national and international journals, and also she has contribution in chapter of books. Please start, madam.
Thank you so much for all that introduction. At the onset, I would like to first thank the organizing team for giving me this opportunity to present my talk in front of this august audience. I would be discussing about red flags and diagnostic workup of autoimmune encephalitis in children. I have no disclaimer to make. My topic would run under the following headings of introduction. Not all encephalitis is autoimmune. Clinical features and red flag signs, diagnostic criteria, a detail about the workup, and finally the take-home message. So, what is autoimmune encephalitis? Autoimmune encephalitis comprise a severe group of neuroinflammatory diseases. Primarily, these disorders are driven by specific humoral immune attack on the central nervous system. There are various antigens upon which these antibodies attack and give rise to the combination of neuroinflammatory diseases. Clinically, these children present with acute to subacute onset of rapidly progressive, severe neuropsychiatric and cognitive decline, which progresses over several weeks. Although it was considered very uncommon, but possibly the recent evidence suggests that they are more common than initially thought, with an estimated incidence of about 1.5 children per million. Now, why do we even bother about autoimmune encephalitis? Why do we think about it? Because the most important thing is it is a potentially treatable neurological emergency. As already told, the incident has been increasingly recognized now. Many of these cases are antibody negative and often they are excluded, but actually antibody negative does not mean it is not autoimmune encephalitis. Most important thing is that early treatment improves outcome, and because of the overlapping symptoms with other common disorders, they are often misdiagnosed as infection or psychiatric illness. So if we don't detect them early, then the treatment will be delayed, and time to treatment is important in predicting outcome. Pediatric autoimmune encephalitis pose a diagnostic challenge because the clinical features overlap with other disorders like the psychiatric disorders, a number of infections, metabolic diseases, and CNS inflammatory disorders. Besides that, the behavior in children are often complex, and the behavior changes which we can see in autoimmune encephalitis is often passed as normal. The child is considered a more troubling child in comparison to the other children, and the initial behavior changes may be overlooked. Also, children have very limited capacity to describe their symptoms. But pediatric autoimmune encephalitis is an entity which is different from the adult one, and the guidelines in adults do not apply to children because of the differences in clinical presentation, differences in the investigation findings, and the differences in the autoantibody profile. So it is very important that we recognize pediatric autoimmune encephalitis because treatment delays worsen prognosis and increase the risk of permanent neurocognitive deficits. Although there are many disorders which can mimic autoimmune encephalitis, but clinically there are those para-infectious group of disorders which we are more concerned, which will mimic or resemble autoimmune encephalitis, and therefore we will worry which is what. So the three groups include the acute infectious encephalitis, the infection-triggered group, that is the infection-triggered encephalitis group, and finally the autoimmune encephalitis group. The primary driver in the case of acute encephalitis, that is the infectious encephalitis, is direct invasion of the brain by a viral or a bacterial pathogen. Whereas in infection-triggered encephalitis, it is a systemic infection which triggers a hyperinflammation in the form of cytokine storm. Autoimmune encephalitis, on the other hand, is because of autoantibodies against antigens in the central nervous system. The onset in case of acute infectious encephalitis can be acute, lasting from hours to days, whereas in the ITS group, it is hyperacute, around 1 to 2 days, and in this autoimmune group, it is subacute, from weeks to less than 3 months. Preceding infection is an essential criteria for acute infectious encephalitis, and the symptoms of fever are usually present at the onset of neurological symptom. In the ITS group, again it is para-infectious, so infection and systemic inflammatory signs are common. In autoimmune encephalitis, presence of infection or fever can be variable. Most commonly, they are para-infectious and they are present as a prodromal feature before the onset of symptoms of acute autoimmune encephalitis. Encephalopathy is an essential criteria which is present in all three of them, and therefore the diagnosis becomes difficult. If we go ahead with the investigation, the CSF in case of acute infectious encephalitis will show PCR positivity of the invading pathogen along with lymphocytic pleocytosis. In the ITS group, there is no pleocytosis but high levels of interleukin 6 and 8. And in the autoimmune group, there are oligoclonal blands, elevated IgG levels, and autoantibodies which can be detected in CSF. MRI in the case of acute infectious group can show focal necrosis or can show cerebral edema, whereas in the infection trigger group, different group of ITS have different MRI findings. For example, in the acute necrotizing encephalitis, there is symmetrical thalamic lesion. In the ACID group, there is restricted diffusion, which is very characteristic. In the case of acute autoimmune encephalitis, there are many T2 and flare signal abnormalities in the limbic system or in the white matter. Because of the underlying pathophysiology, the treatment in case of acute infectious encephalitis is antiviral. In the ITS group, it is immunomodulation, and in the autoimmune group, again, it is immunotherapy. So let us understand this more clearly. Different mechanism leads to different pathology. So in acute infection, there is direct entry of the pathogen into the central nervous system, which crosses the blood-brain barrier. There is viral replication, which leads to the activation of T cells, and the T cell causes inflammatory cascade with microglial activation, which leads to actual neuronal injury and necrosis. Therefore, the treatment for this treatment or the target is kill the virus. In the ITS group, the mechanism is infection-driven systemic cytokine storm. So there is a trigger, usually an infection, which causes an exaggerated immune response with development of a cytokine storm. There is interleukin 6, TNF alpha, interleukin 1 beta, etc. These cross the blood-brain barrier, cause activation of the astrocyte and excitotoxicity, resulting in diffuse cerebral edema and metabolic dysfunction. Therefore, the therapeutic target in this group is control the inflammation. In the autoimmune group, it is antigen-specific adaptive response. So there is a trigger, either infection, tumor, or genetic susceptibility, which leads to loss of immune tolerance with molecular mimicry. There is activation of the B cell and production of autoantibodies against the targets of the central nervous system. These autoantibodies cause synaptic dysfunction and disruption of the membrane function, resulting in autoimmune encephalitis. So the target for this is remove the antibodies. Now, How do we suspect or when do we suspect autoimmune encephalitis in a child with encephalopathy? So, in a previously normal child, when there is subacute onset, that is onset less than 3 months of encephalopathy and cognitive decline, new onset seizures, behavioral change or psychosis, speech dysfunction or speech regression, movement disorder and catatonia, dysautonomia or sleep disturbances, that is, it's a polysymptomatic syndrome involving different parts or different systems with the prodrome of fever, headache or viral-like symptoms, which may often go unnoticed. The clinical course consists of an acute or subacute onset. In children, we often find acute onset with a rapid decline. Often the patient is initially thought to be viral encephalitis but does not respond or relapses after treatment, and there is involvement of multiple domains like the cognition and the extrapyramidal symptoms. What are the features which are against the diagnosis of autoimmune encephalitis? A very chronic or an indolent course, plateauing of symptoms. Initially there is rise and then the symptoms plateau. There is no impairment in the activities of daily living, that the child is able to perform his activities absolutely normal. Cognition remaining intact and only psychiatric symptoms. If these features are present, then these go against the diagnosis of, a point away from the diagnosis of autoimmune encephalitis. Now coming or teasing each of these symptoms now. The neurological red flag signs consist of new onset seizures. Most of these seizures are refractory. They can be focal or generalized, often amounting to status epilepticus, and they are often resistant to first-line anti-seizure medications. Child displays encephalopathy in the form of reduced consciousness, language impairment in the form of aphasia or pure mutism. They can be ataxia, and new onset focal neurological deficit. In children, another interesting presentation is an acute or subacute loss of previously acquired milestones of language, memory, or a decline in academic performance. Coming to the psychiatric and sleep red flag signs, in any child less than 13 years of age, if there is a new onset psychosis, hallucination, or delusion, then these are atypical for primary psychiatric illness, and they strongly suggest an organic cause requiring investigation. These children can also present with anxiety and mood disorders. The red flags in sleep consist of refractory insomnia, mutism, fixed posturing of fluctuating catatonic state, alternating with agitation, inconsolable or unprovoked crying, and hyperactive behavior. So catatonia is a neuropsychiatric syndrome where there are a combination of symptoms involving behavior, movement, and responsiveness to the environment. These children are often unresponsive, almost awake, but not responsive, and this can alternate with stupor, rigidity, and agitation. The red flags in dysautonomia and movement disorder consist of dysautonomia. There can be unexplained fluctuation in heart rate, blood pressure, temperature, manifesting as arrhythmia. Arrhythmia is more common in adults. In children, we more commonly find tachycardia or bradycardia. Labile blood pressure, hyperthermia or hypothermia, central hypoventilation, and urinary retention or incontinence. Movement disorder manifests in the form of hyperkinetic dyskinesias. Most of these kinesias are in the orofacial lingual distribution, which are described as severe orofacial lingual dyskinesias. There can be chorioathetosis, tremors, dystonia, and myoclonus, and ataxia. So these are the clinical features which can be seen. Certain autoantibodies present with a group of features which make the clinical suspicion of that antibody more common. So based upon these, we can divide the clinical phenotype. So the most common one is the anti-NMDR receptor antibody, which presents with psychosis or behavior disturbances, memory impairment, seizures, and dyskinesia. Autonomic instability is more common in adults. The behavior disturbance in anti-NMDA receptor encephalitis in children can manifest something like temper tantrums, agitations, aggregation, or mood changes. Anti-GABA receptor encephalitis can present with severe seizures, status epilepticus with poor response to medications. Anti-GAD65, that is an intracellular antibody, can present with memory loss, cognitive impairment, ataxia, and seizures. Anti-LGI1 presents most commonly with seizures, which can be focal seizures or facio-brachial dystonic, more importantly, tonic seizures. They have hyponatremia, which can often present with seizures. And the last one is the anti-Casper2, presents with Morvan syndrome, which is a triad of neuropathic pain, sleep disorders, and dysautonomia. Now, this is not the end of list of antibodies. These are the most common antibodies which are seen in the pediatric autoimmune variety. Out of that, anti-NMDA receptor encephalitis is the most common after the MOG-ADEM. Progressing next to the diagnostic criteria. So, if we have a child who was previously normal, he or she presents with acute or subacute onset of symptoms. What are those symptoms? At least two of them should be present. These symptoms can include altered mental state, altered level of consciousness, or e.g. evidence of slowing or epileptiform activity, new onset focal neurological deficit, cognitive difficulties, acute developmental regression, motor movement disorder, psychiatric symptoms, and seizures which are not explained by any known previously present seizure disorder. Then we look for evidence of neuroinflammation either on the MRI, EEG, or CSF, which can include the CSF inflammatory changes of leukocytosis or oligoclonal band, MRI feature of encephalitis, and if a brain biopsy is done, it shows inflammatory infiltrates. Exclusion of alternative diagnosis is an important part in the diagnostic criteria. Reasonable exclusion of causes including the CNS inflammation. If all of these are present, then this point towards a probable pediatric autoimmune encephalitis, and this is the point when we initiate immune therapy. Even before the antibodies are tested, this is the point where the immune therapy can be initiated. So what are these differential diagnoses which we have been telling to exclude? So the infection group. In the autoimmune, the different kinds of autoimmune varieties, including the ITS group, metabolic disorders, psychiatric disorders, toxic disorders, and CNS vasculitis. Now, based upon this workup, we have the classification of possible, probable, and definite autoimmune encephalitis. So, first look for evidence of acute or subacute clinical features which in a previously normal child. If they are present, at least two of the features are present, then that becomes a possible autoimmune encephalitis where we have a clinical suspicion of autoimmune encephalitis. After this, we proceed with paraclinical evidence of inflammation in the CSF, MRI, or brain biopsy. If one of these features are present, then it becomes probable autoimmune encephalitis. After this, we proceed with antibody testing. If two features are present clinically, one feature of neuroinflammation is present, but the antibody is negative, then this becomes probable antibody negative autoimmune encephalitis. If at least two features are present, at least one feature of neuroinflammation is present, along with antibody positive, then this becomes definite antibody positive autoimmune encephalitis. However, we have to exclude other etiologies which simultaneously when we proceed with this diagnostic criteria. So how do we progress? We have a clinical suspicion. We go ahead with MRI, EEG, and LP while we exclude the other disorders. Based upon this, we have a feature of a probable autoimmune encephalitis. We go about with antibodies testing. If the antibodies are positive, it becomes antibody positive autoimmune encephalitis. If it is negative, it becomes autoantibodies negative autoimmune encephalitis. Tumor screening, usually not indicated in pediatric cases because tumors are usually not associated, but beyond 12 years of age, tumor screening may be indicated. And then we progress with immunotherapy. So what are the findings? Based upon the first thing that we do is brain MRI. The common findings include limbic hyperintensity, involvement of the cortex, subcortical, basal ganglion and white motor lesions. In the MOG variety, it is ADEM-like presentation. However, MRI abnormalities are present only in 20 to 50% cases of anti-NMDA receptor encephalitis, but it is more common in the other varieties. Therefore, a normal MRI does not exclude autoimmune encephalitis. Again, diffusion restriction is not common in autoimmune encephalitis. It is more common in the ITS and the vasculitis group. So coming to some of the MRI findings, the first one is the limbic encephalitis, where we see bilateral mesial temporal hyperintensity and involvement of the hippocampus. The second one is the anti-NMDA receptor encephalitis. Again, MRI normal in 50 to 80% of the cases. When abnormal, we will see T2 and flare abnormalities involving wide areas. It can be in the cortex, the brainstem, the subcortical areas, the insular region, and white matter lesions. The anti-LGI encephalitis will present with mesial temporal hyperintensity. It can progress to mesial temporal sclerosis. And the MOG variety presents with ADEM-like presentation where there are multifocal involvement involving both the cortex and the subcortical region and diffuse white matter involvement. Next is the EEG. The EEG finding most common is diffuse or focal background slowing. We can see epileptiform discharges and non-convulsive status epilepticus. Most characteristic is the extreme delta brushes. EEG abnormality is seen in up to 80 to 90% of the cases. It appears very early, so it is very sensitive, even more than MRI, early in the course of the disease. However, again, a normal EEG does not exclude autoimmune encephalitis. What are extreme delta brushes? These are the delta waves on which there are superimposed beta activity. Again, they are uncommon, but if present, they are pathognomic of anti-NMDA receptor encephalitis, and it correlates with severe clinical course. Lumbar puncture, CSF will show evidence of neuroinflammation in the form of pleocytosis, increased CSF protein, oligoclonal bland, elevated IgG index, and the presence of autoantibodies. LP also helps us to exclude the other infectious causes. Last is the autoantibody testing. So in pediatric patient, the NMDR constitutes about 50% of the detected antibodies, followed by MOG, which is 35%, and the rest of the antibodies constitute about 15%. So together, anti-NMDR receptor and MOG antibodies represent 85% of the antibodies in children. Antibody testing should ideally be done in both CSF and serum to avoid false positive and false negative results. However, the preferred sample for NMDA receptor is the CSF. If there is a CSF anti-NMDA receptor positivity, then we may not need any other signs of neuroinflammation to diagnose NMDA receptor encephalitis. For GAD, again, it is CSF. For GABA, both serum and CSF is required, whereas LGI and Caspar-2 can be detected in serum. MOG also serum. Again, negative antibodies do not exclude autoimmune encephalitis. Most of the other tests that we do are to exclude other causes, which includes the blood test like the complete blood count, ESR and CRP to look for inflammation, vitamin B12, vitamin D level, serum lactate for metabolic acidosis, thyroid profile test for Hashimoto's encephalitis, serological testing for infectious causes depending upon the clinical picture and the epidemiology, ANA, DSDN and anti-Smith if clinically indicated, serum complement and IgG level if there is personal or family history of autoimmunity or immune deficiency. Because toxic drugs can also mimic autoimmune encephalitis, a urine test for drugs, and look for viral PCR in CSF, nasopharyngeal swab for respiratory virus, and mycoplasma PCR. So this is how we go ahead. A clinical suspicion, followed by MRI, EEG, LP, exclude infection, go ahead with antibody testing, in older children tumor screening, and finally the treatment. So the take-home message, infectious encephalitis are pathogen-mediated injury where there is direct invasion of the pathogen into the brain. ITS are cytokine-mediated injury. Autoimmune encephalitis is autoantibodies directed against the CNS antigens. The red flags consist of a polysyndromic, polysymptomatic symptoms, consist of psychosis, seizures, dyskinesia and dysautonomia, along with encephalopathy. MRI can be normal. Antibody negative autoimmune encephalitis exists, and do not wait for antibody results before treatment. Thank you.
Thank you, Dr. Agarwal, for your nice description about this difficult subject. Especially in children, it is very difficult to diagnose, although the incidence is less. And below 1 year, this psychotic behavior is really, we cannot understand. So the diagnosis is also difficult. And autoantibodies are also very difficult to detect in children. Thank you so much.
Thank you, ma'am.
So please, wait, 1 or 2 questions can be invited from the audience.
Madam, I have a question. I think for detection of the autoimmune encephalitis, PET CT scan is also very much important tool. Because I have also seen a patient that was admitted in our department. As PET CT scan is available in our institute at free of cost. So the patient was a female, young female, and we thought that possibly it may be, and there is some psychiatric manifestations along with encephalopathic stage. Initially we thought that possibly it was a herpes simplex encephalitis, but all the parameters and the biomarkers are negative. Then think of possibly, and the other like NMDR and all the autoantibodies panel also negative. And the MRI was done twice, it was quite normal. So then we send this done PET CT scan, and the PET CT scan report shows that there is a parieto-occipital hypometabolism and there is a hypermetabolism in the frontal and amygdala region. So we considering all this, and the literature has shown that if the MR negative, the PET CT scan will give 94% sensitivity of this autoimmune encephalitis. So we have started these patients with IVIG,
Sir, you
and
have
the patient
answered
is now
both the
good.
question. It is available in your institute and it is free of cost. Most of the places it is not available and it is not free of cost. So we cannot recommend it as a routine procedure for all children. Clinical symptoms is the first thing, and what is more commonly available. Yes, there are guidelines which say that PECT and SPECT can be done if everything else is negative, but that is not available everywhere and definitely not free of cost in most of the places. Therefore, I have not written it as a routine investigation or routine suggestion.
Thank you.
There is a stress on the cognitive decline, the cognitive part of the patient. So even in HSB encephalitis, there is substantial involvement of the cognition part. So, and lesser the age of the child, the lesser we tend to think about this entity. So my question is, in those circumstances which are quite common, we find in our wards, the simultaneous possibilities of HSB and autoimmune encephalitis. Is the first question is there any particular anatomical involvement of autoimmune encephalitis in neuroimaging?
So,
also clinically.
So as the time is short, so the discussions will be done after in the dais. Thank you. So our next speaker is Dr. Jayashankar Kaushik. Recently, he is an additional professor and head of the Department of Pediatrics, AIIMS Guwahati. And he is an author of book on approach to pediatric neurology and got V.V. Raju Endowment Award in Pedicon 2018. And his publications is about 120 publications in different index international and national journals. Sir, Dr. Kaushik, you start your...
Thank you very much, sir. Good afternoon, everyone.
I'm sure all of us are quite hungry, and I'll not take more than 10 minutes to finish, because Guillain-Barré syndrome is something which every one of us are quite familiar, that it is quite a rare but a potentially life-threatening immune-mediated polyradiculoneuropathy, and the diagnosis is predominantly relying on the combination of the clinical features with the support of electrodiagnostic and laboratory features which are there. And we are all aware that boys are more affected as compared to the female, although all age group, right from infancy, it can start up to an elderly population. So all age groups are primarily affected. And we are also all aware that, the common triggers include the Campylobacter, Mycoplasma. These are the two most common triggers, but there are various other triggers, including the vaccinations, which are also important. And we are also very familiar with the immune pathology behind the entire Guillain-Barré syndrome, that the immune system aberrantly disrupts the function and the structure of that peripheral nervous system. So it is quite uncertain whether it is actually a pure inflammatory neuropathy or not, because it's uncertain whether the GBS is actually truly autoinflammatory in condition rather than an autoimmune condition. One of the classical feature that we see in the pathology is a mixed axonal demyelinating equivocal or normal NCS findings are quite frequent, and it suggests a complex electrophysiological involvement. Now, but one of the underlying thing that we commonly see is endoperineural and subperineural edema, inflammatory infiltrates are also seen, and axonal changes and demyelination. So we are all familiar that it can be demyelinating, it can be axonal kind of a Guillain-Barré syndrome. To just sum up, when should we definitely think whenever a child presents with GBS? Whenever a child presents to us with a progressive involvement, less than 4 weeks, weakness of arms and the legs, that's a very important point. Areflexia or hyporeflexia is another very important point when we have to think of Guillain-Barré syndrome. Majority of the Guillain-Barré syndromes are usually symmetrical. They usually have mild or absent sensory symptoms. Cranial nerve involvement may or may not be there. Autonomic dysfunction may or may not be there. Respiratory involvement may or may not be there. But pain is one of the very, very important symptom which is often we tend to see in children with Guillain-Barré syndrome, and the nerve conduction studies might suggest a polyneuropathy, either axonal demyelinating or a mixed type of this thing, and the CSF might show the albuminocytological dissociation. So the point that I wanted to emphasize is that whenever we have progressive symmetrical weakness of the arms and the legs of a duration less than 4 weeks, we definitely think of GBS. When we should not be thinking of GBS, whenever the child is presenting to you with an asymmetrical weakness. That's a very classical presentation of poliomyelitis. Predominantly sensory symptoms, only respiratory symptom, no limb weakness. Again, we are not going to think of GBS. Similarly, if we are going to get a very, very clear-cut hyperreflexia, upper motor neuron signs, which are very predominant, I am not going to think of GBS in the first go. Predominant bladder and bowel dysfunction. It's a general teaching that whenever a child presents to you with a bladder retention, first think of transverse myelitis, think of a cord pathology before thinking of Guillain-Barré syndrome as a possibility. Similarly, if the child is having symptoms like abdominal pain, altered sensorium, nystagmus, these are some of the symptoms that do not go with Guillain-Barré syndrome. Similarly, when we do a CSF and the CSF pleocytosis is there, that means more than 50 cells in the CSF, very unlikely that we are probably dealing with the GBS. So at least we should be very clear when to think and when not to think of it. And one of the most important point that we need to keep in our mind is that if the child is worsening not after 24 hours, whatever was happened, the child has achieved, and there is a, the child is obviously not deteriorating after 2 to 4 weeks, or there is a deterioration beyond 4 weeks also. These are some of the important points which do not suggest a Guillain-Barré syndrome. Two important points that we just need to remember in our practice is that Guillain-Barré variant, whenever we have an electrophysiology which is suggestive of a polyneuropathy, but the clinical weakness is not like a symmetrical upper limb and lower limb weakness, but it is only involving lower limb. So it could be paraparetic, it could be a pharyngocervical brachial variant, PCB variant, or it could be just a bifacial weakness with the limb paresthesia, or it could be pure. So that means none of these clinical patterns, but these are the clinical pattern, but the electrophysiology is suggestive of a polyneuropathy. We should think of Guillain-Barré syndrome variants which are primarily there. But one of the important thing that you and me are aware is about the Miller-Fisher syndrome. The typical Miller-Fisher syndromes will have a classical triad of ophthalmoplegia, ataxia and areflexia, but all the three criteria need not be there, and we are all aware that GQ1B antibodies are very sensitive for almost 80% of patients to be diagnosed with Miller-Fisher syndrome, and majority of the MFS will also have albuminocytological dissociation. If less than 3 criteria are there, we call it like an incomplete Miller-Fisher syndrome. But if there is a Miller-Fisher like syndrome and the child also has a limb weakness, we often very commonly think in lines of GBS, MFS overlap with a motor sensory GBS. So these are two important entities that I wanted to highlight. There are 2 more entities that we need to remember in our clinical practice. Whenever the child is having a progression to the nadir of the weakness within the 8 weeks, that means very slowly progressing, or the child is progressing beyond 8 weeks, or if there are more than 3 or more treatment related fluctuation, that means the child improved, again deteriorated, again improved, again deteriorated. So if there are more than 3 such type of TRFs that are happening, please do think of acute onset CIDP. That should never be missed. Otherwise we always keep thinking that it is GBS only. Similarly, there is second entity that we should never miss in our practice, that is the Bickerstaff brainstem encephalitis. It otherwise behaves like MFS, but one of the classical feature that we tend to see is altered sensorium, presence of pyramidal signs, CSF showing pleocytosis, MRI showing white matter changes, especially in the brainstem areas where you can very clearly see that you can have brainstem involvement which is there. Please think of Bickerstaff brainstem encephalitis. So GBS, MFS like presentation but altered sensorium, MRI showing brainstem changes, think of brainstem, Bickerstaff brainstem encephalitis. One of the important entities that in our clinical practice that we should never forget is the presence of nodopathy. Whenever you are treating a child with a severe GBS, progressive GBS, you gave IVIG, you gave Plex, the things are just not working, please do test for the nodal paranodal antibodies. You are probably dealing with a nodopathy, and this is the patient who is going to probably respond to the steroids and rituximab. So please remember, otherwise steroids have absolutely no role in Guillain-Barré syndrome. So this is a beautiful article from the European Academy of the Neurology which gives you a summary of when to think of the variants. I wanted to just highlight that it could be a motor sensory GBS, it could be a motor GBS, it could be GBS variants that I told you, it could be Miller-Fisher, it could be Bickerstaff, or it could be an acute onset of CIDP. It's a beautiful article that will give you a lot of clarity on how and when we should think of Miller-Fisher and when we should think of the other variants of the Guillain-Barré syndrome. So this is just a summary of what are the clinical types of it. It could be motor sensory, it could be motor GBS, it could be only paraparetic GBS, it could be a PCB variant, it could be bilateral facial weakness variant, it could be only a sensory variant, it could be a Miller-Fisher variant, or it could be a brainstem Bickerstaff brainstem encephalitis. So these are the common variants of Guillain-Barré syndrome that we will tend to encounter in the practice. Now, one of the classical story of the GBS is that majority of the children with the GBS will be following the infection, they will have a progression, then they will achieve a plateau, and following the plateau they will start recovering, and gradually if the GBS was very severe, the disability will somewhat tend to remain. So this is the general course of the Guillain-Barré syndrome that we tend to see, and you and me are also aware that when we do a nerve conduction study, the 2 commonest patterns that we see is demyelinating pattern, which is AIDP, or it could be a motor variant which is AMAN, that is, or it could be a motor as well as sensory variant, that is AMSAN. frankly speaking, they have no implication on the treatment, but when should we think? From our clinical practice, we need to remember that whenever a child is AIDP, majority of these children will have more of cranial nerve involvement, they will have more of sensory involvement, they will have more of pain. That's very, very important. Pain is a very, very classical feature of both Aman and AIDP, but AIDP, the pain of radicular pain will be very, very classical. And one of the important signs that I keep telling the residents is please do the straight leg raising test. If the child is wincing on the pain, you're probably dealing with a GBS and you're not probably dealing with the other entities like transverse myelitis. There are multiple outcome measures that are objective ways to measure, which include IGRACE, modified IGRACE, IGRACE kids, EGOS, but one of the most common variant that we tend to use in clinical practice is GBS disability score. These are some of the disability scores or the outcome scores which are usually very, very important whenever a patient comes to you, because majority of the treatment decisions are based on this type of an entity. Now, how to investigate a child? You and me are quite aware that CSF shows a classical albuminocytological dissociation, but please remember in the first week this might not be seen. So if the child is within the first week of the illness, it's quite possible that the CSF albuminocytological dissociation might not be seen. Again, take it with a pinch of the salt if the CSF is showing pleocytosis. If the CSF is showing more than 50 cell, probably you're not dealing with the GBS like an entity. Please think of an alternate diagnosis. That's one of the reasons why we often do CSF in the second week, especially when the child is not responding. Only in ambiguous cases we tend to do CSF studies. Similarly, in the antibody testing, I am making it very, very clear, routine testing for serum antibody against ganglioside, not at all recommended, but yes, two things that are very useful, MFS-like variant, GQ1B antibody testing, very useful. Severe GBS, persistent GBS, not responding to your immunotherapy plex, always think on test for nodal, paranodal antibodies. Please remember this is very, very important because this will have a major treatment implication, because you will have to give steroids or rituximab to these patients who are there. So the two important messages for antibody testing is related to MFS and severe GBS, otherwise not responding. Imaging always takes a second step. If you are very classically thinking in terms of GBS, the neuropathy, the electrophysiology has shown that it is a neuropathy, then imaging has a very, very supplementary role only. One of the imaging finding that is usually often seen is the contrast enhancement that can be seen, but majority of the time you and me often get an MRI spine to rule out transverse myelitis rather than trying to prove that it is a GBS per se. Now, electrophysiology remains the most important, that is nerve conduction study, that's the most important, but one of the important point that we need to remember, whether it is AIDP, AMAN or AMSON, is usually not very, very helpful. The differentiation between them, when we were PG, we were always taught it is AMAN, it is AMSON, it is, AIDP. And it's a general teaching that AIDP children will respond much better, AMAN children will respond quite bad. This is a general teaching, but the treatment implication, disability scoring right now is often not very much related to the electrophysiological findings which are there. And when it comes to the treatment, we need to importantly highlight and we need to remember that IGRACE score at the presentation, presence of the risk factors, presence of the clinical assessment. This is a very beautiful article that has been published in the European Academy of the Neurology. Please do refer to this article. This is a beautiful article that gives you a lot of clarity on how you should be managing children with GBS, especially when there is a high risk patient. Then you take the child to the monitoring assessment in the ICU itself. If the child is in moderate risk or in the low risk, you are only monitoring these patients and then you are taking the decision for the treatment. Now, when it comes to the treatment of the Guillain-Barré syndrome, the same article beautifully maintains that if the patient has presented to you within 2 weeks from the onset of the illness and the child is unable to walk, or the child is able to walk but is rapidly deteriorating. This is the patient where you need to start the child on immunotherapy, IVIG, or 4 to 5 cycles of plasma exchange. But if the child has presented within 2 weeks and the child is otherwise still able to walk, there was an initial thought that कि ऐसे ambulatory patients को आपको treat करने की ज़रूरत नहीं है. But this guideline very clearly says that you can consider 2 cycles of plasma exchange therapy in these patients, but IVIG is often not indicated. But if many of the time you and me will agree that many of these patients come late to us, if they are going to present within 2 to 4 weeks from the onset of the illness and the child is still able to walk, that is 2 to 4 weeks, late presentation, still able to walk, no indication for immunotherapy. Late presentation, but the child has a disability, please do consider immunotherapy. So I would strongly urge the audience to please go through this article. It beautifully, very clearly highlights on how you should be doing the assessment and how you should be treating these patients. 3 important things that we need to remember. Should you give IVIG? Should you give plasma exchange? The answer is very, very clear. There is no significant difference between IVIG or plasma exchange, and all of us will agree that giving IVIG is much more easier because it is an injectable medication that we need to give it. Plasma exchange, the facility may or may not be there. Now the next question that comes to you is, should I give a second dose of IVIG if the child has not responded to the first IVIG? The answer is now very, very clear that in 1 to 2 weeks the child has not responded. If you have treated the child with IVIG, a second course of IVIG will often induce only some amount of side effects rather than any improvement. So there is no role of second course of an IVIG. The third doubt that comes to our mind, I gave IVIG, the child is not improving, can I do PLEX? I gave PLEX, the child is not improving, can I do IVIG? Please, there is absolutely no role of IVIG followed by PLEX or PLEX followed by IVIG. None of them have shown any kind of an evidence which is there. One of the upcoming method that many of the people have used is zipper method, in which zipper method, alternating cycles of plasma exchange immediately followed by IVIG, both repeated alternatively 5 times. Many of the authors have shown some type of good benefit with this thing. But please remember about the treatment related fluctuation, TRFs should be documented. Please remember, if the patient is otherwise improving, again deteriorating, within 8 weeks you call it as TRF. If the same thing is happening after 8 weeks, think of an acute onset of a CIDP. Now, please do not forget the management of autonomic dysfunction. Do not forget the management of the pain. Gabapentines are the drug of the choice for pain. If the things are not improving, don't hesitate to give the tricyclic antidepressants. But at the same time, I want to make it very clear that GBS has absolutely no role for corticosteroid and other biological agents which are listed. Please do initiate a good physiotherapy, initiate speech, swallowing, occupational therapy. It's very important that it's a comprehensive management. You alone as a pediatrician and as a neurologist are not able to manage these patients. You often need lot of supportive therapy which is primarily there. So the key summary points with these small presentation I wanted to make is that please think of GBS whenever a child presents to you with symmetrical weakness of both upper limb and lower limb, but the duration or the progression is less than 4 weeks. Beyond 4 weeks, none of the GBS will deteriorate. Whenever the GBS is usually of multiple variants, we saw that it could be motor sensory GBS, it could be motor GBS, it could be a GBS variant, in which electrophysiology will be suggestive of GBS, but the clinical presentation is only paraparetic, pure sensory, only these things are there. Or it could be an MFS spectrum. Do not forget MFS GBS overlap. Very, very commonly you see in your practice. Please do not forget acute onset of CIDP. That should be always considered whenever you have more than 3 treatment related fluctuations. Never ever forget nodopathies. Even if you forget everything in GBS, please at least take home this important message that if the child is not improving to your classical treatment of IVIG and plex therapy, and the child is don't keep thinking of second dose of IVIG and plex and all. Rather, you should now, this is the time where you should be testing for antibody. If antibody is positive, please do consider corticosteroids. Many of these children will often require rituximab also. So treatment with IVIG or plex is equally good. There is absolutely no role of second dose of IVIG. Please think of nodopathy whenever there is severe and no response to IVIG. Think of acute onset of CIDP whenever there is a progression beyond 8 weeks or more than 3 treatment related fluctuations are happening, because again acute onset CIDP, it is steroids, that's the treatment of the choice. Otherwise GBS has absolutely no role of steroids here. Please do not forget to treat the pain, analgesics and autonomic dysfunction, and please remember that autonomic dysfunctions need to be treated only if it is persistent, otherwise do not treat these things. So with these words I thank the organizers for inviting me, and I bring my greetings from AIMS Guwahati, where we have developed in the northeast area the entire comprehensive center, where we have the entire team of child psychiatrists, pediatric neurologists, developmental pediatrician, child psychiatrists. So, and all my residents, all of them have been the great supporting pillar, and we are able to give all the treatment to all these patients free of cost, because we have incorporated majority of all the government schemes which are there. So this is the first type of northeast related neurological center which is very comprehensive and gives a full treatment choice. So I thank once again the organizers for the opportunity.
Thank you, Dr. Kaushik. You have nicely covered this very, important disease condition. We as pediatricians, we treated lot of cases of this Guillain-Barré syndrome, but in our time, actually, we had to depend mostly on the clinical.
Yes, ma'am.
And the question was whether to start IVIG or not.
Yes, ma'am.
And the patient party, mostly they couldn't buy also.
Yes, ma'am.
So I got very good recapitulation of my knowledge along with many addition of fresh knowledge. Thank you very much.
Thank you so much. Thank you. Sorry I ate your lunchtime.
I can invite only one question because we are already learning late. Any question?
Yeah. Can somebody give him mic, please?
So recently we had a patient of nodopathy 140. So when you say how long you have to wait after IVIG to say it's not working?
Sir, generally the working principle is 2 weeks. This is generally the dictum. If that's the reason why I wanted to emphasize, please use this MGRIS. Even I did not use it, but objective scoring really makes a lot of difference when we start monitoring them on an objective scores. In 2 weeks is the good time when we decide that yes, this is the time when we send antibodies. There was a time when I was a postgraduate where we used to start thinking of second dose of IVIG. This is the time where now we send antibodies now.
No point second dose IVIG directly.
No point of IVIG. Rather, many people have reported that it is more of side effects. So I think I learned this way.
Thank you.
Yes, sir. Yes, sir.
We start either plex. Plex is also very much helpful for nodopathy rather
yes,
than
sir,
IVIG.
yes, sir.
Or we don't use prednisolone, rather we use
Ritux.
Yeah,
I agree. That's the reason why I mentioned both methylpredni and Ritux, because many people have different experiences of methylpredni and Ritux, both of them.
Okay, thank you.
Thank you so much. Thank you.
Next program is management of autoimmune encephalitis, which is very important, encephalopathies. So it's a very important and a big session. Now the moderator is Dr. Pradeep Paria. I request him to please come to the dais, and he is now Assistant Professor of Pediatrics in Raiganj Government Medical College, and his affiliations are Institute of Neurosciences, Kolkata, and his achievements, research-led infantile epilepsy. His publications at this age, already he has done 50 in national and international journals and 12 book chapters. So we are very proud of Pradeep. We have seen him in student life. Now he is in this position. Very nice to see.
Thank you.
Okay.
Thank you.
Carry on.
We will also like to invite the panelist, Dr. Sumon Das. Where is Sumon? He is now as an assistant professor of North Bengal Medical College. His publications are more than 50. And he is also, when I was a National Medical College, he was a DM resident of there. And Dr. Anup Kumar, Dr. Subhashish Bhattacharya, Dr. Supratim Datto, Dr. Supratim Datto now is attached at KPC Medical College. Previously he was ex-professor and HOD Pediatrics IPGMR. And he had more than 35 national and international publications. And Dr. Maloy Sinha, now he is at Kolkata, HOD Kolkata Medical College. SSKM, oh, now he is at SSKM, sorry. And next, Dr. Charlene Martin. She is a senior resident of pediatrics, member of IAP since 2023. He had one publication in national and one publication in international journal.
Good afternoon, everyone. My respected chairpersons, all the delegates. We will discuss regarding the management of autoimmune encephalitis. Actually, some of the questions are overlapping with the previous lecture by Ekta ma'am. I will the first question just overlap with the previous lecture. So, our objective is to identify your introduction to autoimmune encephalitis and answer specific queries on the presentation, diagnosis and treatment of anti-NMDR. We usually divide the encephalitis or encephalopathy into encephalopathy, that is the clinical syndrome of altered mental status, manifest as reduced consciousness or altered behavior. And what is encephalitis? Encephalitis is the one form of encephalopathy, but there is an inflammation of the brain, and it is strictly a pathologic diagnosis. And acute encephalitic syndrome is a person of any age or at any time of year with acute onset of fever, a change in mental status and or new onset of seizure, excluding the simple febrile seizure. So, we all know that relatively recently recognized disorder, autoimmune encephalitis, just described in 2007, and that is a serious but treatable immune-mediated neurological syndrome, generation of antibodies targeting synaptic proteins. In autoimmune encephalitis syndrome, mostly in childhood age group, we are usually going through the anti-NMDR antibody encephalitis. In adult age group, there is limbic encephalitis, anti-GAD, and obviously MOGAD, that is acute disseminated encephalomyelitis, also a variety of autoimmune encephalitis syndrome. Some rare disorders are there, like Hashimoto, like opsoclonus mycloris, or Rasmussen's encephalitis, and some conditions are there with presumed inflammatory basis but no proven autoimmunity, like fires, like HAE, hemiplegia, hemiconvulsion, epilepsy, and new onset refractory status epilepticus. In autoimmune encephalitis, mainly in NMDR encephalitis, there is the disruption or dysregulation of the NMDA receptor, that is internalization of the NMDA receptor and hypofunction of the NMDA receptor leads to the specific symptoms. Usually that is a idiopathic one. In adult age group, the underlying tumor may be there, but in children there are incidence of tumor is less than 5%. And some infectious trigger like mycoplasma, JE, enterovirus or H. influenzae or HSV is a known trigger for autoimmune encephalitis. We all know that some cell surface antibody and some intracellular antibody is there, and the response to immune therapy is better in cases of cell surface antibody, but rather than the intracellular antibody. So we will discuss one case only, not the 6 cases. 11-year-old girl presented with acute onset neuropsychiatric symptom, and obviously they landed to child psychology department with stress reaction or depression. There is a low feeling, insomnia, withdrawal, mutism and emotional lability. But child psychologist, as she is a 11-year-old girl, referred to us due to the refractory symptom, and she later developed motor slowings, subtle stereotypic hand movement. We see there is some sorts of myoclonic jerk, rigidity, dystonia, hypoventilation requiring intubation, and there is autonomic dysfunction, and we shift the child to PICU. So, the first question to Dr. Shuman, what is your possibility in this case?
Hello. If this constellation of symptoms are present, they are presented in a hyperacute fashion, then I would go for the infectious cause, like those who are affecting the temporal lobe, like more commonly HSV, or neurometabolic like porphyrias. If it is acute to subacute presentation, then I will go for the autoimmune encephalitis. I would go for Wilson disease and other demyelinating like MOGAD. If it is in a chronic form or a recurrently relapsing form, then I will go for PANDAS, then and SSP.
Okay. Actually, in these cases, in autoimmune encephalitis form, there may be infection, as already Dr. Shumon had told. There are some sorts of, in childhood age group, some sorts of metabolic disorder may be there. Like, I have already told that Wilson disease may be there, maybe glutaric aciduria, maybe organic acidemia group, maybe urea cycle disorder may be a cause. And in childhood age group, malignancy or paraneoplastic is a less possibility. And ictal form, that is the epilepsy, non-convulsive status or EACS may be also a possibility in these cases. So, to Subhasis sir, when you suspect it may be an autoimmune encephalitis over infection or genetic metabolic cause, as in childhood age group, that is always a possibility that the genetic metabolic cause may landed up with these symptoms.
Yes. So diagnosing autoimmune encephalitis is not that much easy. As a clinician, we face a lot of problem initially to find out or to diagnose this condition. But there are some catch point. What are those catch point? Is a polysymptomatic. This presented with lot of symptoms, not only the seizure or mental retardation, there is catatonia, movement disorder, dysautonomia, psychosis, so all present together. And there may be precipitating factor, may be infection. But usually this particular condition associated this never comes to a plateau. It increases, the symptom increases. So that is a very important point. Clinically we judge, then go for other investigation like EEG, MRI, they are suggestive in this condition, and CSF examination is also very important to know that antibody present in the CSF, though many of the cases there may not be any antibody, but you should suspect and go for antibody test. But one point is very important regarding some infection, though the infectious cause it can be ruled out before, But some infection like SSP should be ruled out in all cases of acute encephalitis syndrome, because the presentation more or less in this condition may be similar with acute encephalitic syndrome, like this motor CNS convulsion.
Obviously, sir, in our setup, SSP should be excluded.
Yes. So that should be thereby, and rule out the other metabolic cause if you suspect, because metabolic cause actually presentation is rarely acute presentation. This is acute or subacute, but in infectious cause is acutely presented. So that is also there, and metabolic cause is slowly progressing. And another very important, the CSF, when you do CSF, not only antibody, but CSF pleocytosis is a characteristic of infectious condition. But here there may be mild pleocytosis, but usually severe, more pleocyte is not there. And also another oligoconal blend is present in autoimmune encephalitis. And another very important point, many of these autoimmune encephalitis associated with fever, but rash is very uncommon, where by infectious causes there is not only fever. Fever is a very important presentation along with the rash, which is usually uncommon in acute autoimmune encephalitis.
Okay, sir. Actually, in pediatric age group, some criteria is there. By Seleucid T in 2022, they have divided into possible, probable and definite antibody positive autoimmune encephalitis. So some pages are there, some viral prodrome followed by psychiatric symptom, neurological symptom, and also the residual prolonged deficit. So what is the features that point away from AIE, that is autoimmune encephalitis, that a very chronic or indolent course, plateauing of the symptom, no impairment in activities of daily living, cognition is intact, and purely psychiatric symptom. Yeah, we can exclude that that may be not a cause of autoimmune encephalitis. So regarding epidemiology, there is a 2.2 million children per year, and children under 18 years of age account for nearly 40% of the patient. So question to Dr. Salim. What may be the psychiatric feature, as most of the autoimmune encephalitis in childhood age group is presented with neurological plus psychiatric symptom and some sorts of movement disorder. So what may be the psychiatric feature in autoimmune encephalitis, and how will you differentiate from primary psychosis?
For older children and teenagers, there are prominent psychiatric symptoms which consist of rapidly progressive anxiety, mood lability, hallucination, delusion, disorganized thought. There can be aggressive behavior, insomnia, and sleep changes. In case of autoimmune encephalitis, within a few days or weeks, there will be additional symptoms, like there will be reducing consciousness, or choreotheatoid movement, or oral and limbal dyskinesia. And another very important feature is we will see autonomic instability. Hypertension, hypotension, bradycardia, tachycardia, hypoventilation. In primarily psychiatric causes, there will be no such association.
Actually, with psychiatric manifestation, if there is neurological manifestation, seizure, movement disorder, autonomic dysfunction, and dystonia, that usually indicate that the child is suffering from autoimmune encephalitis, not a primary psychotic disorder. So, next question to Molloy sir. What may be the different movement abnormalities in cases of autoimmune encephalitis?
Different movement abnormalities are considered as very important feature of autoimmune encephalitis. Lots of movement disorders are usually observed, like orofacial dyskinesia, very common in NMDR encephalitis. It manifests in the form of facial grimacing, lip smacking, facial twitching, tongue thrusting, jaw opening, closing, like this. And other forms of movement disorders like chorea, athetosis, combination of chorea and choreoathetosis, and myoclonus, sometimes tremor is also observed. Not only that, also there is some hypokinetic disorders like bradykinesia and catatonia. And there is a definite correlation between the type of movement disorder and the antibodies found in either serum or CSF. For example, this orofacial dyskinesia and dystonia, Parkinson-like features, these are observed in NMDR encephalitis. On the other hand, other antibodies like dopamine 2 receptor antibodies, also there is dystonia and rigidity. In Casper antibody, there is also ataxia and tremor. In mGlu-R antibody, there is chorea and dystonia. And there is a definite correlation between these movement disorders and the respective antibodies, specific antibodies found in either CSF or serum.
Okay, sir. Actually, we are usually go through the three type of autoimmune encephalitis form, that is NMDR, MOGAD, and also GABA. NMDR usually presented with orofacial dyskinesia, MOGAD may be present with basal ganglia involvement with dystonia and chorea, and GABA presented with generalized seizure and stiffness. That is the most common in pediatric age group, GABA, MOGAD, and NMDR. So next question to Supratim sir. Is there any difference in presentation between children and adults? What clinical phenotypes makes you think of specific antibodies?
The autoimmune encephalitis, it's a polysymptomatic disorder, constellation of psychiatric behavioral abnormality, movement disorder, seizure manifestation, as well as the dysautonomy. So all these things are present both in adult and children, but certain features predominant in adult and certain in pediatric age group. The adult, the psychiatric manifestation is the usual presentation, whereas in pediatric age group, the seizure and movement disorder is usually the presenting manifestation. Dysautonomia can occur in both the situation, but the dysautonomia is usually severe in adult, whereas dysautonomia is less severe or mild in nature, only tachybrady or fluctuation of the blood pressure, whereas the central hypoventilation needing intensive care, the ventilation, as well as the dangerous arrhythmia, these are all common in adult age group. And as already Pradeep, you have already said that the tumor association, there is a difference between the adult and the pediatric age group. The 40-50% of the adult patients, they are associated with tumor, whereas in pediatric age group, this is very, very less. Less than 12 years, practically the incidence of tumor association is less than 5% or something like that. So these are the differences between the pediatric and the adult. And the antibody, presence of antibody and the clinical feature, the association, the NMDR, basically NMDR antibody is there, and this is polysymptomatic. The behavioral problem, the movement disorder, the seizure manifestation, autonomic disturbances, all are present, either in sequentially or adding one after another. But the presence of the certain antibodies, the presenting feature can be different. For example, the anti-LGI1 antibody, Casper antibody, as well as the internuclear antibody, they present usually the limbic syndrome, the limbic encephalitis, the mood changes, the cognition difficulty, the seizure, these are the usual manifestations. And another is the stiff person syndrome or the rigidity myoclonus. They happen in the glycine receptor antibody as well as the GAT65 antibodies. The dopamine 2 receptor, they usually present with the basal ganglia manifestation, and the GABA A receptor antibody, they usually manifest either with the refractory epilepsy or refractory status epilepticus. So these are the correlation between the presence of antibody and the clinical manifestation.
Okay, sir. Actually, usually we go through the neurologic and psychiatric symptom in NMDR. And limbic encephalitis is more common in adult population. I have seen only one AMPA cases in my life, only one AMPA cases. And probably AMPA cases is not there, described in childhood age group in literature also. I have just searched 2 months prior, but no AMPA cases is related to childhood age group. So, how will you investigate, sir? Anup sir.
Hello. I agree with Supratim sir. The child is not a small adult. So guidelines cannot be same for both the children and adults. So we start with the clinical suspicion and we look at the history, what history the child is giving. And if there is acute or subacute onset of altered behavior, seizures, movement disorders, psychiatric symptoms, and if we we rule out the common mimics with the help of blood, CSF. In CSF, we used to do the routine investigation along with the viral markers, oligoclonal band, IgG index, and other autoantibodies. If we are getting other autoantibodies, so that will be the confirmatory to autoimmune encephalitis. And along with this, MRI is very helpful in the diagnosis of the autoimmune encephalitis, especially in NMDR encephalitis, where we got the temporal lobe predisposition along with the limbic region involvement. And on doing the EEG, if we get the delta brushes, which are very much correlated with the severity of the disorder, then it is very much suggestive of the autoimmune encephalitis nature. And ultimately the autoimmune antibody testing, which is very much important. It is not like that if we are not getting the antibodies positive, so there is no autoimmune encephalitis. But if we are getting the antibodies positive, so that can lead to the specific diagnosis, and we can institute the urgent treatment accordingly.
Actually, we usually go through the basic blood test, one MRI, one EEG, CSF study for CSF autoantibody panel, and if possible, ANA, HEP2 and anti-TPO. That is the basic investigation we usually go for the diagnosis of autoimmune encephalitis. So, question to Dr. Shuman, how much should we rely on antibody panel? And what should be tested, CSF versus serum? What if there is false positive and false negative result? And should CSF be repeated if first time is negative?
For the diagnosis of autoimmune encephalitis, it is always prudent to test both CSF and serum, because the sensitivity of the autoimmune antibodies differ from CSF and serum. In case of NMDA receptor encephalitis, the CSF sensitivity is about 80%, but the serum sensitivity is only 50%. So, since there is a wide gap in the sensitivity of CSF and serum, it is always advisable to test both. Now, in certain autoimmune encephalitis, the sensitivity is more in serum, like that of MOGAD. Here in MOGAD, the serum sensitivity is much higher than the CSF sensitivity. Now, the second question is that about the false positive and the false negative. Now, first I come to the false negative results. False negative results, that is, the patient is suffering from autoimmune encephalitis, yet the antibody titers are negative. It can occur in certain situations. Number one is that the novel antibodies, those antibodies which have not either been discovered, or those tests for those antibodies, they are not commercially available. Only specific research laboratories may identify those antibodies. So now the first situation is that the antibodies are novel antibodies. Number two, second situation is that the exact test that is being done for the antibody titer, it is usually advisable to do a cell-based assay. But if an ELISA is done, then the chance of false negativity is much higher. Number three is that the patient is having a low titer of antibodies. And number four is that the patient has already been treated with steroids. After that, the sample is being sent. So these are the chances of false negativity. Now I come to false positivity. In suspected cases of autoimmune encephalitis, there is the multiple autoantibodies may come sometimes. So say a patient is positive for 2 or 3 autoantibodies. This is sometimes possible that, especially with GAD65, where say it runs in families. So low titer of GAD65 antibodies may be present in many patients. In that case, where the multiple autoantibodies they come positive, then the clinical correlation of that exact clinical phenotype that is related to that antibody should be considered before the starting of treatment. And the last question was? Should be CSF be repeated the first time if it is negative. It is not advisable to repeat if it is first time if it is negative. If there are specific criteria for the diagnosis of seronegative autoimmune encephalitis, if the patient follows those criteria of seronegative autoimmune encephalitis, it is better to treat the patient. The repetition, the question of repetition comes only when the patient is having a relapsing disease, the patient is having a very refractory disease. In such cases, the titers of antibody may guide the amount or the duration of time over which the immunotherapy should be given. It is better to treat the patient first if the antibody is negative, if the clinical suspicion of seronegative autoimmune encephalitis is high.
Okay. Actually, we usually go for the live cell-based assay, not the ELISA, and not also the fixed cell-based assay. Usually, we go for the live cell-based assay. If the ELISA was done, then go for the live cell-based assay. That may be positive. Next, the principle of treatment is recommendation based on the retrospective series and expert opinion, not any protocol is there. Immunotherapy and removal of the trigger is the key point. And as it is usually a monophagic illness, it usually relapses in 15% of cases. Next question to Subhasis sir, when to start treatment? And if the treatment should be started before antibody panel, what is your first line? And obviously the first line one after another or simultaneously?
Yes, we should start treatment as soon as possible, as there is a ongoing damage to the CNS, brain cells, and the synapses. So we should start as soon as possible. And before that, we should reasonably exclude other conditions. Like already you have mentioned the infectious cause or other cause, you should reasonably rule out, and don't wait for antibody to come. Because many of the situations, this antibody estimation is not available everywhere. And another thing, antibody, some patients, they cannot afford it if it is, you have to do it from outside. And also it takes time to come this antibody report. So before antibody result, we have reasonably excluded other condition, so we should start treatment as soon as possible. Next question.
What will be your first line drug?
The first line drug is always the immunomodulator, like pulse methylprednisolone or IVIG.
Is there any role of oral prednisolone?
There may be role, but pulse methylprednisolone in this condition is hyperacute situation.
If methylprednisolone is not available, we can go for the Dexa pulse and also the oral steroid, but methylprednisolone is the drug and you should go for the methylprednisolone.
Okay. And then another thing is the plasma exchange. You can combine plasma exchange with pulse methylprednisolone or IVIG for better response, or some cases where it's a delayed response, you can add it. What is the third question?
But that is simultaneously or one after another?
Yes. You should be started one already I mentioned and wait for to response. If it is a no response in 2 to 3 weeks, you should go for the second line, but not at the beginning, because beginning we should start all these things and then combine plasma exchange along with it, and subsequently for the second
Obviously,
line.
sir, in last consensus, they have told that we can combine steroid with TP or steroid with IVIG, and we can go for the steroid only after 1 week. If there is no response, just add IVIG or flex. So, next question to Salin, when to start second line? We have completed the first line, but when to start second line?
Second line therapy can be started when there is no significant improvement after giving first line therapy for 2 to 3 weeks. We can start it earlier if there is a rapid progression of the disease. If there is severe disease at presentation, then we can go for second line, or in case of relapse. Second line treatment is given
what is your option? What is your option? Drug option?
Rituximab is started, and cyclophosphamide can be added to it.
Can be added, or we usually do not go
usually
for that?
We don't combine because of the toxicity. We can go for one after two.
Actually, usually we do not combine. There is no evidence to combination is better than single second agent. And there is every possibility of severe toxicity with combining rituximab and cyclophosphamide. Next question to Malloy sir. When to go for further immunotherapy and what is your option? we have given the first line therapy, after that rituximab or cyclophosphamide, but patient is not responding. When to go for the further immunotherapy?
Further immunotherapy or third line, it is called escalation immunotherapy. If there is inadequate clinical response with first line or second line, we'll wait for 2 weeks, not more than 2 weeks, and or with first line or second line, if there is worsening of clinical symptoms, or if the initial presentation is very severe, we can go directly to escalation immunotherapy. We have different classes of drugs like cytokine modulating agents, some plasma cell depleting agents, and some mTOR inhibitors. In the cytokine modulating agents like IL-6 inhibitors, tocilizumab, interleukin-1 receptor antagonist, anakinra, and JAK-STAT inhibitors like tofacitinib, all these things. Plasma cell depleting agents like
Actually,
bortezomib, daratumumab, all these things, and mTOR inhibitors like sirolimus and everolimus. This can be used.
Actually, most evidence tell that the tocilizumab is the drug for the third line one, and we can use the bortezomib also. Our experience regarding the intrathecal methotrexate or intrathecal steroid is less in cases of autoimmune encephalitis in children. So next, the chronic immunosuppression. Though there is an initial adult protocol favored chronic immunosuppression, but in children we do not know, and there is no consensus guideline regarding the chronic immunosuppression. To question to Supratim sir, should you go for the maintenance immunotherapy? When, how many days, and what is your option?
The anti-NMDR encephalitis, this is the commonest one in pediatric age group, and this is a usually very severe one. So after nowadays many centers they are preferring to treat initially with combined therapy, the steroid plus IVIG or steroid plus Plex. The IVIG is better, easy to administer because most of the patients are agitated one. And following this first line therapy, most of the center, they usually, although there is, as you are right, that there is no consensus guideline, but most of the center, they start the oral prednisolone 1 to 2 milligram per kg, and that is usually given for 12 weeks duration and gradually tapered off over a period of 6 to 12 months. But many centers, they follow the different line, the monthly pulse methyl prednisolone or the monthly IVIG also, that is there in many centers protocol. And some centers, following the steroid therapy as a steroid sparing agent, they give either mycophenolate mofetil or azathioprine. And the total duration of therapy is usually 2 years over here. So these are although there is no consensus, but in practice, most of the centers, they give the oral prednisolone, gradually tapering it off over a period of 6
sir.
to
Actually, in that is autoimmune encephalitis is a monophagic one. You usually do not go for the rituximab for next time. But in relapsing cases and high risk cases, you usually go for the rituximab every 6 monthly, or usually measure the CD19 or CD20 level and go for the next rituximab dose. So regarding the tumor screening, frequency of tumor in children less than 12 years and males of all ages is only 6%. And though in adult population tumor incidence is more. So question to Anup sir, when do you go for the tumor screening and how often it should be repeated?
Yeah. Why we want to do the tumor screening? Because the response to the immunotherapy in those patients who are tumor positive is much more than the tumor negative persons. So we should do the routine tumor screening. In case of NMDR receptor and autoimmune encephalitis, in pre-pubertal girl, we should start screening with the pelvic ultrasound. And in adolescent girl, we should start with pelvic ultrasound with MRI pelvis, and every 6 months till up to 2 years. In male, we should do the testicular ultrasound first, and if relapse or poor outcome, then we have to repeat the ultrasound. In GABA, mPOWER MA2, directly you should go for the CT scan, MRI or PET scanning, and we should repeat this screening till 6 to 12 monthly, up to 2 to 4 years.
Okay, sir. Next question to Dr. Shuman. How will you manage a seizure or refractory seizure in cases of autoimmune encephalitis? And the second question should be, how many days ASM, anti-seizure medication should be continued in cases of autoimmune encephalitis after recovering from the primary stage?
Now, the first question, the management of seizure or RSC, it is the consensus Indian guideline should be followed, that first the loading doses of 2 the non-sedative anti-epileptic, then the midazolam infusion. If there is no response, then going to the anesthetic, general anesthetics. If still not controlled, then trial of ketogenic diet can be given. Now, regarding the how many days an ASM should be continued, the answer is that for those patients who are of a one-time disease, they have responded well to the immunotherapy. In that case, the seizure should be treated as an acute symptomatic seizure, and the patient can be tapered off anticonvulsant over a period of 3 months. But in certain situations, it must be remembered that there are a higher chance of recurrences of seizure. Number one, in whom they have been RSC or SRSC. Number two is that in whom the patients are having the severe diffuse or mild diffuse encephalopathy in EEG or persistent epileptiform discharge even after the discharge of the patient from the hospital. And number three is that the patients with intracellular antibodies like the anti-HO, anti-RE, anti-MA, anti-EO, anti-CV2, these intracellular antibodies, they have very high recurrence of seizures as compared to the patients who are having extracellular antibodies. So patients with intracellular antibodies, it is better to continue them for a longer duration. In such cases, up to 2 years duration can be considered. If within these 2 years the patient's EEG normalizes and there has been no more relapses, then they can be stopped.
Actually, immunotherapy is the first choice, and if there is acute symptomatic seizure, go for the 3 to 6 months, and if there is persistent epileptic activity, go for the general rule that is up to 2 years. How will you manage dyskinesia, autonomic instability and psychosis? Question to Subhasis sir.
Because these are the conditions which are associated and sometimes very disturbing and associated a lot of problem in acute autoimmune encephalitis, especially the dyskinesia. But one point of caution regarding management of dyskinesia is that we should not use the drug where this is acting on dopamine receptor, because this may associate a very severe condition,
and that may aggravate the rigidity, dyskinesia, and also there is a possibility of neuroleptic syndrome is there.
So best drug for this dyskinesia are diazepam and diazepam analog like clonazepam, and for autonomic instability, clonidine and this kind of anti hypertensive can be used. For
psychosis,
and for severe orofacial, this painful condition, we can use tramadol as an analgesic, but better we should avoid those drugs like risperidone, haloperidol, because those are associated with a lot of side effects in this condition.
Last 2 to 3 question is there. Question to Sarlene. How will you differentiate between relapse and residual disease and approach to relapse prevention? What is relapse and what is residual disease in cases of NMDR encephalitis?
Relapses after a period of clinical improvement or stabilization, there will be new onset and worsening of neurological and psychiatric symptoms, and this will be attributable to active CNS inflammation. It can be seen in previous relapse or incomplete recovery or when immunotherapy is delayed. And residual disease is persistence of the neurological, cognitive, behavioral or psychiatric deficit remaining after the acute inflammation subsides. The prevention for relapse is early and aggressive immunotherapy and early initiation of rituximab.
Obviously, to go for the early immunotherapy and to screen for the who needs the maintenance immunotherapy in cases of relapse. So, next question to Moloshar. What if the antibody assay is negative?
This entity is seronegative autoimmune encephalitis. And the diagnostic criteria...
Actually, 44% of the patient with suspected autoimmune encephalitis were positive only. Most of the cases are seronegative.
Yeah. Most of the cases are seronegative. So that diagnostic criteria evolved in 2020 that acute or subacute onset within 3 months. Next is some new onset, it's very important, new onset of neurological symptoms or psychiatric symptoms in a previously healthy child.
Actually, in our newer classification, that is probable autoimmune encephalitis is the seronegative one.
Seronegative one.
And in seronegative one, you usually go for the similar type of treatment with IV steroid, IVIG, plaques. If there is no response, then go for the rituximab and cyclophosphamide in cases of seronegative one. So, one question for Supratim sir.
Time is very short.
HSP followed by NMDR, how common and how to treat? Just two questions is there.
The HSV, this is commonly associated with NMDR antibody, and this is said that 50% of the HSV encephalitis is associated with the development of the NMDR antibody in them. And of these, 50% usually go to develop the autoimmune encephalitis later on. And this usually takes within after 2 weeks to 12 weeks of the successful treatment of HSV encephalitis with acyclovir. And even though there is the clinical suspicion of as well as the presence of antibody in favor of NMDR encephalitis, still the CSF should be examined for HSV DNA PCR to rule out the...
If sir, actually if herpes is considered, then go for the acyclovir and treat the in same manner like seropositive autoimmune encephalitis. In 40 to 50% cases, HSV followed by NMDR may be positive. Okay. We will just... in autoimmune encephalitis, we just think about autoimmune encephalitis, early recognition and early treatment. And timely immune therapy is the key of this autoimmune encephalitis management. Thanks the chairperson and thanks our expert panelist. Time is very short, so we have completed just.
Thanks to moderator and all the panelists for this difficult subject which needs further advancement in our knowledge in future we expect. Difficult to diagnose, difficult to treat, and also future improvement in advancement. Okay. Thank you all.
Thank you.
Thank you, sirs and ma'am, for this extensive discussion. We will be marching towards our fourth session, cerebral palsy, autism and ADHD. So I would like to invite the chairperson for this session on stage. We have Dr. Rita Chatterjee, former professor and dean, BCRI Postgraduate Institute of Pediatric Sciences, and we have Dr. Madhumita Bhattacharya, professor of pediatric medicine, Jagannath Institute of Medical Sciences and Hospital, Baj. Ma'am, please come over the stage. Our first session will be on cerebral palsy, medical management of spasticity and comorbidities. Ma'am, I would like to call Dr. Shankar Dungal on stage.
Good afternoon, everybody, and thanks to the organizer for inviting me here. Now, Dr. Shankar Dungal
I request you to start the program, but before you start, I would like to say a few words about cerebral palsy. We are primed with these diseases from the very beginning of our pediatric knowledge, and we knew that it was the major cause of disability in children. And now, after 50 years of so much great, excellent work on prenatal, perinatal, and postnatal care and neonatal care, even it remains the same. It is the thing. And cerebral palsy is also being managed to lots of things are coming up. There is improvement, but the goal is not achieving. So there is a problem in diagnosis and intervention, I think so. And along with that, epilepsy and the intellectual disability and the incapacitating, that spasticity, that what you are going to talk, these problems, if solved, I think it will improve the situation, and it is not preventable, it is not treatable, it curable. It is true, but I don't think it is not treatable, because we have seen the improvement a lot. So this is, with that, I would love to say you start your session, and I would like to introduce you. You are Dr. Shankar Dhungel, and you are the consultant pediatric neurologist, and you have your own center in Patna, and you did your MBBS in Kolkata, MD in PGI Chandigarh, and DM in AIMS, and you have very much achievements in oral paper presentation. You did very well in the DM thesis oral paper. Thank you. Start your session, please.
Good afternoon, respected chairperson. Thank you for the kind words, ma'am. Good afternoon, respected faculties, seniors, and dear colleagues. It's a privilege for me to present in front of this esteemed delegates. So the topic allotted to me was the medical management of spasticity and comorbidities associated with cerebral palsy. As ma'am already told, cerebral palsy is a very common condition, but it is a very complex entity to manage. So I'll begin with these 3 videos. So let us have a look at these videos. So this young child, he has, let us find out what abnormality the child has. So you can see the child has tiptoe walking of left lower limb. There is also some amount of crouchness on right lower limb. Similarly, there is some flexion abnormality present in the both upper limb, but you can see that the involvement of upper limb is less as compared to lower limb. So this was the abnormality. We'll discuss about the categorization. The second video, you can see this young child. You can see the abnormality. There is abnormal twisting, posturing involving both upper limb, lower limb, trunk, even cervical, mandibular region. So this is another condition. Now let us look at the third one. Now you see this one. So here the child has, you can notice that there is again plantar flexion of right lower limb. There is some amount of circumduction, not very apparent, and you can also notice there is paucity of movement. While he was walking, there is paucity movement of right side compared to left side. So with this videos in the background, so first 2 to 3 slides I'll discuss about the basic of cerebral palsy. So this was the first classification which was given by Miner et al. Back in 1956, where he has classified cerebral palsy on various axes, that is physiological, topographic, supplemental, etiologic, neuroanatomic, therapeutic, and functional. But over the period of time, the goal in cerebral palsy is to improve the quality of life and to address whatever the functional impairment the child has and to improve the functionality of the child. So over the period of time, the classification has been upgraded. Now this is the latest one, where the surveillance of cerebral palsy in Europe, it's an independent registry. They have tried to classify the motor impairment. So how do we go about that? So whenever we see a child, we need to evaluate whether the child has persistently increased muscle tone in one or more limbs. So if that is yes, then we need to know whether both sides are involved or a single side. Accordingly, we can classify it as spastic bilateral or spastic unilateral. On the other hand, if there is no persistent increase in muscle tone, then we need to see whether the tone is variable. So if the tone is variable, then it will categorize into dyskinetic CP. Now if the tone is also not variable, there is no persistent increase in muscle tone, then we need to see whether there is generalized hypotonia along with some symptoms of ataxia. So then it will categorize as ataxic CP. The diagram on the right side, it shows the same finding, but it has anatomically demarcated. So very important to know that many at times we confuse diplegic CP with quadriplegic CP. The differentiation point is in diplegic CP, the upper limb involvement is very less as compared to lower limb involvement, whereas in quadriplegic is almost uniform involvement of all 4 limbs. The diagram below shows the abnormality or insult to the brain and corresponding anatomical distribution of the cerebral palsy. So I think we should classify the cerebral palsy based on these 3 categories mostly. First of all, we should try to differentiate whether it is spastic, whether it is dyskinetic or ataxic. The second thing we need to classify in all the children with cerebral palsy are the associated comorbidities, because these are the key things we don't need to address that will help to improve their quality of life. The last one and the most important one is functional classification. We should try to classify each child of cerebral palsy based on GMFCS and MECS, at least GMFCS and MECS. We should also we can also do in a routine busy OPD practice. We may not be able to go in details about communication function classification system and eating and drinking ability classification system. But as far as functional classification, GMFCS and MECS is must. Now, very 2 important points I want to mention here. We frequently encounter a lot of OPD card where it is just mentioned as spastic CP right at the age of 4 months or 8 months. So important thing is this, the development of brain is in a very dynamic state. So till 2 years, if it is advisable that till 2 years of age, we should just mention as evolving CP rather than giving a diagnosis of spastic or hemiparetic CP. Many a times we will be very sure that it is hemiparetic CP, but over the period of time due to the ongoing development of the brain, the intervention that we apply, maybe it will change over the course of time. So it's better to just mention as evolving CP. The other thing is, other important challenge for us, even for neurologists also, it is to differentiate between spasticity and dystonia. So many a times the child which is being followed up as spastic CP, they may have a component of dystonia. So that will also somehow have implication in the management, both in terms of medical management or in terms of surgical management. So I'll discuss about how to identify dystonia in the subsequent slide. Now a very brief about the embryological aspect, or rather what are the neuroanatomical substrate that leads to different type of injury in the brain. So what this was MRI based classification system which is called MRICS. It was developed by Himmelman et al. In 2017. So what they have told is that CP radiologically will have 5 categories. The first one is maldevelopment. The second one is predominant white matter injury. The third one is predominant gray matter injury. So maldevelopment will usually occur if the injury occurs prior to 20 weeks of gestation. And what do we get? We get this kind of MRI picture. You see this thickened cortex with poorly formed sulci and gyri. So this is lysencephaly pattern. The other one you can see here is schizencephaly. So this again will present as CP, but the injury is before 20 weeks of gestation, and genetic testing is very important here. The second one you can see it's predominant white matter injury. So it is after 20 weeks of gestation when myelination start to happen, and then there is some insult, be it just prior to delivery, that is after 20 weeks, it can go till the myelination is continued. So any time during the process of myelination, if there is injury to the white matter, that will radiologically appear as white matter injury leading to CP. So you can see there is involvement of white matter in this area. There is again thinning of white matter and expective dilatation of ventricle. The third one is predominant gray matter injury. So you can see here is involvement of deep gray matter, that is thalamus and putamen, and subsequently you can see here a lot of cortex is involved, cystic and cephalomyelitic changes. So these are the 3 types. The other one is mixed type, another is unclassified. So this is about MRICS, that is MRI based classification system. Now let us go into the proper topic, that is comorbidities in cerebral palsy. So it's difficult to mention all the comorbidities associated with cerebral palsy in a single slide, What you can just go through is just scan right from the head to the toe. So we can go through, like in head, the child will have, may have epilepsy, may have intellectual disability. Then we can come to ear, hearing loss, then eye, vision problem. Then in case of orofacial, we can say about drooling, speech disorder, dysphagia, GI abnormality. Then musculoskeletal, lot of disorders, comorbidities are present in CP. So as I mentioned few here, so I'll be primarily focusing on spasticity and dystonia, because they have some there is some role of medication and intervention in this aspect. So I'll discuss the spasticity part in with these questions. That is, what is the pathophysiology? How will you assess the degree of spasticity? What are the treatment options for spasticity? And what is the indication for stepwise escalation? If one treatment fails, what next? So spasticity definition, we all know it is characterized by velocity dependent increase in tonic stretch reflex. So this is the normal reflex arc. Whenever muscle tries to contract, the intrafusal fiber, they will get stressed, they will send afferent to the spinal cord will send efferent, it will stimulate, or it will lead to the contraction of extrafusal fiber, and there is movement. Now what happens in case of spasticity? There are two components of spasticity. The first one is exaggerated, this stretch reflex gets exaggerated. The other one is intrinsic hypotonia, that is biomechanical properties of muscle. This is also altered in case of cerebral palsy. So for exaggerated stretch reflex, we can have three components again. One is this sensory input, abnormal processing of sensory input. Whatever the sensory input is going here, in the children with CP, there is some abnormality in the sensory processing. So there will be more afferent impulses going to the spinal cord. The other one is in the spinal cord. So there will be irregularity, there will be abnormality in the level of interneurons. So the inhibition that is done by interneuron is also affected. The last one is supraspinal influences, which we consider that is the major factor. Now the important point again here to note is that we tend to say that the child is having spasticity because of pyramidal dysfunction, pyramidal tract. So it's not just corticospinal tract, it is more of reticulospinal, vestibulospinal and medial reticulospinal tract that coordinates with the corticospinal tract. So the role is more of these three tracts, reticulospinal tract and vestibulospinal tract, not just corticospinal tract, because this reticulospinal tract will have inhibitory influence on the spinal cord, and once this connection is lost due to any insult in the brain, then this inhibitory influence is lost, and then the child will go into spasticity. So that is one point to consider. The other one is intrinsic hypotonia. I'll explain here. So this is another diagram where I'm also giving the pathophysiological aspect and the intervention. So we have, as I discussed earlier, two component, neural component and biomechanical component. So neural component, where we have a role of antispastic treatment. Biomechanical component won't have any role of medication, it is more of physiotherapy. So this is the vicious cycle. You see here spasticity, there is shortening, soft tissue changes, hypotonia will lead to irreversibility fixation, and then again permanent deformities. This will again lead to lack of emulation, and same cycle will repeat. So now with this background, we need to, how do we assess? So there is two way, obviously. When we see a child in the OPD, we'll have a clinical assessment looking at their gait, tone assessment, power assessment and everything. Then there are some objective scales. So we have two scales that is commonly used. One is modified Ashworth scale. So we have 5 grades of that. We can go through this. And there is another important scale that is less commonly used because it will require some instruments. So Tardieu scale, but it is more objective. So what we do here is we measure two angles at a different velocity. R1, it is the angle at which resistance is first encountered. So what we do is we give a first, we flex, we do a stretch reflex with a first velocity, and the angle at which the first catch is felt, that is R1. Now R2 is we move the limb with slow velocity, and the maximum movement we can achieve, maximum range of motion we can achieve, that will be R2. Now from that what we know is if the R2 minus R1 is small, means the catch is also felt early and the range of motion is also limited. That means there is some amount of contracture. So in that case, again anti-spastic medication won't work. So we need to go ahead with surgeries. And if it is large, then we can go ahead with the anti-spastic medication or nerve block. So treatment option, we need to have a definite goal setting. So I have enumerated these as smarter. Regarding treatment option, again, non-pharmacological intervention, pharmacological and surgeries. So the important thing with regard to non-pharmacological intervention is reduction of common triggers. We need to avoid this trigger. These are very important thing, but very much underrated point. I tell my parents I'll tell my patient with dystonia, I mentioned properly in their OPD card, these are the triggers you need to avoid. Because this again works in that cycle where I have told that abnormal sensory processing. So lot of common triggers are there which can precipitate. So we need to take care of that. Treatment per se wise, if it is a focal spasticity, you can go with chemodenervation or casting or splinting. For generalized spasticity, we have oral antispastic drug or intrathecal baclofen. So these are the common classes of the drug that are used in spasticity. We have GABAergic, we have monoaminergic, we have ion flux blockade, and few others which are not very commonly used. So these are the common drugs that are used in clinical practice. Baclofen, it's a GABA agonist. Dose we can start with 2.5 mg per day and go up to 40 mg per day. We have diazepam. Again, this is not very commonly used, but studies wise this has found to be quite effective. Dantrolene not very commonly used here in India in a clinical practice. Clonidine sometimes we use. Tizanidine is a very effective antispastic drug. Now we'll see. Now what about the principle of drug therapy? We need to educate the patient about the side effect, that is sedation, drowsiness, weakness. Start low, go slow policy. That is, we should try to go as slowly as possible, and we should titrate by looking at the side effect. We should reach the maximal dose before labeling the drug as ineffective. This is very important. Even in the case of other drug which we use in ADHD, risperidone, everywhere, we continue for 2 weeks, and then if it's not working, we tend to take it off. But we need to wait for at least 6 weeks. Sudden discontinuation, very important. It will lead to rebound increase in spasticity and other side effect also. If it is not responding to a single drug, try 2 or 3 drugs. So baclofen, few points because this is very commonly used. It has a short half-life, so we need to give in a tedious dose, mostly tedious dose. An important thing about baclofen is that it might develop tolerance over the period of time. So we might give drug holiday for 1 to 3 weeks. During that time, we can use another agent and then we can reintroduce because there will be desensitization of the receptor. So we can give a drug holiday period. RFT, LFT monitoring is important. There has been discussion about risk of seizure with baclofen, but studies wise and even in my personal experience, risk of seizure with use of baclofen is only in 2 scenarios. One is if there is rapid withdrawal, and other one is if it is given at a very high dose. Otherwise, it is safe to give even the child with seizure. Tizanidine, it's a very good drug. 1 tab HS to start with. This is maximum, but we tend to go up to 10-12 mg per kg per day only. Again, it has a short half-life, so frequent dosing is required. Hepatotoxicity is a potential side effect. So this was one systematic review where they have compared tizanidine with baclofen because this is a very common question we used to go, which one is better. So this study has 3 RCTs, all of which has shown that efficacy wise also tizanidine was better and side effect wise also tizanidine was better. So we can take home point that tizanidine is a better antispastic drug as compared to baclofen. So regarding chemodenervation, so this is I am talking about Botox. So what is the indication? The important thing for us as a pediatrician and pediatric neurologist is to know when we should refer the child for Botox injection. So when the symptoms of spasticity are focal, so this is very important, focal, segmental or regional. When modified Ashworth scale is 1+, so I have given the scoring grading. So if it is 1+ but affecting the function, or if modified Ashworth scale is more than or equal to 2. So a modified Ashworth scale is very subjective thing, it will improve with practice. So that is another indication. The other thing is we need to differentiate spasticity from contracture to give Botox. So for that what they do, physiotherapy PMR department, what they do is they give a diagnostic local anesthetic block and then they will see whether there is improvement in spasticity or not. If there is improvement, then they go ahead with Botox, otherwise they don't. If there is a failed trial of 3 to 6 months of physiotherapy or ortho, so initially what I have discussed with PMR team prior to this presentation also, so they tend to give 3 to 6 months of intensive physiotherapy with orthosis, and even if that fails, then they go ahead with chemodenervation. And obviously no definite contracture has to be developed. So botulinum toxin, I think this will be more in the part of physical medicine and rehabilitation department. So I will skip this. This one. So we have other option also, intrathecal baclofen. So if the spasticity is generalized and if nothing is working out, then we can try this one also. It is found to be quite effective. The therapeutic dose of intrathecal baclofen is 1% of the oral dose, because oral dose has very poor CS of penetration. Surgical management, two departments can be involved, neurosurgeries and orthopedic surgeries. Just a point, these are the indication for, this is the ideal candidate for selective dorsal isotomy. You can see here, diplegic side will have a best response. Orthopedic surgeries when they are fixed deformities and contracture. Okay, so this is the flow chart where you can, how to escalate the management for spasticity. I am running short out of time, so I'll just quickly go through. So this is how we assess dystonia. So the most important thing for us to differentiate dystonia, whether there is dystonia or not. So what happens whenever the child is in a lying down position, how do we check for dystonia, whether it is present or not? So ask him to reach for an object. So you can see some twisting position, twisting movement at the hand. Similarly, when the child is seated with upper extremity task, what you can do is rapid finger tapping. That will also help us to differentiate whether there is dystonia, because otherwise the child will have difficulty in doing rapid finger tapping, reaching for an object. There will be some twisting posture, right? So again, common drug use, baclofen, pacitan, gabapentin, carbidopa, levodopa has to be given a trial in until and unless the CV is cerebral palsy is diagnosed. Actually, any case of dyskinetic cerebral palsy, we need to give a trial of levodopa to look for any underlying primary generalized dystonia, dopa responsive dystonia. So even clonidine is very effective as an antidystonic drug. So what in our routine practice we give pacitan, we give clonidine, we give benzodiazepine. So intrathecal baclofen again has a role here. Deep brain stimulation. So deep brain stimulation is primarily for it's more for genetic dystonia. In secondary case of dystonia, it is not very effective. I'll just take 2-3 minutes more. In case of secondary dystonia, it is not very effective. However, few studies that shows that there are variable results, right? There are results ranging from 1.2% to 49% reduction in this Burke-Van-Marsden dystonia rating scale. There are certain contraindication for this. So this is the review which they have shown the efficacy. There is decrease in BMF DRS score. You can see there are variable on an average. It is around, they have taken as around 20% reduction in BMF DRS score, which is a good thing. So other aspect I think I won't be able to cover. So I'll just go. So you can see the first one. What you can do here, we can give oral antispastic drugs, but the best one would be to give Botox on this left lower limb. What about this one, antidystonic drugs? I don't think it will work here. So if at all there will be some improvement, it will be with DVS only. We need to go for more palliative care. The third one, this child will definitely benefit by the use of Botox in the right lower limb. So I want to leave with this last slide. So this is very important. Every CP parents, they tend to ask about what is the predictor, whether the child will be able to walk or not, how will be the cognition of the child, and we will be stuck. We will be just saying, okay, maybe we don't know, we are not sure. But there are certain predictors which can give them hope. So these are the predictor of ambulation. If the child is able to sit independently at 2 years of age, if he doesn't have any visual impairment, doesn't have any intellectual disability, or doesn't have epilepsy or seizure burden, the chances of being ambulatory is more. So we can just counsel them, okay, so this is going on right now. Let's see if at 2 years of age he is able to sit without support, then he can walk. So that we need to give positive hope to this patient, to these parents. Simultaneously, there are some predictors of cognitive outcome. There are some predictors which you can predict from memory lesion. That's all. Thank you.
Thank you, Dr. Shankar, for nice presentation. Any question from the floor?
Sorry, sir?
So I think it may be discussed later on. Okay, our next.
Yes, we can give. Yeah, we can give.
Thank you, Dr. Shankar. So our next program is on ADHD, the pharmacotherapy strategies by Dr. Jairanjan Ram. He's a known neuropsychiatrist stressed in a city of Kolkata, not only the city but also in the West Bengal. and his affiliation is with Apollo Multispeciality Hospital, Kolkata, and Mental Health Foundation, Kolkata, as a consultant psychiatrist, and he had many achievements.
Thank you.
Sir, you start your session.
Sure, I would like to thank Dr. Shaha and Joshudhara for inviting me here. It's good to see so many familiar faces. You know, essentially the point I want to make today, and for all of you to remember and take home, is that all over the world, pediatricians, more than psychiatrists, treat ADHD pharmacologically, and there is absolutely no reason why all of you should not treat ADHD with the two medicines which are available in India. One is methylphenidate and the other one is atomoxetine. Primarily, all of you use far more complicated drugs. You know, psychiatrists, who are the least intelligent of all medical specialities. My mother, who was a pediatrician, was very ashamed that I became a psychiatrist, and she said that it reflects my intelligence. My brother was a pediatrician, so he was higher up in the ranking at the home. If we can use methylphenidate and atomoxetine, there is very little reason why you should not be using it very, very commonly. See, primarily ADHD, the prevalence wise, it is about 5 to 7% overall. So it's a very common disease. The second issue is that unless you treat ADHD effectively through the early years, by the time a child is an adolescent, they will have so much behavior problems and oppositional behavior, academic lag, that it is very difficult to then expect a good prognosis. And also remember that, see, we see ADHD children as very disruptive children. But ADHD is a condition which is also very, very distressing for the child. So if you are a child, if I am a child with ADHD, I am criticized by my teachers, I am criticized by my parents, I am shunned by my peers because I am too restless and I am unable to play patiently with other children. No one likes me. I am described as a bad boy who is naughty. And just imagine what impact it will have on my self-esteem and the way I view myself. So if I am labeled as a bad kid right from an early childhood, I will never try and become good. And therefore, I feel it is absolutely essential that we treat ADHD very, very effectively pharmacologically. And see, if the treatment doesn't work, it doesn't work. You stop the medicine, because these are very, very non-toxic, safe medicines. So there is absolutely no reason why pediatricians should not treat ADHD. You know, many years ago, Shukantoda requested me to build a pharmacotherapy course for pediatricians, and I think it is essential that most of you are confident in treating ADHD and many other childhood, like childhood depression with tiny amounts of fluoxetine, because these are very safe medicines. The other part is, if you have an ADHD child, the burden of care is enormous, and parents lose sleep, they are unable to, they are fighting amongst themselves, the husband is saying, the father is saying that the mother is to blame, the mother-in-law is saying that the mother doesn't take care of the child and therefore the child is disruptive. So I think we need to really feel confident and treat ADHD. What drug should I start with? Methylphenidate. You know, it's a very, very commonly used medicine, and there is enormous amount of long-term safety data. Now, whenever you start a child on a psychiatric medicine, no parent is going to jump up in joy and hug you, saying that, oh my God, what a wonderful thing you are doing, because every parent is afraid of their child being started on a psychiatric drug. So the way I think best is to convince parents that this will help your child to perform better in school, academically, because Indian parents and Bengali parents, পড়াশোনায় ভালো হলে সাত খুন মাফ. So if you are able to convince them that this will help you to improve your child's performance, I think most of them will agree to give it. The other fact is, methylphenidate is a drug which is now about 80 to 90 years old. So therefore, the long-term data about its safety, that this drug can be used effectively and safely without any long-term disadvantages, is enormous, because this is an 80 or a 90-year-old drug. Now the concerns you have about methylphenidate primarily is growth retardation, number 2 is cardiovascular safety, number 3, as pediatricians who see epilepsy, methylphenidate, can it be given safely in epilepsy? And fourthly, in tics and Tourette's, can you give it? So I will cover them briefly. So if you see the effect size of the medicine, methylphenidate is frankly outshines everything. Now, so this is the most crucial part, So how do you start methylphenidate? How you start methylphenidate? Methylphenidate is available in 3 versions in India. One is the immediate acting, and the other is long acting, the other one is intermediate acting. For all of you, for simplicity of use, choose one medicine which is methylphenidate immediate acting, which is sold as Inspiral or Advise. They are available in 5 mg and 10 mg. Best is to start 5 mg twice a day. Now remember, methylphenidate works for about 3 to 4 hours. Immediate acting methylphenidate works for 3 to 4 hours, and it starts to work after half an hour. So if the child's class is starting at 8:30 a.m. in the morning, give the child a breakfast and then give the 5 mg tablet. And then the child will be able to focus and concentrate for next 3 to 4 hours. If the child has slightly longer classes, then you can give methylphenidate medium acting, which works for about 6 hours. Now, 5 mg in the morning and then 5 mg in the evening when the child again sits down to study. So if the child is studying from 6 p.m., then give the medicine at 5:30 p.m., 5 mg. You try this for 1 week and then increase the dose to 10 mg twice a day. The maximum accepted dose of methylphenidate for children is up to 60 mg. In my experience, very few children require more than 30 mg or 40 mg. So 5 mg to start with BD, then make it 10 mg BD, maximum 15 mg BD. And it will actually greatly help the child. Now, what are the side effects you need to monitor? I will come to it. But remember, timing of the drug is most important. What will you want? Ami ki boli, je bachchader jokhon when we start, that you will be able to understand the effects of this medicine within 7 to 10 days, because it is immediate acting. Jei debo tar 8 ঘন্টার মধ্যেই লাভ হবে. Many parents, many mothers would be able to, if the child has skipped the dose, if the responsibility of giving the medicine in the evening is given to someone else at home, say maybe the domestic help or mother-in-law or someone, when the mother comes back from office, she can immediately pick up that my child has missed the dose of methylphenidate, because it is so obvious. So what are the side effects you need to warn them about? That initially it might cause appetite suppression, but again it is a very, very rare side effect. It's not common. It is dose dependent, and also the side effect goes away. remember the effect of the medicine stays for 3 to 4 hours. So if they give the child properly a good breakfast, then the afternoon lunch he may not be able to eat. But again, once the evening dose wears off, the nighttime dose, at night the child can have a proper dinner. Very few children actually, we need to stop medicines in very few children because of appetite suppression. And also you can give drug holidays. You might say that on a Sunday when the child is not studying, if it is Saraswati Puja in the morning, do not give the medicine. So drug holidays can be given quite commonly if there is appetite suppression. The other side effect is that, see, methylphenidate increases alertness. So it promotes wakefulness. So these children, and the medicine lasts for about 4 hours in the body, 4 or 5 hours. So if you give the tablet too late in the evening, the child would stay alert until 2 a.m. in the morning and play video games, computer games. So try and not give the medicine after 6 p.m. আমাদের খুব প্রবলেম হয়, কেন অনেকে আবার টিউশন থেকে ফিরে 8টার সময় পড়তে বসে। তখন when will you give the medicine? Because if you give the medicine at 7:30 p.m., then the child will not sleep till, quite late at night. So we have to, I think that is the crucial part. Timing of the dose is very, very important. Increase the dose every 1 week, 2 weeks if required. By 4 to 6 weeks, you will figure out whether the medicine is working. Majority of children, so if you give methylphenidate, 6 to 7 children respond to methylphenidate. If you try methylphenidate, then atomoxetine or methylphenidate, 8 to 9 out of 10 children improve. So the drug response is actually very good. And as I said earlier, all of you are actually far more capable and give very, very complicated drugs. So these two drugs should be absolutely simple to use for you. If the child has significant anxiety, OCD, conduct problems, learning problems, then the response will not be that great. So what will the child and the parents tell you? That they are able to sit and focus. But see, the most important part is that methylphenidate improves concentration, but you have to sit down and to study. মানে এটা না এই ওষুধটা মানে ছেলেকে রামকৃষ্ণ করে দেবে না, ছেলে যদি পড়তে বসে তাহলে সে পড়তে পারবে। So the analogy I use is that it is like a hearing aid. আমি যদি কানে শুনতে না পাই তাহলে আমায় যা ইনস্ট্রাকশন দেবে আমি করব না, কারণ আমি শুনতে পাচ্ছি না। এবার আমায় যদি মিথাইলফেনিডেট দেওয়া হয় সেটা হচ্ছে একটা হিয়ারিং এড পড়ার মতো, আমায় এবার কিছু বলা হচ্ছে সেটা আমি শুনতে পাচ্ছি, কিন্তু করব কি করব না সেটা আমার টেম্পারমেন্টের উপর। তার মানে এই নয় যে মিথাইলফেনিডেট দিলাম আর তার মানে সে পড়াশোনায় ফার্স্ট হলো আর দারুণ চারিদিকে জয়রঞ্জন নামের হইচই করে হাততালি দিতে দিতে সবাই বেরিয়ে গেল, তা নয়। কিন্তু মিথাইলফেনিডেট উইল এনেবল ইউ টু স্টাডি ইফ ইউ ওয়ান্ট টু স্টাডি, অ্যান্ড দ্যাট ইউ হ্যাভ টু টেল দ্য পেরেন্টস দ্যাট ইউ নিড আদার বিহেভিয়ারাল মেজার্স। মানে মিথাইলফেনিডেট দিলেই সে একেবারে দারুণ হলো তা নয় কিন্তু। সো দ্যাট ইজ ভেরি ইম্পর্টেন্ট। The other thing is, with ADHD, 30% of children with ADHD have dyslexia, SLD. So therefore, when the outcome is not that good, do check for dyslexia. Checking for dyslexia, you can easily ask 3 to 4 questions. ঠিক করে রিডিং পড়তে পারে? তোরা পারে না, অক্ষর ধরে ধরে পড়ে। লিখতে বানান ভুল খুব করে, মানে খুব বেশি বানান ভুল করে, আর বিডি সিডি এই কথাগুলো উল্টে লেখে। এই 3-4 প্রশ্ন করলেই না ইউ উইল ফিগার আউট ওয়েদার দ্য চাইল্ড হ্যাজ ডিসলেক্সিয়া অর নট। দ্য সিম্পলেস্ট কোয়েশ্চেন টু আস্ক ইজ রিডিং ফ্লুয়েন্টলি পড়তে পারে কিনা, বাংলা ইংরেজি পড়তে পারে কিনা। tahale you will get to figure out. You don't need complicated assessments to suspect the child has dyslexia. And then you ask for, if you have time, ask the parents to check with the teachers whether they feel that the child could be having dyslexia and can they see a special educator in school. Majority of big schools and even government schools under Sarvashikha Mission now have special educators in their classes, in their schools. So do use them. When to use atomoxetine? Atomoxetine is when you suspect the child could be having tics and all that. I am not going into atomoxetine. Atomoxetine starting dose is 0.5 milligram per kg body weight, and after 10 days make it 1 milligram per kg body weight. Problem with atomoxetine is that you have to wait for about 4 to 6 weeks in order to figure out whether the child is responding. তাই আমি সব সময় বলি যে 2 মাস কিচ্ছু এক্সপেক্ট করবেন না, তারপর এক্সপেক্ট করবেন। আর যদি 2-3 মাসে লাভ না হয় তাহলে অ্যাটোমক্সিটিনে লাভ হবে না। But try at least 1 or 1.2 milligram per kg body weight. It is an incredibly safe drug to use. So 0.5 mg per milligram kg body weight you start, and then 1 or 1.2 milligram per kg body weight. Now I will clonidine, I am skipping. See, growth retardation. Growth retardation e bole je if there is significant appetite suppression, children finally grow about 1 or 2 centimeters less if at all they are affected. So the fear of growth retardation is actually overrepresented. And if you, all of you pediatricians are far more capable of monitoring growth than psychiatrists. So growth retardation, possible growth retardation is very, very rare, and it happens very, very infrequently. Cardiovascular safety, it's a very safe cardiovascular drug. Although there was, at one point there were concerns, but now that concern is no longer there. Only if the child has prominent family history of arrhythmias, if there is a structural problem in the child's heart and other symptoms, then only you need to be worried about cardiovascular safety. একটু ব্লাড প্রেশার বাড়তে পারে, একটু পালস রেট বাড়তে পারে, কিন্তু দোজ আর ক্লিনিক্যালি ইনসিগনিফিকেন্ট। সাইকিয়াট্রিস্টরা যদি ইউজ করতে পারে, ইউ ডোন্ট নিড টু বদার অ্যাবাউট কার্ডিওভাস্কুলার সেফটি অ্যান্ড নট ইউজ দ্যাট মেডিসিন। টুরেটস আর টিক্স নিয়ে আই উইল এন্ড। আগেকার দিনে বলতো টিক্স বা টুরেটস থাকলে আমরা ইউজ করব না, এখন বলে যে না, ইউ ক্যান ইউজ, ইট মে ওয়ার্সেন, ইফ ইট ওয়ার্সেন্স দেন ইউ স্টপ ইউজিং মিথাইলফেনিডেট। But the current consensus about using it in tic disorder or Tourette's disorder, that yes, you can use it, but monitor more carefully. Epilepsy khetre, there was earlier a fear that the methylphenidate reduces seizure threshold. Now, what is being said, if the child has stable epilepsy, well-controlled epilepsy, do use methylphenidate without any concern, but obviously you monitor more carefully. I think I will finish here because, yeah, okay, thanks.
Thank you, Dr. Ram. It was a very nice, elaborate discussion about the methylphenidate, and you have said it so confidently and precisely that it can be used by the practicing pediatrician, and that is going to produce definitely a confidence in the practicing pediatrician, because we heard many things against the even we are scared of using methylphenidate. We are not using, we are not at all psychiatrists. And then, but there is one thing I want to say, there are problem in sleep also. Do you think that does a lot?
Sleep problems is a definite issue, but if you time the medicine properly, that you don't give it after 5:30 or 6 p.m., then usually sleep problems are no longer a major issue. Very rarely, you know, 1 out of 20 children might have sleep problems, then you manage that with melatonin.
Thank you. Again, there is one question. Drug-free options, is it available in India?
Yeah, available? Yes. No, drug-free options are available. So
like the patch, external trigeminal nerve stimulation,
No,
video,
no,
these things are
no,
not
those are
available.
not. Those are not.
These are not available.
Not available.
And you are not asking to give non-stimulant.
Non-stimulant atomoxetine is there.
Atomoxetine only.
Atomoxetine,
Only
yeah.
atomoxetine.
We have only 2 medicines.
Yes. Thank you, doctor. Now, any question from the audience?
Methylphenidate, doctor.
Body weight calculation is there?
That's actually not required. 5 mg to begin with, because body weight calculation is hardly anyone does it all over the world. So 5 mg BD to begin with, and then 10 mg BD or 15 mg BD.
So if there are patients who are referred to me having their first seizure, who are ADHD or other children who are on these medications, and the reaction from the psychiatrist is that na ei oshutta dewa jabe na or ekta seizure hoyeche.
Na khub bhul oi psychiatrist
I do my bit on trying to establish the epilepsy, do a EEG, if necessary give the medicines, but is that a blanket statement?
No. It's very safe for.
So in our earlier days, we used to listen that ADHD cannot be treated by drugs alone. It needs a special structure, etc. So in actual practical setting, a child from a poor or lower middle class family who's supposed to, the pediatrician thinks that he is suffering from ADHD. Now, whether referral to a psychiatrist is a must, number one. Number two, whether the child needs a cardiological checkup before starting off methylphenidate, or the pediatrician himself can start methylphenidate irrespective of whether any other structural treatment is available or not.
I think I'm glad. I think these are very, very valid questions. I feel that the least we can do is to give the medicine, because you see the children are suffering so much, the families are suffering so much, and in reality in India, therapy is a very expensive process. Now, try and give the medicine. It is cheap medicine, it is not expensive, it is relatively safe to use. At least the child will be helped to a degree. And then you can ask them that look for ADHD information or videos, you can find them and do read about it. And you will be able to manage, give them some basic behavior measures. And also all government schools also are now under Sarvashikha mission. And they may have a special educator attached to the school.
Thank you. আমি কিন্তু মিথাইলফেনিডেট ব্যবহার করে খুব ভালো উপকার পেয়েছি, আমি জেনারেল পেডিয়াট্রিশিয়ান। তো আমার একটা কোশ্চেন, টিক্স অথবা এডিএইচডিতে আমাদের ইইজি চেঞ্জ কিছু হয়? ইইজি চেঞ্জ
ইইজি না, আমি না ওই টিক্সে তো ইজি চেঞ্জেস হবে না,
টুরেটে
না।
Thank you, sir, for
Thank
your
you.
lucid presentation. And we will proceed to next session, optimizing the multimodulary therapies in autism. So it's a panel discussion. I would ask our moderator, Dr. Ashok Datta. Sir, please come. And the panelist, Dr. Taraknath Ghosh, Dr. Moushumi Mukherjee, Dr. Deeptangshu Dash, Dr. Shundip Shamanta, and Dr. Manjari Basu. Sir, please start.
So initially it was 40 minutes, then the time is reduced to 35. So 20 minutes, okay, sir. So my respected sir, Dr. DNB Resident, who is the founder of this Pediatric Neurology in West Bengal, our respected teachers, Sukhanto Chatterjee, and the senior persons, senior teachers, my colleagues, my students, all are there. After ADHD, it is the autism. Very difficult things to our pediatricians, because ADHD you can control, but it's difficult to control the autism. Now, I'm going to tell you that what we thought previously, say before July 2025, the concept of autism was different from the concept today. I will discuss these things today with the illustration of the cases, and you will see the autism begins with just genetic disorders and environmental reactions, and depending on that, there are different types of autism spectrum disorder, not like as before what we told previously, the Asperger, child disintegration, pure autism, etc. So this is a new concept. I am going to elaborate that concept. This is an article published in Nature Genetics, and decomposition of phenotypic heterogeneity in autism reveals underlying genetic program. Go to these things. And this is the large cohort. 5,392 children are taken in this study. And what is the base of the study? To see what are the genetic changes and to see what are the environmental reactions and how we can control these with the measures which are required. Not all the cases are measured in the simultaneously in the same condition. Let us go to the discussion paper. The 4 subtypes from that paper published, that social and behavioral challenges, they are 37%, moderate challenges 34%, mixed ASD with developmental delay 19%, broadly affected 10%. So you see the two group, social and behavioral challenges and the moderate challenges. In these two groups, we are near about say 71% cases where the autism is simple. It is not too difficult to manage. Let us go to the next step. In social and behavioral challenges, 37%, autism traits are there, but here the important thing is that no developmental delay. So this is the important thing. But what important another thing is that there is increased incidence of ADHD, OCD, anxiety and depression. So here the control of the disease can be done easily along with the some therapeutic management, treatment of ADHD, OCD, anxiety and depression. And genetic pattern is common variant mostly and polygenic risk. But remember, this genetic pattern is not inherited pattern. The social and behavioral challenges, 37%, genetic pattern is single nucleotide polymorphisms after birth, SNP after birth, and it is associated with the other polymorphisms of other like say ADHD, OCD, anxiety and depression like this. So these are mixed. This group is the moderate challenges, 34%, this is the mildest group. Here is also no developmental delay. Autism symptoms less severe, fewer mental health issues, and lowest genetic burden. So you see, of these two groups, the pediatrician in general can easily manage the autism. From this onwards, it is difficult. Here the autism symptoms are more prevalent, developmental delay present, and inherited genetic problems are there. So in the past two, there are no inherited problems, but here the inherited started. That is called mixed ASD with developmental delay, but it is only 19%. Next, bodily affected group, the 10% is profound autism, severe problems in all fields, and there is de novo damaging mutations in highly important genes. So what we know previously that genetic changes and the environmental interaction is the development of the disease. So genetic changes are less prevalent in the past two groups. So that's why their outcome is much more better in comparison to other groups. These are discussed. Moderate changes also discussed. Comorbidities are not present or less prominent in moderate changes groups. Genetic burden is less in moderate changes groups. In mixed ASD, inherited variant of genetic disorders are there and developmental delay is present. So when there is an inherited genetic defect from the parents, developmental delay is a must. So this delay is present both in the mixed ASD and here the prenatal gene expression affected. And also in case of bodily affected, severe gene damage is there. So in bodily affected only 10% cases, so 10 and further 15, say only 25 to 27% of cases, you will get they are difficult to manage, but the rest of the cases you can manage, pediatrician can manage easily with this. Mainstay of the management nowadays, we show the parental interaction and teaching to the parents about stimulation. This is the hypothesis now. And this is accepted throughout the world. You teach the parents how to give, say, therapy or say interaction with the children, and parents will take care of that. We should not be dependent on therapy. It is not possible. In our country, it is not possible. Let us go to the case number 1, and I request you, so you take the case and say the Ria was diagnosed with autism spectrum disorder at age 3 years, and delivery was normal. He walked at 12 months and spoke her first word at 14 months. Developmental milestones is only mildly delayed. Participate in simple conversation, but often prefers to talk about her own interest, understand basic rules, but sometimes misses certain social clues. Eye contact is good, can speak with slight delay, can participate in simple conversation, no major developmental delay. But the occasional hand flaps shows some lining up twice, does not like loud noises or certain texture of clothes. No ADHD, no anxiety or significant emotional dysregulation, sleep normal, appetite normal. Here the core autism symptoms are present but milder. Now, in which group it should be and why?
As Ria has some deficit in social interaction and occasional repetitive behavior, but these are mild, and she has normal developmental milestone, and there is no significant mental health issue. So it is moderate challenge subtype.
What should be your current management plan?
Moderate challenge subtype needs both type of management, co-treatment of autism by interdisciplinary team and parental guidance at home. Now they should get the behavioral management therapy, occupational therapy and speech therapy once or twice in a week. And parents should create a sensory friendly environment at home, and they should engage themselves in joint activity with the child. Now social interaction should not be forced. It should be given step by step manner, and we should encourage the child to take part in parallel play and small group interaction. And they should enjoy the mainstream schooling.
So social interaction is very important in this case, and flexibility. So say this is a 37% of cases where the outcome is good and everything is good in these cases. This is case 2, that is Arjun, a 3.5 years old boy, first child of educated parents, delivery history normal, developmental milestones slightly delayed but almost normal, no major developmental delay, consistent with ASD without intellectual disability or with average cognitive abilities. So patients diagnosed with ASD at a later stage or exhibit subtle early developmental milestones are more vulnerable to experiencing co-occurring neurodevelopmental and psychic conditions. Now, here the most important thing is this, there is comorbidity risk in these conditions, because the genetic changes in these conditions are associated with the genetic changes with the ADHD, anxiety, depression, OCD and sleep disorders. So we will have to manage all these conditions along with this. So in this percentage of cases, the comorbidities are associated, treatment of these should be done along with the normal interaction which I discussed before should be done with the patients. Now, so management of comorbidities in this case. Dr. Taruk Ghosh.
Actually, this fall in the group, that is the major group under the SPARK study cohort, that is 35%, in between 35% included in this group. So here the only features, autism is there, but their normal development is there. So as comorbidities, lot of comorbidities are there. More than 70% of cases, there is comorbidities are associated with this pattern. So these comorbidities usually occurs due to overlapping causes, that is genetic cause, neurobiological cause, immunological cause, metabolic cause, all are implicated with this pathogenesis. And mainly ADHD, if we come to the point of ADHD. ADHD is usually related to the neuroinflammation, as well as there is degree of dopaminergic nerve dysregulation. So first thing we have to do assessment whether it is ADHD or not. It is very difficult to diagnose ADHD below 5 years of age, but we can suspect. After objective diagnosis can be done after 6 years of age. There are a lot of scoring. Scores there, so we can use it.
What intervention you should do in this case? What interventions you should do?
Intervention only we can do behavioral therapy, and cognitive behavioral therapy is the main part, and also medicine has the role, as already it is discussed by previous speaker, that is we can use medicine like atomoxetine or methylphenidate as a stimulant initially, and as already it is discussed, we not go into details. And another part, that is the anxiety disorder. Anxiety is usually related to the imbalance of serotonin. So there is also, apart from the behavioral therapy, cognitive behavioral therapy, there is a role of drugs. SSRI is also useful in these cases. And regarding the OCD is also related to the repetitive behavior of the autistic disorder. And when to suspect OCD in a case of ASD child with repetitive behavior? We all know that it is pleasurable. Repetitive behavior is enjoying for the baby. But when it is done due to anxiety, and there is stress, and it is relieved by doing that, so we suspect the child is suffering from OCD. So at that time, we have to treat the case. Apart from behavioral therapy, we use SSRI in that cases.
Okay. Thank you, Dr. Taruk. And the most important thing is the early identification of the different comorbidities and managed it. Parents should be involved in all these cases. Now we are going to another case, this difficult case, that is case 3. And I request Dr. Diptangshu to tell about this case. The Arian is the only child of a 34-year-old mother, and the father is 37 years. Pregnancy was uneventful, but delivery was done by cesarean section. He had mild jaundice after birth, but no major neonatal complications. Now, developments all are delayed significantly. The language also delayed. And so total developmental delay is present. Poor eye contact, limited social smile, does not respond consistently to his name. So just simply with this, we can say that this is not included in the earlier 2 groups. This is the 3rd group, where this is the mixed type of disorders, where there is inherited genetic defect is there. Without inherited genetic defect, there is no chance of developmental delay. Now, presentation is the significant global developmental delay, poor fine motor scale, and language also delay. Autism symptoms are strong present in this case, and other features like say intellectual disability, sleep initiation difficulty, hyperactive or anxiety are not present in this case. How do we assess this case, Diktangsu?
We can do the assessment by developmental screening test, DST, VSMS, and ESA. This is going to reveal the degree of autism and what sort of developmental maturity is there. Here we can see that the child is at a developmental age of 18 to 22 months, whereas the chronological age is 44 months. And apart from that, genetic testing reveals that whole exome sequencing has various rare variants. FRA test is positive.
Now this is important, that is folate receptor autoantibodies, and in the subsequent discussion you will see that there are drugs now available which can control this also, folate receptor autoantibodies. So this should also be assessed. So this assessment is required because the antibody is present. There is some difficulty in metabolism of the brain. How do you do the diagnosis in this case?
The diagnosis here would be mixed type developmental delay with autism spectrum disorder, and the level 2 severity with language impairment and intellectual impairment is there.
Good. So this is the typical case of autism which is difficult to manage, but otherwise we are going to current management plan. What will you do in this case?
Various therapies like occupational therapy, physiotherapy, special education, and even nutritional support would be needed with folinic acid. There are certain speech therapy techniques like PECS, sign language, oral motor exercises that would also be helpful, and parental training is very important.
So nutritional support like the folinic acid supplementations, that is also required here. And sleep and GI disturbance, how will you tackle this?
Melatonin is very useful, and dietary modifications are also to be done.
So you see, the melatonin is very important to autism patients, and there are studies where showed that 63% of cases may be improved by giving melatonin. This study is published. This is just a study analysis are there where there are sleep disturbances present with the autism patient. So what prognosis you expect in this case?
With consistent intensive intervention, children are going to show some improvement. Language development is usually the slowest, and many children remain non-verbal, and AAC can be used. Long-term support is likely to be required.
So prognosis is somewhat, some sort of guarded prognosis is there, but it should be continued. Most important thing is that we should involve the parents here. What is the key learning point in this issue?
The subtype needs very early, high-intensity multimodal interventions focused heavily on communication, motor development, and genetic and metabolic factors like FRAA play a bigger role here compared to moderate challenges group.
Now this is the fourth case, that is bodily affected case, and this case is given to Professor Sanjeev, and because it is very difficult case. So bodily affected case, and only 10% of autism cases, out of 10 only one case will get this type of cases. Now Bihan is the second child born to consanguineous parents. Pregnancy was complicated by gestational diabetes. Gestational diabetes, very difficult and very complicated matter to the baby. He was born full term but had perinatal hypoxia. Family history includes intellectual disability in a maternal cousin. Now developmental history, head control at 8 months, sat unsupported at 14 months, walked at 28 months, no meaningful words till date, poor response to name and limited eye contact since early infancy. Current presentation, in this case, Dr. Sandeep, you please highlight the current problems in these bodily affected subtypes in different groups?
In current presentation, it's coming to the broadly affected subtype, so which involves severe multi-system involvement, particularly in all the domains, social communication, language, repetitive and restrictive behaviors, and severe cognitive delay with intellectual disabilities, with gross developmental delay, and with huge sensory issues like hypersensitivity, as well as some avoidance of hypersensitivity, as well as self-injurious behaviors, and he bangs heads on wall, covers ears, and refuses many food textures. So all the issues related to the severe form of autism are here, and so treating this type of patient is a challenging also, and grossly it comes under broadly affected subtype. With regarding therapeutic point of view, it comes under type 3 probably.
Now, what co-occurring conditions may be associated with this disease?
Co-occurring condition like previous cases, here also just epilepsy, feeding issues, GI issues, sleep disturbances, and particularly severe aggressive behavior and severe injurious, self-injurious behavior. These two are very challenging for this type of cases.
How do you assess this case?
For assessment, as basically it's already diagnosed autism cases, so our target will be to scoring the grade and severity. So for that we can use the scoring scale, particularly like CARS, ADOS, RADOS2 like this, and some intelligent IQ assessment, developmental assessment. So probably they will be under the severe category. And simultaneously genetic testing, particularly whole exome sequence, is very important, because in other cases where chromosomal microarray probably the sufficient to diagnose the genetic origin. But for this type of cases, probably whole exome sequence ordering is very important. And simultaneously comorbidity like epilepsy, so EEG and MRI pattern should be recorded for further management or add-on drugs.
So these are the typical case where we get this feature size type of cerebral palsy, what we usually discuss associated with the features of severe autism. And definitely we should do the MRI and find out cerebral atrophy present or not. We will also do, as it is available nowadays within 10 to say 15,000 whole exome genome sequencing, if it is possible we should do and find out what are the changes, genetic changes are there, highly concentrated gene are present or not, what types of changes are there, that's what can be. These are important, these are not very helpful in management, but for say subsequent pregnancy, in other cases it will be helpful. Now, so this is definitely, I think, Sandeep,
it's a broadly affected subtype with
level 3 group, level 3
which is
disorders.
requiring very substantial support according to DSM-5.
So this is broadly affected group.
Yes.
Now management just like other before, but everything should be with more stress. Everything should be given with the more stress, like speech therapy, occupational therapy, physiotherapy, and ABA therapy, etc. That should be given with more stressful conditions, and here the real requirement are there.
Yes, sir, a minute, one minute. So previous slide, sir. Yes. In comparison to previous cases, where we can do weekly or twice weekly therapy is sufficient, but here intensive therapy. So regarding multimodal therapy, intensity and professional accuracy of the therapist, it's the determining factor for the outcome of this type of children. Particularly 30 to 40 hours per week intervention is required in multimodal using the specialist, particularly occupational therapist. Sensory integration is very effective for these cases, and the other behavioral abnormality and this challenging behavior which we are using, basically ABA technique, what we are using, ABA principle rather, applied behavioral analysis, which based on ABC, antecedent, and B mane behavior, C mane consequences technique. But for the children in the early age, for these severe cases, if we start earlier, so Denver model, like Denver model and PRT model, they are more effective, probably this type of cases. Denver early start model, that is a very pinpoint model, and it's a child-friendly model which can be more useful, and we should use that type of ABA.
Sandeep, what
for
should be your
particular
medical management in this case?
Yes,
medical management.
Medical management, basically comorbidities, sleep issues, GI issues, and anti-epileptic management according to need. So these are the main therapy. And other, if for behavioral modification, we can use some antipsychotic or antidepressant or anti-anxiety drug as discussed earlier according to need. But for supportive treatment, sometimes family, they cannot bear all the burden. Sometimes they think for respite care or home, there is a structured homes are available where parents can put their child, and there is a structured room, there is a online monitoring is there, and nowadays other form of therapy like robotic therapy, virtual
Actually,
room where they can be
these are
trained
not
properly.
These are not applicable in our country and in all places. So I think we are going to the things that early intervention and some improvement maybe they are in communication, but these type of patients, they need constant support of the caregivers for the family. Next, we are going to the another part of the discussion. Previously, we thought that probably there are no medicines for autism, but now the concept is changing. There are some medications medicines are coming which may help to some extent. I request Moushami to discuss these things. Go on.
Thank you, Professor Ashok Datta, sir. So, up until now, we all have the basic idea about autism. We are much more aware of what autism is like, and with the help of IIP, we know that the two important things to be able to recognize autism are the core two things. Number one, our inability to communicate verbally or non-verbally with gestures, and repetitive thoughts, actions, and behaviors. If these two are there, then we are dealing with autism, and along with that, there may be sensory issues, there may be feeding issues, there may be ADHD, there may be other things, but the core problems are these. Now, also, it was very till now we knew that the core things cannot be altered. The core things are addressed by training as per facility available, as per financial, as per understanding of the parent, as per availability of structure. So either it can be home-based strategies or it can be clinic-based strategies. By home-based strategies, we mean that the parents are given the basic understanding of what to do and how to do and help the child to speak, to interact, to gestures, to behavior management, sleep, and all that. And by clinic-based, we mean that the professional therapists are there, like the special educators, the occupational therapists, which help with the sensory integration issues and which help with the functioning of the child. The speech therapists, provided the hearing is okay, they help with the speech, provided the language area is okay, because we have to understand that autism is basically a coherence of two things. So can we go back to the first slide, earlier slide? I want to talk a bit about this thing, that it not only depends on the neurobiology. Basically, it means how the neurons are formed in early gestation, including the migration, the formation, followed by the neural synapses formation, and also the pruning. So the pruning happens as and when we use the particular functions that we need, and it happens, those which we don't need, they are pruned, they go away. So this over-differentiation, over-synapses, absence of pruning, they are all part of what goes on behind a brain having ultimately manifesting as autism spectrum disorder. So the pharmacotherapy till now was aimed at comorbidities. We have talked about comorbidities, several comorbidities all this while. So you will know by now that there could be behavior issues, there could be ADHD issues, there could be anxiety issues, there could be GI issues like constipation, inability to, poor appetite, fussy feeder. There could be sleep issues and so much, so on and so forth. And these can be addressed by adequate medication like melatonin, like constipation with constipation relieving medications, anxiety, irritability, risperidone, and so on and so forth. But is there any medicine for the core thing, for the core issue of autism? That is the core neurobiology of autism. So there are a lot of emerging scientific research going on. In the US, the incidence of autism has increased dramatically. They maintain good, they maintain good records. So it was around 1 in 1 lakh in the 1970s. That is the incidence of autism. In the 2000, it was 1 in 150. In 2016, it was 1 in 50, and now it is 1 in 30. So they are doing a lot of research. And it has been seen that in some instances, this folinic acid or leucovorin, and initially the FDA had approved for autism spectrum disorder because it was working well, but again in March this year, that FDA approval has been taken away, but what they say that it is useful in a particular type of autism in which there is cerebral folate deficiency. Now the folic acid, which is there in the blood, goes inside the brain in a particular pathway, and this pathway is targeted by the folate receptor autoantibodies, and therefore folic acid, which goes in and has a lot of function like methylation, like antioxidant, like lots of other DNA manufacture. So that is unable to act, and this is one of the reasons for autism being manifested in a child. So in those children who have been demonstrated to have folate deficiency in the brain, either by the FRAT test or by the genetics, but ideally by the CSF folate level, which is not possible. So FRAT test is done, but since several studies have shown that 40 to 70% in some studies, they may have cerebral folate deficiency.
Is there any role of sulforaphane?
Sorry?
Is there any role of sulforaphane in this case? Autism?
Sulforaphane. Okay, so first is the folic acid, then the sulforaphane, and it has got some antioxidant, anti-inflammatory activities, and it's a nutraceutical obtained from broccoli and sprouts, and it has been shown to have some modest improvement in behavior. This is also core drug for core symptoms of autism. And then the other two are not addressing the core symptoms, but they are good adjuvants. One is like the L-carnosine, it's there in the use, we all know. It has an antioxidant effect, and it has been shown to act on the GABA and NMDA pathways and stabilizes the excitatory and the inhibitory signals in the brain. And there have been seen some improvement in hyperactivity and irritability in the cases of L-carnosine. And omega fatties also are there. It's being used in vastly by many in cases, and also over the counter. And also the trials have shown that there is some reduction in irritability and impulsivity. And there is another one which is bumetanide. It hasn't come into in the market and has not been approved, but it's in the research level. It modulates the GABA, and it needs electrolyte monitoring because it can cause chloride level instability. And then if we can go to the next slide, sir. So we have talked about this. I will skip this slide because we have talked about the folic acid and the folinic acid. There is something in the market called quadrofolate. Quadrofolate still goes in by the regular folinic acid alpha receptor pathway. And it does increase folic acid in the blood. But however, folic acid in the brain, we don't know how much. Probably it is not as good as folinic acid, but maybe better than the normal folic acid. And sulforaphane also, we have just talked about it. It has got a particular pathway, NRF2 signaling pathway. And what it does is, there's a genetic master switch, and it increases the body, it helps the body to produce the antioxidants or anti-inflammatory substances.
Okay,
so next
thank
slide.
you. Actually, thank you. We are going to quick some studies which are going on the different drugs which are given. Thank you for your nice discussion, extensive discussion of the drugs. As there are a few minutes time, I will go through these drugs. Drugs L-carnosine, these are the different studies. I have done one study in 2025 for 36 children, only slight reduction of hyperactivity and irritability in some children, and slight improvement of the sleep problem in some cases. Omega-3 fatty acid, as it is randomly used, but actually review, including 2025 studies, conclude there is small or non-significant effect on overall ASD behaviors of omega-3 fatty acids. Now, this is one important drugs for discovery of this drug, got the Nobel Prize in 1977. It's from Italian scientist, the palmitoyl ethanol amide. Now, it can give rise to some sort of, it can reduce some core activity of autism spectrum disorders, also psychiatric distress like anxiety, depression, and strongest evidence are there. We are going to that strongest evidence of this. Neuroinflammation is also reduced here. Very well tolerated in children, considered safe for even long-term use, these ones. Quartifolic acid has, Moushami Madam discussed, the leucovorin, which is very difficult to get here. Quartifolic acid is available, and quartifolic acid can bypass the folic acid mechanism, and it helps in the cerebral metabolisms and helps in the core symptoms of autism. And these are the different contexts, how it acts. And current division 2026 is that double-blind RCD trial in young children less than 5 years with mild to moderate ASD found that quartifolic supplementation significantly reduced autism severity, measured by CARS-2 scale and improved hemoglobin levels also. So there are, it is not a cure, it works best as an add-on to our behavioral therapies also. Sulforan is a good drug. I think it is very safe drug also. Finding from Bocoli, and you see the recent meta-analysis summary of evidence in 2026, this year's. You see that if you give the 10 to 18 weeks of sulforan, it is supportive or adjunctive treatment of autism spectrum disorders. So these are the key clinical landmark in 2014 Johns Hopkins study, multiple 2024 to 2025 different studies showed that it is very helpful for 3 to 12 year child with ASD. Mechanism of action, Madam discussed just before, how it acts, anti-inflammatory axis, gut-brain axis, strong enough to activate ALS signal. Probiotics in autism spectrum disorders, there are some researches are going on. There are some evidence that some probiotics are may be used in say management of autism spectrum disorders, but these are all under study, all are going on, but still not accepted properly. So what is important is that, most important is that to use the concept of mirror neuron hypothesis. In the management of any behavioral disorders in children, the most important concept should be mirror neuron hypothesis. It means whenever we do something, whenever you are seeing me as giving lectures, your brain cells are also exciting. When a child sees other person is doing something, their brain cells are also doing same things. So thank you for your listening and giving attention to this discussion, and also my panelists were giving chairperson, so thank you.
Thank you, Dr. Datta, for your elaborate moderation over the ASD. And we know the autism spectrum disorder is a very complex neurological disease where the core symptoms are usually not addressed. It is the mainly management of the coexisting or comorbid conditions. But nowadays drugs are coming up which are thinking of attacking the main area of the problem because of more advent of, it needs more biologically active
of cases,
neurological tools.
71% of cases, they are not critical.
No.
71% cases.
Multimodulatory therapy.
37% cases only comorbidities should be treated along with the parental interaction. 34% cases, they are very mild. They can be improved by parental interaction. So pediatrician can treat 71% of cases. Only for the remaining patients, more and more therapist involvement, which is very much impossible in our setup. So we should stimulate the parents. We should involve the parents to take care of the child.
Biologically active neurological tools are also necessary, sir, regarding EEG, neuroimaging markers, what they are stressing, that these things may guide some way that where is the problem, where the neurotransmitters are problem that can be managed. But one thing I can think of, that there is a good saying that nowadays there is a change in understanding autism in a different way, that it take it as a human diversity and recognize it like that, other than it is a purely a medical condition which are waiting for the cure. In that case, it will have a large, broader societal change, but because everything cannot be changed. What I understood about the autism, is it true, sir?
No, it can be in autism, can be in remission in more than 70% cases. You can do in remission. And it is in 2017 in a conference in the AIMS. I was there along with the Minister of National Trust and Cephaloglutarity. I was present there in the hall, Science Congress Hall in Delhi. And there they declared that autism may be in remission. And now in this 2025 study, a genetic study shows that 71% of cases of autism may be in remission. But constant stimulation should be continued. Only in case of say 29% cases of you will have to give some more intensive therapy and other things. So autism is now a business of some persons. They are doing the business, taking the autism patients. So we, on behalf of the pediatricians, we should take care of these patients. We should stimulate the parents to take care of the child. Everything you do will give some impression on the human brain.
Thank you, sir. We cannot invite any question, I think so.
One question from me. That is the all drugs whichever told regarding the core therapy, all drugs is applicable for all patients, or there are some precision medicine regarding that particular patient?
Thank you. Thank you all. Oh, question is it allowed? No question. They are asking not to ask any question because they are running in late. So what can I do? Thank you. Thank you all the panelists.
Thank you all the chairpersons and the panelists and the moderator. Please collect your memento from the memento corner. So we will move on to our next session, which is on demyelinating disorders and stroke. For this session, may I like to invite Dr. Shukanto Chatterjee, Vice President, IAP 2026, Dr. Sumita Basu, Professor and HOD, WIMS. Sir, ma'am, please grace the stage.
Good afternoon, everybody. Now, at the end
I
of
will
the
also invite Dr. Anjana Chatterjee ma'am, ex-HOD, Arjikor Medical College.
Okay, now we start the symposium on demyelinating disorders along with stroke and epilepsy part 2. May I invite Dr. Debashish Panigrahi to give the first talk on management of new onset seizures in children. Dr. Debashish Panigrahi is currently associated with, he's a consultant pediatric neurologist associated with Ankura Hospital, Bhubaneswar. Please go ahead.
So, thank you, madam, for your kind words, and thank you, Dr. Sudeep sir, Joshodhara madam, and the whole team to invite me to this topic. So I have been asked to speak about management of new onset seizures in children. It's a very broad topic to finish in 20 minutes. So I made a very simple presentation which will be helpful for the residents and pediatricians. So today we'll discuss about definition, then epidemiology, clinical evaluation, investigation, recurrence list, treatment decision, how to select drug, and prognosis and counseling. So many of you must have attended the PET-1 course. The PET-1 course first slide is there. What is a seizure? Anything that seizes the patient is a seizure. So one has to understand that any paroxysmal event may not be an epileptic seizure. There can be lot of non-epileptic events, so it's a non-epileptic seizure, and when that event is associated with excessive and hypersynchronous discharge of the brain associated with that event, we call it as a epileptic seizure. And when the brain has a tendency to get recurrent unprovoked seizure, we diagnose it as a epilepsy. So coming to the definition of epilepsy, previously when we were students, it was taught that 2 unprovoked seizures 24 hours apart, you can diagnose epilepsy. But this 2024, this addition was made ki after 1 unprovoked seizure, unprovoked epileptic seizure, if you if you see that the chance of getting another seizure in next 10 years is more than 60%, with 1 seizure also one can diagnose epilepsy. And if you make a diagnosis of epilepsy syndrome, you can say it's an epilepsy. And many people when you call epilepsy is resolved, so when we call epilepsy is resolved, so when the child is seizure free for more than 10 years, or out of which more than 5 years should be of drugs, or sometimes when we diagnose is a age-dependent epilepsy syndrome, like your SELECT, self-limited epilepsy with centrotemporal spike. So most of the children outgrow it by adolescence. So when the child passes the adolescent age, very unlikely he is going to get that seizure. So we can say that this epilepsy has resolved. So this is some of the definition about epilepsy and seizures. Now epidemiology is that this is very common. So 2 things are important here. If you look at the pediatric age group, there are 2 times when the chances of seizure is high. One is your infancy and early childhood, where most seizures are more due to genetic etiology, congenital malformation, any perinatal insult like hypoglycemic brain injury, hypoxic ischemic encephalopathy. And another age group comes in adolescent, where your genetic generalized epilepsy like your JME, all this become more common. So many times parents comes and ask why my child started to have seizure in 10 years of age, 12 years of age, and were not earlier. So this is quite possible. Now this is just one slide about this 2025 update of classification of seizure. So you all know well versed about the 2017 classification. So now again the word awareness has been changed with consciousness, which include both awareness as well as responsiveness. Previously used to call it the focal onset seizure or generalized onset seizure. Now it is focal or generalized, because many times very difficult to see the onset of the seizure. So either say focal, generalized, or unknown. And so this is a major change in the new proposed classification of epilepsy. So when you see a child, parent comes there is a paroxysmal event. First when you see a child, always think it's a paroxysmal event. It can be a seizure or can't be a seizure. So don't go in a fixed mind parent will tell you my child got a seizure. So you should not think you should go with the open mind, it may be a seizure or may not be a seizure. And if you think, clinically if you think it's a seizure, then identify the seizure type. Then if the child is getting recurrent seizure, what is the epilepsy type? It's a focal epilepsy, general, combined, unknown, or can you make a diagnosis of epilepsy syndrome? So what is an epilepsy syndrome? You need three things. One is the seizure type, like West syndrome previously, or infantile epileptic spasm syndrome. So one seizure type is infantile spasm, the EEG signature is Hibbs arrhythmia, and a specific age of onset. Similarly, all these syndromes can be identified in this. Then coming to the etiology, the same thing holds. That can be previously used to say cryptogenic, symptomatic, and unknown etiology, idiopathic etiology, but in 2017 classification, it has been told as structural, genetic, infectious, metabolic, immune, and unknown. The last slide is last point is also important, because lot of epilepsies are associated with comorbidities, developmental delay, learning issue, behavioral issues, other psychiatric comorbidities. So never forget to identify the comorbidity, because addressing comorbidities along with epilepsy can improve the quality of life and better outcome. Now, we'll come to first unprovoked. So my talk is mostly based on this first unprovoked seizure, how to evaluate what to do in first unprovoked seizure. So as we have already discussed, the first step is to decide whether it's a seizure or not, an epileptic or a non-epileptic event. So there are a lot of non-epileptic events that can be confused in pediatric age group, syncope being the most common. Many patients of syncope, typical history of syncope, are on multiple anti-epileptic medications. So you should need to identify syncope, breath holding space, behavioral startle or inattention, movement disorder like tic and dystonia, long QT syndrome many times can present with arrhythmia and loss of consciousness. Migraine can be confused with seizure. And lastly, very common is psychogenic non-epileptic seizure, which is a major group of patients, many patients come. So these are some of the factors that favors a seizure, like sudden onset without a trigger, eyes open during the event. Many times PNES eyes are strongly closed, rhythmic sustained tonic-clonic, tongue biting, especially lateral tongue biting. Tip of tongue biting is more common in psychogenic episode, and lateral tongue biting is common in epilepsy. Then a prolonged postictal phase, Todd's paralysis, and recall of a preceding aura or focal symptom in some of the focal seizures. So these are some of the factors that help. Now how to evaluate? Now you have decided. So first thing is history. History is very, very important, because epilepsy diagnosis or seizure diagnosis is clinical, and clinical. So clinical history is very important. Always take a good history from the person who have seen the event, because we get second hand, third hand information. The event has occurred at school, the teacher has described to the father has described to the mother, and the child come to your clinic with the mother. So lot of things are lost in the way. So what you do? Give a call to the teacher, talk to her, take a detailed thing from the teacher, what happened, what she saw. Then only you will have a good idea about the event. So try to take a detailed description of the semiology or the whole event from a person who has seen it directly. Secondly, everybody has mobile. So always ask for video recording. If this is not clear or you don't know what happened, let the history evolve. Ask them to get a video recording, and there is a procedure of video recording from starting to end, what you are doing, whole body should be covered. So a proper video will help. And from the video, from the history, now you have decided that you are dealing with an epileptic seizure. Now how to evaluate the epileptic seizure? So EEG is very important. When you think of an epileptic seizure, all the recommendations tell that all children with unprovoked seizure, EEG should be done. In all children. If you think it's an epileptic seizure, EEG should be done. So yield of EEG in first unprovoked seizure may not be very high. There are various studies which have from 15 to 50%. Remember one thing, EEG is not used to diagnose seizure. EEG is mostly used to classify the seizure, epilepsy syndrome, and it predicts recurrence. When you will do the EEG? Many very common question. Patient has come to a seizure today. Are you going to do it immediately within an hour, within a day, 2 days, 7 days, 10 days, 14 days? So the thing is that you should be done early, within maybe 1 to 2 weeks. If you do an EEG very early, within 24 to 48 hours, the yield will be higher. The chances of getting epileptiform discharges will be higher just after a seizure, and the time progresses, it may come down. The interictal part may be normal. So, but it should be outpatient EEG, non-urgent. If possible, it should be done early. Otherwise, 1 to 2 weeks is a good time. And EEG is the strongest predictor for 2-year recurrence versus a normal study. A EEG with definite epileptiform abnormalities, the chances of getting a second seizure after a first unprovoked seizure is quite high compared to a normal EEG after an epileptic seizure. So, EEG is the strongest predictor. Sleep EEG, yield will be higher. So, when routine EEG is normal and you still think you have to get abnormalities in the EEG, then ask for a sleep EEG. Very procedure like sleep deprivation is a very important procedure. It helps the child to fall asleep as well as it increases the yield of the EEG. It's a provocative procedure. So, always possible, if possible, get a sleep deprived EEG. How to get a sleep deprived EEG? Ask the patient to sleep late in the night, maximum 3 to 4 hours or 4 to 5 hours of sleep. Ask them to wake up the child early in the morning, bring you to the OPD after a good breakfast, and most of the child may fall asleep in the EEG room. If not falling asleep, you can give a little bit of your medication like triclofos or melatonin, so that can help. The last thing is most important here. This line is most important. Normal routine EEG does not exclude epilepsy. So, you have seen the video. If you think it's a seizure, the child has come with multiple episodes, you did an EEG, came normal. You didn't start anti-epileptic, you say, no, EEG is normal, this is not seizure, will not start. Again 1 month back, the child again comes with the episode, still EEG is normal. So, EEG can be normal in 40 to 50% cases of epileptic seizure. So, interpret it with a caution. And one more thing is that an event which is non-epileptic, we think it's a typical breath holding spell. You asked for an EEG, somebody reported it as abnormal. That does not make it epilepsy or epileptic seizure. Still it is clinical. And most of the patients, this EEG we do are sleep EEG. This vertex surf, the hypnagogic hypersynchronies are very commonly reported as EEG, abnormal EEG. So take it with a pinch of salt. Whenever you are asking for an EEG, interpret it with the light, interpret it in toto, in the patient, the history, everything, rather than isolated. Don't take action based on the isolated EEG report. It should be done based on everything. So we are losing time. So this is a very interesting study which have looked at what EEG abnormalities can predict this recurrence higher. So they have found that when there are frontal paroxysm is a EEG, the chances of recurrence of a second seizure is higher compared to other areas of the brain. Again, this is a ILA recent published 2025 paper, and they have also said that epileptiform EEG discharges increased risk of recurrence after the first unprovoked seizure. MRI is not indicated in all the children with first unprovoked seizure. If a child has a brief, developmentally normal child, a brief seizure, and everything after that is normal, so MRI may or may not be considered in that scenario in all the cases, but it is if there are some features which will, the MRI, yield of the MRI will be higher when there is a focal seizure or a abnormal neurological examination, any focal deficit, the child with pre-existing developmental delay in small infant less than 2 years of age, and EEG showing focal abnormalities, there is a torse paresis persisting for a longer period of time. So all these things, the chances of positive MRI is higher, and always get an MRI with proper epilepsy protocol. So that's very important. Many times they don't do all the section that is required. So, and when you have strong suspicion and you are getting a 1.5 Tesla MRI is negative and you are still thinking it's a focal seizure, so 3 Tesla and higher MRIs can also be done. So it's a routine investigation, and urgent MRI is mostly not required in most of the unprovoked seizure, but when there is a persistent focal deficit or significant altered mental, because after a postictal phase, the child sensorium should improve, the consciousness should improve. If it is still persisting, any sign of trauma, any sign of raised ICP, then urgent neuroimaging, MRI or CT or MRI should be done. Now, routine blood test is not indicated for a simple non-febrile seizure in a well child. One case-to-case basis, you can go for glucose, electrolyte, calcium, magnesium when indicated. If there is sign of CNS infection, then lumbar puncture can be done. Genetic testing, this is important. So, with the availability of genetic testing now, it's easily available, cost has come down. So, our threshold for doing genetic testing has come down, and it's important also, because many times if you find a genetic etiology early, the precision medicine can help. A small baby getting recurrent seizure, if you get a SCN8A or a KCNQ2, then sodium channel blocker will be helpful in that scenario. So, like that, so if available and possibility, genetics, the low threshold for genetic testing should be there, but definitely children with developmental delay, family history of epilepsy, drug-resistant epilepsy, genetic testing will be mandatory. And never miss treatable causes like pyridoxine-dependent epilepsy in IEM that can be treated by some addition of molecule or diet, so that should not be mixed. Now, the recurrence risk, so overall recurrence risk in 1 year after a first unprovoked seizure is only 36%, and after in 2 years is 42 to 46%. That means a child who gets a first unprovoked seizure, only 40% around will get a second unprovoked seizure and 60% will not get another seizure. That's the rationale of starting anti-epileptic after 2 unprovoked seizures, where the chances increases to 70%. So, never be in a hurry to start anti-epileptic after a brief unprovoked seizure. Evaluate if there is a chances of recurrence is high, then we can start. So, what are the things that make the chances higher? That is more than 60%. A epileptiform EEG is the strongest predictor. Then remote symptomatic cause like prior brain insult or abnormal neuroimaging, abnormal neurological examination, significant developmental delay can also, and nocturnal and focal seizure. These are the 4 points which increases the chances of getting a second unprovoked seizure after a first unprovoked seizure. So, this was the recently published 2025 predictor prognostic factor predicting unprovoked recurrence in Cochrane review, and they have also found a similar thing like EEG is the highest probability, followed by abnormal imaging, torus paresis, family history of epilepsy and nocturnal seizure. So, if these features are there, you can start anti-epileptic after a single unprovoked seizure, because you will say that the chances is more than 60%. And so, whether to start or not, the studies have shown that treating first seizure lowers the risk of an early second seizure, but it does not improve the ultimate chance of seizure remission. So, if you start after 1 unprovoked seizure, the early chances in 2 years getting a seizure chances may be low, but the long-term outcome is not affected, and all the anti-epileptic medication has significant side effect. We use sodium valproate left and right. Most of the children I use sodium valproate has poor scholastic performance after 1 to 2 years of using it. So, don't think these drugs don't. Many of the drugs, even levetiracetam has behavioral side effect, other issues, oxcarbazepine has issues. So, all the anti-epileptic drug has a side effect, and again when started it has to be contributed for a longer period of time. Therefore, one should be cautious when starting this anti-epileptic medication. So, time is running out, so we will go fast. And these are the drug choice like focal, and you all know this, so we will just keep it. Just in generalized epilepsy, avoid carbamazepine or sodium channel drug like carbamazepine, ostarmine, gabapentin, pregabalin, vigabatrin. In generalized genetic generalized epilepsy like absence JME, this drug should be avoided. And these are some of these common epileptic syndrome we see, and we have to select the drug based on the epileptic syndrome. Just I will highlight infantile spasm, that's very common, and very commonly we don't start, we write it as myoclonic epilepsy and don't start this steroid or vigabatrin, and it's a medical emergency. So, whenever you think it is infantile spasm, treatment should be started immediately. So, one slide on status epilepticus. Now, the concept is time is brain. The more delay you do in responding, more neuron loss, and once neuron is lost, it can't be regenerated. So, there will be long-term effect. Therefore, previously like wait 5 minutes, 10 minutes, now they have done away with most of the thing, and whenever a child comes seizing to the OPD, work in a rapidly so that you can control the seizure before 30 minutes, before permanent brain damage occurs. So prognosis, again, 50% is, and whatever you do, there are 1/3, 25 to 30% children can develop a drug-resistant epilepsy. So recurrence risk drugs after 2 years of seizure-free interval. Cognitive and behavioral outcomes are strongly tied to the underlying etiology rather to the seizure control. And mortality with single unprovoked seizure is low, but a child with uncontrolled or difficult epilepsy definitely should be discussed. This is parents' depression and anxiety, so counseling is very, very important. Never forget to write, just one line, never forget to write this rescue medication. Any child with epilepsy, even if brief seizure also, rescue medication, so you never know the child can get a status epilepticus. So always write rescue medication that can be life-saving. So take home message, last slide. So confirm that it is truly a seizure. EEG for every child, MRI is a preferred imaging. Most children will not have a second seizure. So if there is a significant risk only, then only start anti-epileptic after first unprovoked seizure. So when you think this recurrence risk is more than 60%, start and choose the drug based on the epilepsy type or epilepsy syndrome. So confirm diagnosis, establish seizure type syndrome, evaluate the need of treatment, select the proper AED, definitely start with monotherapy, 1 or 2 monotherapy, then you can go to polytherapy or another monotherapy or polytherapy. Thank you for your patient listening.
Thank you. Thank you, Dr. Panigrahi. And you said that diagnosis is clinical, and clinical.
Yes, sir.
Yes.
It's always clinical.
That's very important.
I just want a quick clarification. So you are sure that it's a seizure and there is an EEG abnormality. Should we wait for the next seizure or start an anti-seizure medication? First, unprovoked
EEG is normal.
EEG abnormal.
If
EEG normal, we can wait. But if EEG is abnormal, we should start, right? What is the take?
If EEG is truly abnormal and you get epileptiform discharge, true epileptiform discharges like a spike wave or a sharp wave, and you feel it is significantly abnormal, then definitely it should be started. Otherwise, chances will be high. That again, with parent, even if one also we start sometime after parent discussion and on the scenario. Thank you, sir.
The next speaker of this session is, he has got in his account, he is DNB DCH FIAP, National Secretary of this Central European India, and he is very much associated with these academic bodies. He is the Vice President of Maha-European, Treasurer, etc., etc. And also he is interested in this pediatric epilepsy along with metabolic disorders. He will be addressing a problem of MOGAD.
Good afternoon, everyone. I think everybody is alert and awake because the tea break has just done. So there is a little complex topic, and Jasudhar always give me such topics, MOGAD. So at the outset, I want to thank the organizing committee, once again, the chairperson, for the kind introduction and inviting me here for this topic. So Dr. Lokesh sir has made my task relatively easy because he has very well covered ADEM, multiple sclerosis, NMO spectrum disorder. So what is this MOGAD? So you all know that the brain consists of the neurons and the glial cells. There are supporting cells which supports the basic neurons, which conducts an oxygen potential, and there are glial cells which supports those neurons. So this is how the glial system is consist of oligodendrocytes, which provides some myelination to the, these are the neurons. And there are astrocytes, which is basically, so oligodendrocytes not only have a myelin sheath role, but they act as an immune cells to the brain. Second is the astrocytes, which are primarily regulating the neurotransmitters and the metabolites to the neurons. And so these are the 4 cells: astrocytes, microglia, oligodendrocytes, and the Schwann cells in the periphery. So basically 3 glial cells are there. So why I am telling you this all? Because this MOGAD, what is MOGAD? Is myelin oligodendrocyte glycoprotein antibody associated disease. So earlier we used to see a lot of cases of ADEM, like acute disseminated encephalomyelitis, but a part of that has turned out to be in MOGAD. So these are the inflammatory demyelinating disease of the central nervous system, where there is antibodies to the myelin, MOG, it is called as oligodendropathy. So primarily it's a cell, it's a pathology related to the oligodendrocytes. I think that is something which we must understand, and that's why we should know the basic things. So what happens is there is a trigger which stimulates the MOG sensitive B cells, and there is a differentiation into T cells, and then whole immuno cascade starts. This is the pathophysiology of MOGAD, and we'll not go into the much of details, though it's a relatively theoretical talk initially. So how does it matters clinically to us? So episodes of the pediatric demyelination is categorized into a first attack of demyelination and then the subsequent attack of demyelinations. So what is common in children? See, overall if you see, the polyfocal syndromes are more common. What does polyfocal means? They usually presents with, what is the presentation of otherwise demyelinating syndrome? They may have seizures, encephalopathy, and what is important thing is they have motor deficits, polyfocal motor deficits, which may usually asymmetrical. यहाँ पे भी weakness है, यहाँ पे भी weakness, reflexes brisk है. Those encephalopathy syndrome is likely to be ADEM spectrum. So ADEM is a polyfocal syndrome. So ADEM constitutes the total out of the total demyelinations. ADEM constitutes 29 to 32%. Other clinically isolated syndromes 21 to 34%. And monofocal syndromes are more common in adults. So isolated optic neuritis contributes to around 20-23%, and isolated transverse myelitis 9 to 25. And there's all NMO and all constitutes 1 to 3. So relatively rare than the adults. This is how the presentation look like. So if you treat this episode of demyelination with steroids with the usual tapering doses, what you treat for ADEM, what happens next? 30 to 50% progress to a relapsing demyelinating syndrome, which is a fair good number. 1/3 of them do remit. How do they remit? They remit in the form of relapsing, remitting form of multiple sclerosis. They may remit in the form of MOGAD. Like presentation, they may have NMSOD or antibody negative recurrent demyelination syndrome. This is how the demyelination spectrum is current understanding. So how did this started? This is a wonderful lecture by Dr. Khadilkar sir. You need to be curious rather than to be sending for the papers. You have to be curious. And there was a curious person. You know him? He's Eugene Devic. So he was a French neurologist, 1858 to 1930, who published first paper on the possible association of the lesions, demyelinating lesions in the spinal cord and the and the optic nerves. So this association, he has documented few cases. He has seen that association. This is a French neuromyelitic optique this was his first publication in 1894. And that was the first time we felt that the demyelination can be this. Just imagine this is not an era of MRI or a CT or radiology. Still he could figure out the localization was down to that part. It took almost 100 years to come up with a new scientist. She's a Simone Madder, who reports possible involvement of anti-MOG antibody. So first was a MS and those NMO spectrum, and then came this MOG disorders. So it came first in the literature in 1980s, but turning point was 2011 when this lady has developed a cell-based assay to document this antibody, and now we can categorically say that this is an entirely new spectrum of demyelinating disorder. So MOG antibodies, what is this? What are these antibodies? Is usually found in the monophasic optic neuritis and transverse myelitis, and almost they are very common to the extent that 50% of ADEM may have MOG antibody positive. So this is a really alarming one. So you see day in day out the cases of ADEM. Almost all children of multiphasic ADEM have MOG positivity. It's found in the patient ADEM followed by optic neuritis, relapsing inflammatory optic neuritis, and the relapsing brainstem demyelination, and aquaporin 4 negative MSOD spectrum. So if you have MSOD but aquaporin 4 negative, you are likely to have MOG positive. But do this antibody causes a pathogenicity? That is still questionable, but they still feel that it is likely to be pathogenic. How does MOGAD clinically present? They may present in the form of edema as a first manifestation, associated optic neuritis as a first manifestation, MOG associated and transverse myelitis, associated with the brainstem syndrome, associated with MSOD-like syndrome, associated with the cortical encephalitis. So usually it has a multiple ways it can present to you. So any episode of edema or the demyelination, will you go for this antibody? Yes or no? Likely to be yes. So MOGAD presents with the 3 core phenotypes. The edema is 37%, this is in children, 40% optic neuritis, and rest transverse myelitis 14%. But don't forget that it can present the bizarre way it's possible, because this demyelination disorders are a gray matter pathology or white matter pathology? White matter pathology. Myelination means white matter. But they may present as a encephalitis syndrome, as a cortical encephalitis. Yeah? So then white matter, it may have a multiple sclerosis, optic neuritis, myelitis, and it may present aseptic meningitis also. So these are relatively uncommon, but you should be aware of these entities. So this is a common cause of demyelination. If you see the MOG IgG result, it's positive in 32% of the demyelinations, negative in 68. And if you see less than 11 years, it accounts to almost 50%, 47 positive. So it accounts to the huge spectrum of demyelination in children. That's the take home. So this is again a study which tells you about the age of onset and the number of patients. You can see the edema is the one which is more common, less than 11 years, and then the other optic neuritis and transverse myelitis. But now we have 2024 onwards, we have an international consensus criteria when to code MOGAD. So what is the important thing about this criteria is all the criteria are must. The core clinical demyelinating event has to be there in the form of optic neuritis or myelitis or edema or focal polyphasic deficits or brainstem or something like that. It should have a positive IgG test. So serological criteria is also equally essential. We'll go into the details, what is clear positive, low positive, without reported titer. But this criteria is something which is very important. And the third is a MRI feature. You should have a documentation of optic neuritis, myelitis, or brainstem or the cerebellar syndrome. So 3 things are equally important now to diagnose this. In reality, is it straightforward? Because this criteria is easy for those consensus committee to set. But for the practicing person, pediatrician or pediatric neurologist, it always remains a challenging, because sometimes you get the lesions look like a NMO, but MOGAD is positive, you say antibodies are positive, or clinical presentation is different. So limited familiarity, low index of suspicion, though do they have a heterogeneous disease course, they may have a clinical or radiological presentation that do overlap, or they may have a monophasic episode with mild to moderate disease, may be overlooked or sometimes isolatedly present. But overall, if you see the demyelination, because you have seen the presentation in the morning, what I can say is a MOGAD is an oligodendrocytopathy. And MSOD is a astrocytopathy. This is a newer thing which has been coming up. And so we have a MOG and IgG antibody, which is present in MOGAD. Aquafurin 4, that is an NMO antibody, IgG, present in NMO spectrum disorder. And the oligoclonal band is suggestive of MS. That's why these are the basic investigations which you send in the patients of demyelinations. And then the optic nerve, if it is unilateral and mild, goes in favor of MS. If it is bilateral severe papillitis, it goes in favor of MOGAD. And if it is associated with chiasmatic lesions, it goes in favor of NMO. Short lesions are common in MS, long segmental sinal lesions are common in NMO and MOG antibody. But very important characteristic is, if you have conus medullaris enhancement, if you have conus medullaris lesion, it's very likely to have a MOGAD. This is the recent studies which talks about this. And then if you have a periventricular subcortical U fibers with Dawson's fingers, it goes in favor of MS. If a fluffy or cortical subcortical hyperintensities goes in favor of MOGAD. Area postrema, periependymal region goes in favor of NMO because of the location of those specific receptors. Okay, so these are the basic core features. So if both the things are negative, and if you get an oligoclonal band, this is multiple sclerosis. If this is positive aquafurin 4, this is NMO. antibody-wise. So serological way, this is the way we differentiate it. So we got the thing that it is a antibody-mediated perivenous demyelination, which has a complement-mediated perivenous demyelinations lead to myelin sheath damage, and that's why this causes a profound lesions. So let's see how does it look radiologically. So suppose if you have bilateral, can you see those bilateral optic neuritis? If specifically this is long segment demyelination, and if you have central cord signs, this is called H sign. Can you see that H? So this is a central cord sign which you see in MOG. If you have conus lesion at the end, if you see those lesions, this is MOG. If you see multiple T2 hyperintensities, if you see deep gray matter in edema suggestive of MOG, then middle cerebral peduncle, cerebellar peduncle. So if you have middle cerebellar peduncle lesion, you know middle cerebellar peduncle is pontocerebellar fibers. So if you get this, this is again a MOG, likely to be MOG, and if you see such cortical lesions, it can be MOG. So this is how we differentiate. There are so many differentiating finds. I don't know we should cover or not. So this is middle cerebellar peduncle, this is a superior one, and this is the inferior one, which is present with the MS, and this is a superior one with the MSOD. So the location of the lesions, the intensity of the contrast enhancement, or a good radiologist if they are available with you, and if you can see those films, you can fairly make a differentiation whether it's going towards an MOGAD or MS, an MOD or MS. And then the signature patterns I already told you. And the most important, don't forget this conus medullaris, or if you are lumbar lesion, which this H-shape of sign is very suggestive of MOG1. So let me ask the question, does this pattern, so there are 8 patterns, this is a very recent paper, 2026, they talk about the different patterns what we get in MOGAD. Does this pattern guide you to the treatment or can tell you about the possible prognosis? To some extent, yes. If you see this typical sparing the juxtacortical region, usually it's a benign. They usually respond very nice to the IV methylprednisolone. If you get a symmetrical one, this is again a better involvement. In children, we see a deep gray matter or asymmetric lesions. Again, it has a good prognosis. But if you see a leukodystrophy kind of pattern, sometimes you get a leukodystrophy. Patient have sent the clinical exam for that, but it turned out to be a MOGAD later. So if this pattern is there, it is a poor prognosis. Tumefactive pattern. So this is a tumefactive, looks like again a tumefactive demyelination if you got, you please send MOG. A lot of them come out to be MOG positive. You usually non-respondent to the immunomodulation. The typical pattern is a flame. This is another pattern. This is a flame shape, flames. This is again a malignant pattern, which usually presents with the refractory seizures. If you have this type of pattern, the medial enhancement, can you see those patterns? So hyperintensities on the medial part of the brain, it's usually a benign pattern. They usually very well respond to the methylprednisolone. And if you see a unilateral one, have you seen the patients with the unilateral focal seizures which do not respond? You suspect it to be Rasmussen's, but the workup comes to be negative. These are MOGs. So these are the 8 patterns what we see. So this is about the radiology. What investigation you need to send, because the second part was a serology. So cell-based assays to be sent. So because this pathology is at the internode, so there are now nodopathies, paranode, juxtapanode, and then internode. Here lies the MOG antigen and then produces an antibody. So what we supposed to send? IgG antibody. ELISA is not reliable. You need to send a cell-based assay. The specificity is almost 97.8. Low titers may be false positive. And this is how the positive and this strongly positive look like. So which test to be ordered? Send a cell-based one on the flow cytometry. If the titers is more than 1/110, it is clear positive. If it's less than 110, 1/100, it is low positive. So if you are sent an antibody and you have treated the thing, will you repeat an antibody? How many? Yes? Yes? Should we repeat a MOG antibody if the sample is initially negative? So suppose if it is negative, how long does it stays positive? So they did a study for the 5 years. If the MOG negative earlier, they remain 99% negative. So no need to send a sample again if it is negative, because it's very specific test. And the positive, 36% persistently positive, 57% conversion to the negative, and 7 may have a fluctuating status. And on the basis of the non-ADEM and ADEM, they have categorized into 2 forms. So I'll not go into much of those details. Does seroconversion predict relapse? अगर पहले पॉजिटिव था फिर नेगेटिव हुआ, कैन इट प्रेडिक्ट अ रिलैप्स? और पॉजिटिव ही है, दैट मीन्स इट इज गोइंग टू रिलैप्स. So the answer to this is again this study, which remained persistently positive in 56, 31% converted to negative, and fluctuating in 12. So inconclusive. So this doesn't have a titration with the seroconversion. And this is how the big paper, how this started and what was the relapse. A very nice detailed one. Should we order, so what do you send? What you send a serum anti-MOG or a CSF anti-MOG? Who is for CSF? Serum. Because this is again a paper. So if you have a seropositive MOGAD, only 61% have CSF positivity. So chance of having a serum is very high. So do not send a CSF anti-MOG, only send a serum one. And the standard management protocol is star-strolled. We'll go into the details of that. Let's see if the case 1. 2-year-old male child with a normal birth, developmental history, fever since 5 days, altered sensorium since 3 days, seizure since 1 day. On an examination, 8/15 GCS, tone is normal, but the power is asymmetric. Can you see 2/5 in left lower limb and 3/5 in right lower limb? So if you see an asymmetrical focal motor deficits in any child with an acute encephalopathy syndrome, think of demyelination. If your DTRs are brisk and your raised ICP is not that pronounced. So CSF we did mild pleocytosis, proteins are 40, sugars are 60, viral panel is negative, MRI spine was normal, and can you see those fluffy asymmetrical hyperintensities which looks like a cotton balls? So what is this? This was MOGAD. So most common phenotype in young children, prolonged fever prior to the onset, classically bilateral extensive confluent fluffy lesions involving juxtacortical white matter, deep gray matter, and middle cerebellar peduncle, nodular contrast enhancement or leukodystrophy-like pattern or tumefactive, think of MOGAD. I have already talked about this. So monophasic course in 50% of the cases of all MOGAD, and had a good outcome. Let's go to case 2. This is 9-year-old female with a complaint of acute diminution of right eye. So it's a unilateral optic neuritis. So we'll not go into details. MRI spine, can you see those contrast enhanced optic neuritis? So VEP is abnormal on the right side. So this is MOG antibody associated optic neuritis. Again, bilateral in 50%, recurrent in 50%, associated with papillitis in 86%, perinular enhancement in 50%, and you need to do an MRI. Don't forget to do an MRI in cases of optic neuritis or edema if you have this finding specially, because it's a acute disseminated encephalomyelitis. So myelitis should not be overlooked. 13-year-old male presented with the fever since 5 days, headache since 3 days, drowsiness or acute onset of weakness. So given me 25, now I need to take 2-3 minutes. GCS 12/15, hypotonia in bilateral lower limbs, but the DTRs are base. Sensory level T8. What is this? This is transverse myelitis, but if you see a long segment lesion, always send a MOG antibody. This turned out to be MOG antibody associated transverse myelitis. Lesions are usually contiguous or patchy, multifocal. Don't forget this predilection for the conus medullaris, affect both gray and white matter. That leads to this H kind of pattern. Can you see that? So if you see this central pattern, this is very likely to be a MOG. And there are 2-3 more patterns, MOG associated encephalitis, which is a distinct than the demyelinating phenotype. Usually the symptomatology is fever, aphasia, stroke-like episodes, and working memory deficits. More selective cortical involvement. Though it's a white matter disease, may have a cortical involvement, and chance of having a severe brain atrophy and the focal neural deficits is very high. Another very important entity you must be aware, that is flames. I talked in a short while. Flare hyperintense lesions associated with anti-MOG antibody associated encephalitis with seizures. That's the full form of the conditions. And this is how it looks. It looks like as if the flame is there. So leptomeningeal enhancement along with the cortical lesions, marked pleocytosis, usually presents with a seizures status which is often refractory. Then NMOSD-like presentation. So red flags for the severity: if you have bilateral optic neuritis, 32%, unilateral 11%, if you have encephalitis with seizure, 37%, if you have short myelitis, 11%, long myelitis, 40%. So this is a chance. So these are the percentage of the sequelae, white matter lesions, or the outcome. So again, if you have a refractory, what are the pointers? More than one relapse per year, or relapsing trend before 2 months, or if you start the therapy, you don't get the desired results, or at the onset, if you are refractory seizures or encephalopathy, progressive or in spite of immunotherapy, these are all the red flags. So I talked about, so treatment, I told you the methylprednisolone, 30 mg per kg per day for 5 days with a subsequent tapering of steroids, but very long and a very gradual tapering of steroids, unlike ADM. So it depends on how early the child responds, what are the radiological lesions, and there is no consensus the way this has to be treated this way, but more or less what are the patterns I told you, these are the guiding tools for continuing the treatment. Though whatever you do, 20 to 30% are non-respondent even if you treat the best possible way. So what is the second line is immunoglobulin. When there is a contraindication or inadequate response, give 2 grams per kg over 2 days. And then there is a recent paper which talks about monthly IVIG if it responds initially to reduce the recurrences. Plasmapheresis, second line rescue therapy, 4 to 5 cycles on alternate day, indicated in bilateral optic neuritis or transverse myelitis or fulminant encephalitis. These are the 3 indications added by the committee. Rituximab, does it work? It actually doesn't work that well because it's not the CD20 which is involved in the pathogenesis. Does the tocilizumab work? Does not work that way because this doesn't affect the IL-6 as well. But what works is the oral drugs, like the mycophenolate mofetil and the azathioprine for the prolonged therapy, partial non-respondent to the steroids, the usually one. What is new is FRN antagonist. This actually blocks the IgG recycling, lead to sustained and the rapid depletion of this antibody. I'll not pronounce this drug, it's very difficult to pronounce. Rosalilizumab, I don't know. Iflagor, I can't read that. So phase 3 trial is going on, but I think easy name will come as a brand. So follow-up, after 3 months you must get an MRI done. Better not to do these antibodies because the prognosis is variable. What are the take-home messages? The international consensus criteria exists for the MOGAD, and please follow those protocols. Do not overdiagnose, do not underdiagnose. Understanding the pathological mechanism can lead to a better prognostication and the therapeutic option to be decided. Both the monophasic and the polyphasic presentation of MOGADs are known, and we lack the precise radiological or the serological predictors for recurrence. However, we have few radiological patterns which can guide us for the therapeutic intervention. Need prolonged immunotherapy and gradual tapering and aggressive immunomodulation in the refractory cases, and new promising therapies on horizon. Thank you so much once again, Team Kolkata, West Bengal, and the entire organizing team of East Neuropedicon, and a beautiful audience which stays till 3, 4, 5 p.m. This audience is not seen across the country. Thank you so much.
Thank you, Vinit, for this elaborate discussion. As because of we are running shortage of time, so there will be no question from the floor.
Thank you.
Any question from the floor that will be discussed on floor or over the tea? Thank you so much.
Well, may I now request Dr. Jitendra Sahu to present his presentation on infantile spasms. Yes, Dr. Yes, Dr. Jitendra. Yes, please start.
Thank you very much. It's great pleasure and privilege to be here and to speak here. Whenever I come to Kolkata, it gives a very divine feeling. So, and the topic is infantile spasm syndrome. The topic is very close to my research interest. 15 years ago, when I started, it was very Cinderella branch. But over a time, I learned many of the important things, so which I would like to share. Infantile spasms is one of the most common cause of severe epilepsy in infancy. And there are so many issues are there. The moment you make a diagnosis of infantile spasm syndrome, it is an ominous diagnosis. It means the outcome will be poor. But in a proportion of the cases, you can make a lot of difference and can save the child from the ravages of this disorder by the early recognition, appropriate diagnosis, and the right treatment. So I would like to give you the 3 important principles. Number 1, how you should be able to make the appropriate diagnosis at the earliest. Second, the importance of the etiology recognition. And third, about the to empower you to make the right therapeutic choice for the infantile spasms. So just to give you historical perspective, before the NMO, it was 1890, it was 1840. So it started, but now the landscape is completely changed. Now it's no longer the same, which we used to learn. It's completely different. Just if anybody has not seen, to have on the same page, it is like a 10-month-old child with a history of hypoglycemic brain injury. Will come to you with a history of developmental delay, focal motor seizures, and then develop epileptic spasms. These are the clustered epileptic spasms. You will give home recorded videos. MRI, you will see the clear-cut MRI signature of hypoglycemic brain injury. So this is a typical scenario. So first, we have to understand what is epileptic spasms. Please remember, one should not misinterpret it from the tonic seizures and myoclonic seizures. Myoclonic is very fast and tonic is little long. So half to 2 seconds is the usual duration, and that this is very important crescendo, decrescendo phase is there, which I will show you. Those who wish to learn semiology, it may be in the flexor, extensor, and the mixed, but please remember it is the term for a truncal contraction. If it moves towards forward, it is a flexion. If backward, it's extension. If it happens in a mixed pattern, it's a mixed. And please remember, the epileptic spasms may be focal, it may be generalized, or it may be unknown onset. If you see the focal features in there, but MRI shows normal, then it is unknown onset. If clinical semiology is focal, MRI also suggests concurrence with the focal abnormalities, EEG also suggests focal abnormalities, then you can label it as a focal epileptic spasms. Please always look for asymmetry in the epileptic spasms among the sides of the body. That's very important, which I will highlight you subsequently, because it points towards underlying structural etiology, and moment you identify that, it has a underlying treatment implications. So please look at the focal signs also very carefully. Even the seizure may look, spasms may look apparently symmetric, but if you look at the, there is focal eye version is there. The moment you recognize these focal signs, it always very strongly points towards the underlying structural etiology. So that is there. Many times it just points toward underlying focal cortical dysplasia, the underlying which may be missed in the MRI. So this recognition of the focal sign is very, very important and crucial. Epileptic spasms may happen in an alternating spasms pattern. You can see here it's because of in this condition the corpus callosum was dysgenetic. So both hemispheres were firing in an asynchronous manner, so the spasms were alternating. And also please don't miss to recognize this important subtle epileptic spasms, in which parents इसको just बोलते हैं कि बहुत silent से spasms seizures होते हैं. पहले तो मेजर सीजर्स होते थे जो क्राइंग के साथ होते थे, अब एकदम साइलेंट होते हैं. पर अगेन यू शुड नॉट मिस दिस सटल स्पाजम्स, जस्ट फेस पे हल्का सा ग्रिमेसिंग चेंजेस आते हैं. The moment you recognize this, it has to be treated in the same aggressive manner like you used to treat the conventional epileptic spasms. And it may happen in a, you can see, gelastic form of epileptic spasms can also be there. Again, the EEG revealed the video EEG monitoring. It was a characteristic hips arrhythmia with the ictal manifestations. So one has to recognize the subtle forms of epileptic spasms also to make the diagnosis of a peculiar seizure type. And the burden of spasms, one should try to count number of spasms per cluster and number of clusters per day if possible. Otherwise, try to monitor with one major cluster in a day. So, and among all the variables, only the asymmetric spasms points towards underlying structural etiology. That is very important. So the moment you diagnose asymmetric spasms, it tells you there is underlying structural etiology is there. Rest of the variables are not shown to be associated with the etiology or the treatment response. And similarly, status of epileptic spasms we have also seen when it lasts more than half hour. And the moment it is there, if you treat it with the IV midazolam, it responds very well. So that's an important point. So hips arrhythmia is one of the very important EEG signature of infantile spasms that was initially described in the Boston Children's Hospital by Dr. Gibbs and Gibbs. Two important features are there. Number one, there is high amplitude slow activity are there, and second is the random spike wave abnormalities are there. So this is the combination. So if you capture a sleep EEG, you are definitely going to capture hips arrhythmia if it is there. It may miss if there is a you only obtain the EEG during wakefulness, so that is very important. But sometimes the caveat is if you have a severe form of HIE, when the brain is encephalomyelitic, you may not see the hips arrhythmia pattern because brain is very much attenuated. So sometimes in those cases, people misinterpret and they think it is not hips arrhythmia and don't consider it as a infantile spasm syndrome. So that is important. So the moment here you see this is in this hips arrhythmia pattern, you will see that there is a grouping of the IDs are there. So people often report it as a burst, but these are not the burst. This is the grouping of the IDs which happens during the sleep. This is a very important feature of the hips arrhythmia, and it tells you that it is a state of epileptic encephalopathy, and therefore it has to be treated in a very urgent manner, and so you can't wait. So at our institute, we have made a protocol. The moment case with infantile spasm syndrome comes, within a same day they get under EEG. Even if they don't, but please remember, if you don't have a EEG facility, treatment should not be prolonged. You must start treatment at the earliest if you are clinically convinced that this is an infantile spasm syndrome. So the recently ILA has given diagnostic criteria in which they have said that even the hips arrhythmia is not mandatory. Even if the suggestive EEG abnormalities are there, you can label it as an infantile spasm syndrome. Please remember, thus just the presence of epileptic spasms won't make it infantile spasm syndrome. Epileptic spasms may be there in the Lennox-Gastaut syndrome, which is older than 2 years of children, and younger kids also below 2 months of age in the Otahara syndrome, etc. So it is a peculiar age group, peculiar seizure types, spasms with the suggestive EEG. So that makes this diagnosis of infantile spasm syndrome. So there are a rating system also there to classify that this particular EEG will fit into the diagnosis of hips arrhythmia. So their Bassett score is there. So one can read it in detail. So that's very handy tool. At our institute, we are using this for the scoring hips arrhythmia and the monitoring the therapeutic response also. Just to show you the you can see in the EMG, you can identify the clear-cut rhomboid formation happens when the epileptic spasms happen. So during the EEG, if you place the ictal EEG, this EMG on the bilateral deltoid region, you can easily identify this rhomboid formation. So these are the epileptic spasms which happens in a cluster, and simultaneously there is a high amplitude slow wave comes. So that is the features of the ictal hallmark of the epileptic spasms. So we looked at what are the various ictal patterns. So there is wide variability of the ictal patterns are there during the infantile spasms, but none of the factors predict either the underlying etiology or therapeutic response. So it doesn't matter what is the which type of ictal manifestations are there or not there for a practical point of view. So hips arrhythmia may be there just in one hemisphere. The moment if it is there in just one hemisphere, we call it hemi-hips arrhythmia. And this is one of the very important surgical candidature. It is very commonly there in the Sturge-Weber syndrome, hemimegalencephaly, focal cortical dysplasia, which is very widespread, or the perinatal stroke. So please don't miss this hemi-hips pattern. It is a very strong surgical candidature, and if the treatment is not, kids are not responding to the treatment, they are having should be evaluated for surgical candidature. Lesioncephaly may not have a full-fledged chaotic appearance. Here you can see the high amplitude beta-like activity you will find. So this is the EEG signature of lesioncephaly, even in the associated with infantile spasms. I will leave that. So what we identified that the median treatment lag for recognizing this condition in our country, at least at our regional area, was 3 months. So that is something very alarming, because the moment if the treatment lag is beyond 2 weeks, it impacts the treatment outcome. So it has to be, so we looked at what are the various regions that there is a treatment lag is there. We identified 3 important regions. यदि वो पहले ही बच्चे को डेवलपमेंटल डिले है तो पीडियाट्रिशियन सोचते हैं ये जस्ट अ पार्ट ऑफ द डेवलपमेंटल डिले एंड बेबी इज जस्ट जर्किंग. सेकंड, इफ द पेरेंट्स आर not literate, so they don't come to the doctor. And third is sometimes the pediatricians are not able to recognize this condition. So we have to try our best to mitigate this treatment lag at all level. We look at what are the various etiologies. So number one etiology what we identified is the structural acquired etiology. So it's very important, but it is also a challenge for us how to mitigate this acquired brain injuries, the parietal insult, the hypoglycemic brain injury. So neonatologist and pediatrician has a very important role. And tuberous sclerosis complex, the moment you diagnose, the treatment choice changes from the hormonal therapy to vigabatrin. So, and there's various genetic metabolic conditions are also there that looks like infantile spasms. So, and even there are sometimes metabolic disorders, they just present like epileptic spasms. Here you will see there are subtle clues are there. The ecchymotic patches over the body, no parental background, acral cyanosis, and you perform TMS, GCMS, it shows ethylmalonic aciduria, so diagnosis is ethylmalonic encephalopathy. A wide range of metabolic conditions may be there. So if you don't have an underlying structural etiology history, please evaluate carefully for the metabolics and the genetics etiology. Anyone can make out what is the diagnosis. So this is a Menkes disease. Hairs, it was not very visible. So just to alert you that there are a wide range of conditions which can mimic like this. So genetic landscape of the ISS is very wide. And even we have seen the cases, NGS, it may didn't turn up, then we did the mitochondrial sequencing and it shown the mitochondrial pathogenic variants were there. Among the chromosomal causes, the trisomy 21 is the most important cause. It was a multi-center collaborative studies. From the southern state, the pyridoxine-dependent epilepsy was reported to be presenting as an infantile spasm syndrome. So that's something important. If we don't treat this condition very earliest and aggressively, it may progress to the LGS. So that's something very important. And this disease, often there are a lot of comorbidities are there, and the comorbidity recognition should also go in parallel. So for the apt treatment and the diagnosis. So that is also a very important point for this. So among the treatment options, you will see a wide range of treatment options people practice globally. So even the last presentation, I've seen that even the nice, there are people use ACTH, some people use oral steroids, some use combination. So which one is the treatment choice? I will quickly go whether hormonal therapy is superior to oral vigabatrin. So now the converging evidence is there that clearly says that hormonal therapy is superior to the oral vigabatrin therapy in achieving the short-term cessation of spasms. Long-term outcome is better if you achieve it with the hormonal therapy. So that's very important. So in the last presentation, I saw the combination therapy was written because even if you read the British guideline, they write ki use combination therapy, that is preferable. But if you look at the evidence very carefully, so there are two papers, one from the Dr. Finbar from the UK that showed the combination is better, other from the US, if you combine both together, so treatment is not there is no great convincing evidence. So if suppose you start hormonal therapy, some child become completely seizure free. But if you use combination therapy, you are unnecessarily going to keep the child on vigabatrin for 6 months. So in our practice, combination therapy is not at all recommended. You please use the sequential therapy. It is a British guideline. We don't follow it at our center. And again, if you use the combination therapy, there will be cost escalation. There will be unnecessary side effects of the vigabatrin and hormonal therapy, both will be there. There is no problem if you use it sequentially. If hormonal therapy fails, you can within 2 weeks you can decide. And it is not a synergistic combination. We also tried whether the hormonal therapy with pyridoxine is superior. It was from the West Bengal. Arundhati was our student who did a clinical trial. That if you combine the high dose pyridoxine with the hormonal therapy, it will make better sense. Again, we observed that it's not at all a better solution. And one should avoid the combination therapies as far as possible. So again, one question is ACTH versus oral steroids. So it is a very challenging issue, and this is the network ranking of the various therapeutic interventions. And you will see the high dose hormonal therapy is better over the low dose hormonal therapy. But there is no major difference from the high dose hormonal therapy, ACTH versus oral steroids. So that is what the global experience is. But if you ask my experience, so ACTH has some age of superiority is there over the oral steroids. So at our center, we use high dose ACTH therapy injectable as a first choice for 2 weeks. Please remember, the US में जो ACTH use होता है, that is a natural ACTH. So in Swimen protocol, they write 2 times a day. But what we use is a synthetic ACTH. It has only to be given once a day. And one recent study what we have completed, whether the duration of hormonal therapy matters. So what we have given, we have prolonged the low dose hormonal therapy duration among those responded for 3-4 months, very low dose. So we observed the relapses were very low if you use the low dose prolonged therapy. So that is something very important, whether we can prevent the relapses, because if the relapses happens, there is a high probability they may even go into LGS very soon. So one should have an institute guidelines. This is our national guidelines from the AOCN, and similarly institute protocol should be there, so we can streamline the management very aggressively. And we should try best ever to mitigate the treatment lag for this condition. So I conclude by saying that your therapeutic success will completely hinges upon your accurate and earliest diagnosis and initiation of the right treatment. You should recognize this condition within 2 weeks and start. Even if you have high dose oral steroids, you start that. Don't keep MRI karalo, EEG karalo, and then they come after 2 weeks, and then window period gets prolonged and they may become non-responsive. I acknowledge various students who have contributed to the research. Thank you very much.
Thank you, Dr. Jitendra, for the nice elaboration of a very, I should say, emergency topic that you have mentioned. Do you recommend the general pediatricians to start treatment?
If you don't have a facility for pediatric neurologist, yes, please go ahead. High dose oral steroids you can start, and you can. It's only 2 weeks high dose steroids, and then tapering protocol is there. But if you have a facility, because there is so many other issues are there, etiology evaluation. But in our country, 80% of etiology is because of the HIE and the hypoglycemic brain injury. So in that context, the initial treatment remains the same.
Thank you.
Yes.
So, thank you, Dr. Shah.
Thank you.
Next, we have a panel discussion, the moderator of which is Dr. Dipankar Gupta. Can I ask the moderator to kindly come to the dais and introduce his panelists? Dr. Gupta is presently an associate professor in IPG MER, Kolkata, and a consultant pediatric neurologist. Has major achievements and teaching experience in undergraduate and postgraduate for 22 years. May I also request the other panelists, Dr. Shomir Kiro, Dr. Snigdhetu Ghosh, Dr. Shushmita Mishra, Dr. Shumantro Sarkar, and Dr. Shumita Pal. Can I request the panelists to kindly come to the dais?
One panelist may have, I think, has not come. Okay.
Dr. Gupta, please.
Yes.
The dais is yours.
Since this is a late evening today, and this is the last panel discussion, everybody is waiting to go home or like that. Our topic, panel discussion, is a very important topic, the management of acute ischemic stroke. So our topic have briefly being sidelined to beyond the neonatal period, because we don't want to encompass the neonatal causes of stroke. That's why this is there, beyond the neonatal period. Since the other panelists has not come, I'll just brief that WHO definition of stroke is from 2004. It's a clinical syndrome. It's a rapidly developing sign of focal or generalized disturbance of the cerebral function lasting more than 24 hours and may lead to death. This is the definition is still going on. And since the stroke is very infrequent in child, and it's a very, has devastating effects in the child if it's detected late. So this is the iceberg phenomena. It's missed initially. They may come only a brief cry, seizure, or headache, whatever the things. So average time is much more than 12 hours. So it is not within 3 or the recent guideline of AHA, there's 4.5 hours. So we miss so there's a why? Because of the low index of suspicion. And one or two cases before we're starting. These are typical features in a medical college setup, not in the private practitioner. It's a congenital heart disease patient with a hypoplastic left heart syndrome. There's a sudden right-sided weakness and pediatric NIHS scale of 11. It will be, NIHS scale will be briefly later on described. And this is outside the 4.5 hour window, so nothing to do. And atrial flutter cardioversion and generalized management, management for the general condition, and later on physiotherapy and thrombectomy. If it's available in a higher center, it may be done. Another one, just a 8-year-old female with a left-sided weakness. This 8-year-old girl immediately came. Lab investigation is done. The MRI shows acute ischemic stroke, initial therapy on unfractionated heparin, and subsequent daily aspirin. So what are the pandemic? Because the learning of the pediatric AIS is very infrequent, excepting this year. In this year, the American Heart Association and the Stroke Association and issued some guideline which is help for us, the pediatric neurologist, to manage the stroke. And it needs further workup. Dr. Mr. Go on. Another case. 12-year-old female.
She's a 12-year-old girl with sudden left hemiplegia and aphasia. So the diagnosis is right carotid artery dissection with ischemic stroke in right MCA territory. The etiology is arterial dissection, which accounts for up to 20% of pediatric AIS cases. The key learning is that we should consider dissection in any child with acute hemiplegia, and vascular imaging with an MR angiography or a CT angiography is essential in this scenario.
So these 3 cases are only few of the cases to show how it can present. It may present multiple ways, such as the child may suddenly have a fall and have hemiparesis. You may think that it is due to the fall, or it may the child has a hemiparesis or there was a stroke before the fall, like that. Briefly, Dr. Misro, regarding some childhood etiologic stroke and its incidence, and because our topic is AIS basically.
The incidence of childhood stroke is 2 to 3 in 1 lakh population, and it is divided into 2 categories, hemorrhagic and ischemic stroke, and we can see that both of their incidences are almost similar. Hemorrhagic stroke is 1.1 in 1 lakh and ischemic stroke is 1.2 in 1 lakh.
This is the one study which has given how much the AIS things may present. What is this is a large study showing the different incidents. Now, please tell Dr. Misra.
In 277 cases with arteriopathy, focal cerebral arteriopathy of childhood makes up about 25%, primary or secondary moya 22%, dissection 20%, vasculitis 12%, sickle cell arteriopathy 8%, post-varicella arteriopathy 7%, and miscellaneous types 4% with unspecified 3%.
So from this real world study, you see the incidence and the causes and is quite completely different from adults. Completely. Focal cerebral arteriopathy is completely due to the childhood age group. And moa is a genetic condition in the child group. So the etiologic consideration and the diagnostic consideration is quietly completely different from the adults, but the treatment may be similar to the adults. Dr. Samir Kiro, please. Some etiologies.
Yeah, as we saw last 3 cases, first case was of this cardiogenic origin, and last was vascular origin due to dissections, and second was not specific. So actually 50% of the cases, 50% cases are, usually more than 50% cases are arteriopathies. Like we saw in 277 cases, that was 525 cases of this arterial ischemic stroke was taken, and out of the 277 cases were arteriopathies. So actually there are major contributing factors. More than 50% of cases are arteriopathies. We have to very much cautious about while dealing with AIS. Second most common causes of AIS is cardiogenics. Though we in India we may be seeing less cases, but where the operations of due to this congenital heart disease are going on, due to catheterization, due to valvuloplasty or some things, the rate of arterial ischemic stroke is very high. And third common cause is this hematological causes. The hematological causes and other miscellaneous like metabolic causes contribute another 25% of cases. And in hematologic cases, we have to in western this part of India, sickle cell disease is very much common. It is contributing more cases if we compare with the western data. But there is no such review literatures, or there is no published paper is there. But in our experience in Odisha, the sickle cell disease is very much common, and we are seeing number of cases of this arterial ischemic stroke due to sickle cell disease. And polycythemia, thrombocythemia, and this lymphoproliferative disorder, leukomias, protein C, protein S deficiency, antithrombin 3 deficiency, and another thing, nephrotic syndromes. Nephrotic syndrome, though causes central sinus venous thrombosis are more common, but still they may cause arterial ischemic stroke in rarely. In metabolic causes, this homocystinuria, glutaric aciduria type 2, propionic acidemia, methyl malonic acidemia, nisobaritic acidemia, these are though rare. If we will suspect, then we can come across these cases also in our day-to-day practice.
So these conditions are more or less confined to the pediatric age group. One of them is MALS. MALS is totally due to HIE, due to torch infection, where there is a basal ganglionic stroke. This term may not be known to the common pediatricians also. And older infants, please. In older infants, Dr. Kiro.
These are the 5 most common things while dealing with primary vascular lesions. They cause this type of these are the common diseases: acute infantile hemiplegia, moya disease, Takayusu arteritis, though is large vessel disease, may also this carotid arteries extension into the carotid arteries may cause the thromboembolic phenomenon and the arterial ischemic stroke. Fibromuscular dysplasia may cause these dissections, is more common in these cases, so we have to be very much conscious. And hemiplegic migraines. So in rarity of cases, migraine infarct occur, and that may also are responsible for AIS. Though this hemiplegic migraine may also initially present like AIS, but they resolve. But some cases they present as a migraine infarct.
So since time is short, everyone must be brief. from now on, what are the main causes of this stroke, Dr. Sharkar, of this ischemic stroke in the pediatric age group? A lot of the etiologies of
when we see the pathophysiology of ischemic stroke, the ischemic cascades operates. What is that? When there is a ischemia, there is lack of blood flow, so resulting in the lack of glucose and ATP. And we know the membrane contains the sodium, potassium, ATPase enzyme. When there is a lack of ATP, the enzyme fails, so the sodium enters into the cell, and that starts the cytotoxic edema within seconds and minutes of the stroke. So timeline says, first there is an energy failure, followed by there is the damaged neurons. They release the glutamate, that is the cytotoxic material that stimulates NMDA receptors, AMPA receptors, and there is a massive calcium influx into the cell. And what calcium does? Calcium stimulates those enzymes, lipase, endonuclease, and all those enzymes. They damage, they progress into the necrosis. That is the first thing. And then comes the oxidative stress. Some oxidative materials like superoxide dismutase enzymes are operating, some superoxide formed, like hydroxyl, peroxynitrites are there. They start damaging the membranes also. And then in minutes to hours, there comes the inflammatory markers, that is TNF alpha, that is interleukin 6 and interleukin 1 beta, and these are damaging the cell membranes as well as the cell. But remember that when you give oxygen in the reperfusion area, there could be further damage due to oxygen. So be cautious giving oxygen in this patient, because when reperfusion is occurring, the oxygen, they can generate the oxidative molecules, and then oxidative stress then can damage the cells. Next, coming into that, apoptosis. The difference between apoptosis and necrosis is that when there is a necrosis, the cell loses its membrane. But when there is apoptosis, cell membrane remains intact. But as there is a programmed cell death, the cells will die definitely, but it will take some time. So from hours to days, apoptosis will continue, and that all these things will cause the infarct area, and that core, the infarct area, around that core there is a penumbra, and our target is to salvage that the surrounding area where the cells are still surviving, and the vessels are also supplying some amount of ATP and all glucose. So our target is to salvage the penumbra area. So this is the ischemic cascade, and that ischemic cascade operating after the acute ischemic stroke.
Now previously there was the FAST criteria, but now in the recent 2026 criteria, it is be fast.
Yes,
because
time is
brain. You should be fast, not only fast. So
yeah.
Please.
Time is brain. So that is the thing, stroke assessment pathway. Be fast means that is your balance, your eyes, your face, arms, and speech and time. So these are the things to be considered in.
This is the new concept of 2026. Before it was fast only. Face, arm, speech, and time. Now it's be fast.
Yes.
Clinical presentation.
And when you see the clinical presentation, it varies according to the age of the child. Commonly in older children, what happens? The classical presentation like hemiplegia, hemisensory loss, aphasia, and other neurological deficits. But it's difficult in younger children because all the signs and symptoms are very subtle. And there could be variable findings like seizures. There could be early hand preference. Hand preference usually develops by 3 years. So if the hand preference develops before that, that should be kept in mind. And the limping during walking. So the clinician must be very vigilant and suspicious to diagnose the stroke in the younger children.
Dr. Misro, please, some neurologic assessment tools in the children.
The GCA scale and the AVPU scale is the most commonly used things that we use in every ICUs, but we should also keep in mind the PED NIHSS score, which contains about 10 criteria with a scoring of 0 to 42. You should be doing it every 15 minutes for the first hour and then hourly until it is required.
Throughout the world, NIHSS scale is the most standard because all the medications and the new concepts are based on NIHSS scale. It is basically modified, as you see. The slide is a bit distorted. Basically, the modification is the criteria, meaning asking the question, because the child may not respond. So, asking the child, which is the time of the day, who is that? Asking drifting of the hand, the falling of the hand within 4 minutes. Only the criteria or the mechanism change, otherwise the score does not change. This is the modified NIHS criteria, and this is the brief discussion why the GCS score is not so much deficient, and this NIHS score is much more there. It is discusses, tell me please. The full the stroke, the different features can be caught up by the NIHS scale. This is a brief mechanism. What are the things touched on by the NIHS scale?
The loss of the altered consciousness level should be changed by asking questions and commands. The gaze and the visual field should be checked. The facial palsy should be checked. Then the motor activities of arms and legs should be checked. Then the sensory, language, dysarthria and inattention, they should be also checked. And the scoring is 0 is no deficit, 1 to 4 is minor stroke, 5 to 15 is moderate to severe, moderate stroke, and 16 to 20 is moderate to severe, and more than 21, that is 21 to 42 is the severe stroke.
We are more concerned with 1 to 4 and later on the 5 to 15 part. Now, Dr. Sringendu Ghosh, some points about the localization of this.
For the purpose of localization of stroke, brain is divided into 4 parts, namely cortex, corona radiata, internal capsule and brainstem. Internal capsule is basically that it is better called as capsulogangliothalamic region. So there are some specific signs and symptoms of these stroke of these areas. Nowadays, AHA considers seizure as a very important symptom of stroke. So in cortical stroke, symptoms may be seizure, sensory disturbances, then weakness or paralysis will be minimal, and sometimes there will be visual disturbances, and there will be cortical sensory disturbance mostly when involves parietal lobe, like tactile discrimination, astereognosis, sensory inattention or neglect, like this. And in corona radiata, these cortical symptoms will be absent. There will be weakness of both upper limbs and lower limbs, but this weakness will be asymmetric. In some cases, upper limbs will be more weak, and in other cases, lower limbs will be more weak. Especially in the anterior portion, lower limb will be more weak compared to upper limb. Whereas in middle and posterior part, upper limb becomes more weak and lower limbs lesser weak. And these cortical sensations will be a bit blunted. And in internal capsule or this capsulogangliothalamic region, weakness is rather much more intense. There is little difference between upper limbs and lower limbs, and that's why it is called dense hemiplegia. And also in this case, these cortical sensations will be slightly blunted. And in case of brainstem stroke, this is called crossed hemiplegia. So in the ipsilateral side, there will be cranial nerve signs, and weakness will be on the contralateral side. So as the distribution of or weakness are on the both sides, it is called crossed hemiplegia.
Now when to do neuroimaging? The neuroimaging is very essential regarding the new onset focal seizure, headache, and mental status alteration, the coma, new onset ataxia, sudden onset of neck stiffness, or like that. And whatever the thing is there, this is the previous one. Now the recent AHA guideline 2026 says that MRA and MRI is the primary criteria. But if there is, the thing does not exist, then even CT and CT scan may be there. So this is a clear, based on the new AHA criteria, MRA and MRI is the most important, and CT can be done if it's not available. And the first investigations are basically ECG, CT scan, angio if it is very quick. MRI is available in a tertiary care hospitals or a big corporate hospital. Hematology, CBC, platelet count, coagulation test. And sometimes the second tier regarding the transcranial Doppler and lipid profile, collagen phosphorus. This is a prothrombin workup, antithrombin 3, factor 5 latent. This is a stroke workup. And Shumanta Sarkar, please, the other part, other investigations. Because we want to go, time is less.
Yeah. So the third line are the metabolic workup. We have some blood test and we have some imaging studies. In the blood test, we have ABGs, serum lactate, specifically CSF lactate and pyruvate. And remember, the lactate pyruvate ratio is for the diagnosis of MELAS. If lactate pyruvate ratio is more than 20 to 25, then it is usually MELAS. And if it is less than 20, then you can rule out the MELAS. And there are certain tests like TMS and also urinary GCMS. Vasculitis workup should include ANA, all the ANCAs, P-ANCA, C-ANCA, extranuclear antibodies, and those cardiolipin antibodies and lupus anticoagulant. So the vasculitis workup, and then we can go for this mRNA, exome sequencing for MELAS. There are some imaging studies like DSA, echocardiography, particularly transesophageal echo. If the common echo cannot find out anything, we go for transesophageal echocardiography. And the management part is very important. The first 15 minutes is very important. Our goal is to establish the cerebral perfusion, oxygenation, and also minimize the demands for cerebral blood flow. So head of the bed should be flat or 30 degree. When the patient is alert, the bed should be flat. But when the patient is not alert, there is a chance of aspiration. Make the bed 30 degree. IV fluid should be given, that is isotonic or maintenance, but don't give dextrose. That can cause hyperglycemia. But the recent AHA guideline, they have given that there is no role of maintaining the glucose. So previously it was there, but it was straightly said forward, said that no maintenance of glucose, and also strict maintenance of blood pressure also has been against the new rules.
The new rule says that you need not decrease the blood pressure even after thrombolysis. There is no need of seeking the blood glucose, but you should try to go as far as
baseline glucose we can do, but the strict monitoring is not required.
Thrombolysis is possible, you can do in a selective setup. They are much more conscious. This is a clear guideline which is different from the previous guidelines.
Exactly. Oxygen should be given when the room air saturation is just 95%. Otherwise, oxygen is not required. And other is that paracetamol should be given if required. And management, the 4 pillars of management.
Dr. Samir Kido, the 4 pillars of management.
Yeah. When we suspect that the child is having acute ischemic stroke, we should determine whether it is a stroke can be, it may be due to acute ischemic stroke, or it can be hemorrhagic stroke, or CSVT also. First, we have to determine whether it is a acute ischemic stroke or it is a hemorrhagic stroke. In order to that, we first we have to rule out whether it is a hemorrhagic stroke. If hemorrhagic stroke, then we are not going to give any anticoagulant therapies. So we should be restrained from that. First, if we rule out it is a non-hemorrhagic stroke, we may go for unfractionated heparin or low molecular weight heparin subcutaneously. And that has to be given for 7 to 14 days. Then depending upon the situation, we may extend that up to the 3 to 6 months. Then we taper into the aspirin therapy. Second,
heparin dose is given 70 to 100 international units for 10 minutes. Yeah. Heparin. And maintenance dose 28 units per kg per hour in children less than 1 year, and 20 units per kg per hour more than 1 year.
We will have our inauguration ceremony now. To start off the inauguration program, I request Dr. Jashodhara Choudhury to kindly come on stage.
Sangachadyam samvadadhyam sambho manamsi janatam. Let us move together, speak together, and be in harmony, just as the gods of old time, for the sake of pediatric neurology. And with that, we welcome you all to Kolkata, the cultural capital of India, for East Zone Neuropedicon 2026. Let this be a confluence of wisdom, innovation, and academics, and a combined fellowship inspiring us to bring a brighter future for pediatric neurology. With that theme, I'd like to welcome Dr. Arijit Chatterjee on stage as the President of Society of Pediatric Neurology Bengal, and Sir will welcome you all.
Good evening, everybody. I've got a sore throat and an irritable cough, so I'm not going to talk much. Just to say that we are all, as part of the organizing team of West Bengal as well as East Zone, we are delighted to have you as the faculty, the delegates, and of course the pharma people who are supporting us. So hope you are having an enjoyable time so far. I think we've done excellent today, although we are running slightly late, but the overall program was very, very well organized and coordinated by our team. And there's another day, a second day, and of course today we have an evening function, so I want you to all relax and enjoy yourselves and stay back until tomorrow evening. By 5 o'clock we should wrap up things. Thank you very much.
I would now invite on stage Dr. Jitendra Shahu, Chairperson, AOPN. I next invite Dr. Vinit Wankhede, Honorary Secretary, AOPN. I would like to welcome Dr. Shashmita Devi Agarwal, Chairperson, East Zone, AOPN. Next, I welcome Dr. Prakritish Bora, Secretary, East Zone, AOPN. Dr. Shukanto Chatterjee, Senior Vice President, IIP. I now invite on stage our chief guest, Chief Patron of Society of Pediatric Neurology Bengal, Dr. Tridip Banerjee.
May I welcome the chief guest of honor today, Dr. Somnath Chatterjee, Chairman and Visionary Leader of Suraksha Diagnostic, Entrepreneur and Visionary of Healthcare System. Welcome, sir, on the stage.
I invite Dr. Dipankar Gupta, Scientific Chairperson, Co-Organizing Chairperson, and I invite on stage our Scientific Chairperson, Dr. Kalpana Datto. Chairperson, Reception Committee, Dr. Kalpana Datto. I request Dr. Arijit Chattopadhyay sir to kindly felicitate our chief guest, Dr. Tridip Banerjee. I also request sir to kindly felicitate our guest of honor, Dr. Somnath Chatterjee, sir. I request Dr. Tridip Banerjee sir to kindly felicitate Dr. Jitendra Shahu sir. I also request sir to kindly felicitate Dr. Shashmita Devi Agarwal. I request Dr. Kalpana Datta ma'am to kindly felicitate Dr. Vinit Wankhede sir. I also request ma'am to kindly felicitate Dr. Prakritish Bora. I request Dr. Jitendra Shahu sir to kindly felicitate Dr. Shukanto Chatterjee sir. Senior Vice President, IAP. I also request sir to kindly felicitate Dr. Kalpana Datta ma'am. I request Dr. Jitendra Shahu sir to kindly felicitate Dr. Kalpana Datta ma'am. I request Dr. Vinit Wankhede sir to kindly felicitate Dr. Dipankar Gupta sir. I also request sir to kindly felicitate Dr. Joshodhara Chaudhuri ma'am. Sir, I also request Dr. Vinit Wankhede sir to kindly felicitate Dr. Shrudeep Shah sir. I request Dr. Tridip Banerjee sir to kindly felicitate Dr. Orijit Chattopadhyay sir. I request our guest of honor, Dr. Somnath Chatterjee sir, to kindly share a few words with us.
Hi, good evening, and it's a wonderful thing to see, academic places, and one, I must be honest, and one feels so terribly insignificant in the presence of such learned people. One wishes that one didn't go the business way and one followed the academic way. But so many of you have dedicated your lives, your whole effort in cultivating this wonderful science. My daughter happens to be a neurologist, so I understand what goes on. And I wish you all the very best from the bottom of my heart. And please keep this up. You know, West Bengal, if it needs something, it needs academic brilliance, it needs research brilliance. And that can only come from you. Like the leadership that you have shown today evening, you have shown throughout the day, I must say, by organizing this program. Do more of this, do more in the districts, take knowledge back to people. I can always assure you, people are hungry for knowledge. Thank you very much, and thanks especially to Joshudhara for doing all this. I definitely don't deserve to be a guest of honor anywhere on earth, but thank you very much.
Thank you, sir. I now request Dr. Jitendra Shahu, sir, Chairperson AOPN, to kindly share a few words with us.
Respected dignitaries and everyone. So this year we are celebrating 25th year of AOPN, and this event is one of the very landmark event during this journey of 25th year. And I congratulate all the organizing team, Dr. Rijit, Dr. Sudeep, Dr. Jasudhara, and everyone. It tells you the relentless dedication and sustained efforts it requires to make this is possible. And just few lines more that we are moving towards Viksit Bharat, and it is our responsibility that we should also move towards Viksit Child Neurology. So in this, it's very important that we empower our pediatricians to provide the excellence, best care to everybody. And it's possible that we should practice that every child whom we care should receive the best, like the international standard. So we should empower, that's the responsibility for every one of us as a clinician. As a teacher, it's our responsibility. It's time of artificial intelligence, and now the students will be going to addicted to the artificial intelligence. So it's our responsibility to forcefully teach them the natural intelligence by doing such conference and making them to attend and to listen, and yeah, that we have to do forcefully now. So we will see how we do it over that time period. And also as a research excellence we have to do, even in the corporate or the private, everywhere. India has a unique advantage at the patient population. We have the huge number of patient population, and we should not be just कि बाहर AI की software हम खरीद रहे हैं और इंडिया में use कर रहे हैं. We should develop our own sustainable, affordable healthcare solutions. AI के लिए validation हम use करें अपने patient population में और new tools develop करें. That's very important with this. Jai Bharat, Jai Hind.
May I now request Dr. Sasmita Devi Agarwal, Chairperson East Zone AOPN, to share a few words with us.
Hello everyone, a very good evening. Respected dignitaries on the dais and off the dais, our National Chairperson Dr. Jitendra Sahu sir, Dr. Orijit sir, Dynamic Secretary Dr. Vinit Wankhede, Chief Guest of Honor, and my Secretary Dr. Prakritis Bora. It is a great honor and pleasure for me today to welcome you all to our 5th East Zone Neuropedicon as the President of this chapter. The East Zone Neuropedicon started its journey long back, 5 years back, and it was from my state, that was in Odisha. And we conducted the first East Zone Neuropedicon at Puri, the Lord Jagannath Dham, with his blessings. And I hope with his blessings we are here today and doing the 5th East Zone Neuropedicon. The idea of this East Zone AOPN chapter was to update ourselves about the recent advances in the pediatric neurology and to sensitize the pediatrician so that to sensitize the pediatrician about the recent update in the pediatric neurology, so that we can provide, as my national chairperson told, we can provide the best care and management to our patient in this region. That was the idea of opening this chapter. I hope we are doing this, and always there is a scope to do better, and definitely we will do more better in the future. I extend my congratulations to the entire organizing committee of this East Zone Neuropedicon, particularly Dr. Sudeep Saha, Orations sir, and Dr. Jasodhara for curating such a nice academic session with beautiful scientific program. I also thanks my good friend Dr. Kalpana and our East Zone Vice President for this beautiful conference, and our chief guest of Suraksha Diagnostic Center. Thank you very much.
May I now request Dr. Vineet Wankade, Honorary Secretary, AOPN, to share a few words with us.
Good evening, everyone. Esteemed dignitaries on the dais, off the dais, chief guest, and President, my President, Dr. Jitendra Sahu sir, President-elect, Dr. Arijit sir, President of the East Zone, Dr. Sasmita Madam, and Secretary Dr. Prakritish Bora sir, and the beautiful audience. So once again, I congratulate to the entire organizing team for being such a wonderful host. And we have been witnessing this since so many years. They have been consecutively doing these conferences, and the beautiful audience is always there. So I'm a National Secretary of this AOPN. My chairperson, Dr. Jitendra Sahu, is there. So this was a few things which we have achieved. I got installed last year as a secretary, and I finished 1 year in this March end, and then the new year started with Dr. Jitendra Sahu as a vibrant chairman of this chapter. So I feel esteemed privilege that what we did, there are a few numbers I want to say. So total physical programs of this organization which were conducted across the nation was 145. New members which have joined is more than 400. Earlier we were 722, more than 1100. We hold 15 state conferences, 48 national CMEs, 12 workshops, 6 focus conferences, 8 new state chapters were started, and pan-India we are present in 21 states. So these are the few numbers which I want to share with you. So these were the people who have laid the foundation of our central AOPN. Earlier it is to call Neurology chapter of IIP. Now the nomenclature is AOPN. We've been fortunate that we had a great advisors, blend of generations from younger to seniors, and this was our past team. Thank you to all of you for being supportive. With all your help, only the 4 states which were the AOPN was there till 2020 was Odisha, Kerala, West Bengal, and this thing. And now, with the intense efforts of our vibrant team, we are present in 21 states. So the 21st state was Jammu and Kashmir, which was launched 15 days back. So Dr. Jitendra Sahu, he is our honorable chairman, who given roles and responsibility to each one of us and had started with the presidential action plan this year. And this is our vibrant team this year. So Arijit sir is chairperson-elect, vice chairman is Dr. Sasmita Agrawal madam. So you can see many faces from the East Zone. These are the different, and the Dr. Jasodhara is the East Zone EB member, and this is our team. So detailed 50 points presidential action plan was started. Role of each one is defined. It's not only the secretary or the chairman is working. Each one of us is working very hard, and that's how we could achieve this target. So this were the work which has been assigned by our respected chairman to each one of theirs, and that's why we could do 97 programs of what we have promised last year out of 100. And this year we have 50 more to do and pursue the earlier one which was started. So this is a scientific committee. Dr. Joshi sir is in charge, and this was the work assigned to them. So as sir told you, we want to reach to the, so this is a theme which was given by Dr. Jitendra sir, every child brain matters everywhere, and this was a theme given to me, and I felt that these are the core areas with which we should work. Already here is elaborated research, academics, guidelines, advocacy. Our guest of honor also talked about the same. So we felt the 50-point agenda should revolve around the governance, conferences, and promote research, social activity, and public awareness. So first time we held a installation ceremony at PGI Chandigarh. This was the first time any private organization of the doctors have conducted a ceremony inside a institute, topmost institute like PGI Chandigarh. And this was the glimpses of our installation ceremony happened in the month, 2 months back. So we have regular EB meetings and monthly updates. This is how we seriously conduct our EB meetings. There's a meticulous calendar, planning for each calendar, because every single month we have a national focus conferences, and every week we have a national neurology CME. Because we want to reach out to the people, then only we can reach out to every brain of a child. So then people ask me why state bodies were formed. These were all states which we have formed in 2025-26. And smaller places like Bagalkot in Karnataka could have a state neuropedicons, just because we conceptualize that only the capital city of the state should not have the conferences. It should spread out to the different parts of the states, and that only possible if the state body is there. And that's how the conferences which were held from Mumbai was shifted to Yavatmal from this year. Madam has beautifully conducted a conference from Bhubaneswar to Sambalpur, Indore to Jabalpur, and Kochi to Payanur, and that's the success story of our state AOPN chapters. So wonderful modules of the specialty was given to each one of them, and they have created a wonderful modules on this dedicated topics, subspecialty topics like epilepsy, neuromuscular. So, and they did their responsibility very well. Great work is happening with the competitive spirits. As a team, we all are growing. So earlier we used to have only 15 office bearers of the central committee, but because of the state AOPNs, we have now 290 office bearers across the country. That itself is a very big number. We are first time legal team which was formed. So as sir has told, this is the 25th year of our celebration of the Academy of Pediatric Neurology, and we all are very fortunate that we are working in this 25 year. So as I told you, 400 new members were added, and this is all the membership privileges. I think most of you are members, because Jasodhara and every one of us over, and sir, specifically Sudeep Shah sir, has worked very hard to make the members. I think most of you are members. Those who are not, please become a member of this chapter. There are so many privileges. I will not go into details, been asked to talk very short. But so very easy process. You have to just scan this code, send 2000, and you will get a lifelong membership with so many advantages. We have a user-friendly website which was recently upgraded. We have started with the AOPN directory so that we can communicate with each member, and the pediatrician should know where the pediatric neurologist is there. So this was released at Neuropedicon. There is a WhatsApp group which is having a continuous academic knowledge which is shared every single day in the form of quizzes or the articles and everything. Regular quarterly release of the Neuro Bulletin and the monthly Neuro Webinars is an add-on feature with the responsible people given the task. Neuro Webinars are conducted. Digital IEP, with the support of IEP, we are reaching with this Neuro Webinars every month to 50,000 pediatricians across the country. So thanks to CIP President and Sir also, who were instrumental in starting this digital IEP. The Indian Journal of Pediatric Neurology started 10 years back, and I take extreme privilege to say that this is an index journal with the support of my friend, Dr. Amarjit Wagh from Nagpur, who is the chief editor of this journal. And there's a vibrant team of editorial team who was working very hard. Even Jasodhara Madam is also part of that. So research, so this is a flagship program. I told you that the specialty modules been conducted. Last year we had 5 modules. This year we have started 6 new modules in the pediatric subspecialty. Every single state has been given responsibility. Earlier we used to be dependent on the British Pediatric Neurology Epilepsy Training Program, but now we have a National Pediatric Epilepsy Training Program indigenously started and compiled by the AOPN. So one of the state, Maharashtra, my own state, has come up with this. We started the conference, we have launched it, and soon the CIP is going to launch it at Delhi. Sir must be aware of that. So it will be there across the country, and this was the best state award going to the Maharashtra state because of the so many work they did last year. Then the second state was Rajasthan, where this beautiful secretary report they have conducted. So the second award went to them. Neuroimmunology module, they are going to conduct in August last week, this year. Then this was third main important chapter is the West Bengal chapter. You all know they're a vibrant team and they are successfully conducting every year state neuropedicons. So this was the date. Neurometabolic module, what they have started, and I think most of you were there for the neurometabolic module. This was a program given to the West Bengal and they successfully did it last year. And this was a TOT attended by all national speakers. Then the UP chapter did a neuromuscular module. I will be little fast, so please pardon. Madhya Pradesh did a neonatal neurology module, which was installed this year only, which was inaugurated this year only. Telangana's chapter has started with the office practice module. National launch was already done. Jamshedpur, this is our Jharkhand team. Odisha team, Dr. Sasmita madam is here. She is going to be there. She has already had a Odisha State Neuropedicon at Sambalpur this year. And soon, next month, she will be having a neurogenetic module national launch, which will be there in the next coming month. So this is the 7th July. This is 9th July, European neurogenetic module. Then the Haryana state, Punjab state, Tamil Nadu state. So we are having a collaboration with the Indian Academy of Neurology for the first time, which is going to have how pediatric neurology is different than the adult. And we are going to take adult neurologists as a part of that, and we want to train them in sections of pediatric neurology. Neuroradiology module will be there. Then the Delhi state is going to have a European nutrition module. Kerala state is going to have neurodevelopmental module. So most of these modules are already there. We were not there in Bihar, but it is already now. We have started a chapter there. Jammu and Kashmir was not having a chapter, but last 15 days back, we launched the neuro-intensive module there. We started a chapter also. Books and publications, Simplified Neurology, I told only in morning. The second book is a T-table book. This is a very wonderful compilation of the 52 articles already submitted, and this will be launched at our Neuropedicon. On the very common topics, and you can learn neurology just while having a tea in your clinic. So that is a concept. Several publications been done by the members. IAP textbook of pediatric neurology, 4th edition will be there now. And these are the different books which are going to pipeline. State AOP and how they should function. Dr. Sasmita madam was instrumental in having that guideline, those guidelines. Best state awards we have started in 2 categories. AOP and Oration was started this year. In the memory of Dr. Kunju sir. And the gold PM Kunju gold medal was started this year in highest marks in pediatric neurology exam. So this is a best fellow award. So then we have a lot of initiatives like National Registry Initiative. We have collaborated with the genetic lab. We should have a compilation of the data, because unless we have a registry, we can't do a research. And this was launched at Nagpur with Mr. Nitin Gadkari ji was there. We have an intense fellowship training program since last 10 years at this 4 institute, and this one more center is added as Kanchi Kamakoti. We have a fellowship ICP control now, which is their specific body to govern that. We have started a compliance criteria also. So a lot of things are happening. I don't know what to share, what not, because I have to finish on time. So new concept of learning neurology, which every state is telling us we want to populate among the different states. We want them to copy the good models which they are coming up with. Then the digital technology we have on the social media presence, we're already there. This year we have started, it's not moving ahead. So it has just started, okay. So we have n number of things. We have started with the social neuro podcast. That's the series which we have started this year. So Neuro Podcast is a public awareness video with the 22 topics in pediatric neurology. The 22 experts will, we have shot their videos of 30 minutes each for the public awareness on the different topics in pediatric neurology. This was a program conducted. 1 minute neurology is a new concept. Dr. Sasmita madam is in charge, going to launch this program next month. This is because the attention span of the people is very low these days, because we are fond of reels. So we will be percolating the knowledge about the subject among the pediatrician, among the people, about the common topics, and the research paper to be given. That knowledge is to be percolated to pediatrician. Awareness will be given to the people. And this is what the madam has conceptualized. We have enough coverage in the news media. And this is a wonderful thing that with the collaboration of the government, because this is the era of collaboration, and the government is an agency where we can reach to the masses. And with the government support, we have started a unique child rehabilitation center at Nagpur. This is a 25 crore project, already functioning since last 2 years. More than 2,000 patients, child neurological patients were benefited. And we want every state to copy such modules. Please reach out to the government because they have already enough funds, but it's just because of the busy practice we couldn't reach them, and the healthcare delivery system is not happening to them. So we want to transform the public awareness program. We want to start with a newer concept like art for neurodiversity, where the paintings can be sold at a higher cost. So we visit to the disability centers across the country so that we can have a proper model. With our collaborative efforts, we started with the insurance to disability has increased from 1 to 5 lakhs. ICNC Taipei is another international conference this year with the support of Pratibha Madam. There were Indian delegates were taken to the international platform. So need of the focus conferences is something which is very crucial. You've been listening to the topics like MOGAD, and I'm very happy that a pediatrician is listening to these new topics and they want to know about the new things. So era of the newer updates, pediatric neurology approach meets. The approach meets do exist in the adult, but we want to start such program in pediatrics where only the case discussions. The experts will be sitting here and you are going to listen to that. Adult neurology approach meets is a very good concept which is happening by Dr. Singhal sir, and even at Pune, every year they do that, and huge attendance, almost 500, 800 attendance is there. We want to replicate this model. So having said that, this was our last year Neuropedicon. We had another conference in collaboration with the ID chapter Neuro IDCon this year, Agra, with the joint venture of PEDA and AOPN. This went very wonderful. And at last, I want to say the Neuropedicon. This is our 25th annual national conference of AOPN, which is going to happen at Lucknow. Please register for the same. It is going to having a great academic agenda. Dr. Anaita Hegde Madam, Lokesh Lingappa sir, Dr. Sanjeev Joshi sir drafting a very good scientific content. Please attend this conference. So please register and attend this. So these are all the highlights. What I want to say that AOPN has vertically reached from most peripheral part of the country, from Shillong to Bagalkot, Agra to Payanur, Bhilwara to Jamshedpur, and Amritsar to Tirupati. They say the district, and we had some event of AOPN there. So thank you so much. This was not possible without all your support of my office bearers, every single member who has contributed for the success of our program. And this was a special bulletin which was released last year. So we believe that the strength of each team is individual member and strength of each member is a team. So I make an open request to all, use this platform as intense for knowledge exchange, suggesting plans so that every single pediatrician, every single child in need, and every single parent in need should be benefited. Thank you so much.
I would like to request Dr. Shukanto Chatterjee, Senior Vice President IAP, to enlighten us with his words.
Good evening, dignitaries on the dais and of the dais. It's a privilege for me to be here on behalf of Central IP, and I see that the chapter of each IP chapters are growing very fast, and it is necessary. And what Dr. Bineet has so long described, that pediatric neurology is growing, and I'm very happy that in West Bengal, my students and juniors are taking this burden forward. And Jashodhara and Sudeep and all others are there. And for any help from Central IP, please tell me, and whatever I can do, definitely I'll be there. But I want that each chapter, like neurology, pediatric neurology, you flourish and let the knowledge be further escalated among young pediatricians, and they practice it for the benefit of the children at large. So that's my message. Thank you very much, and all the best for future wishes. Thank you.
I request our chief guest, Dr. Tridip Banerjee sir, to kindly share a few words with us.
Good evening, dignitaries on the dais and off the dais, and particularly my young friends. Congratulations, wonderful performance. Special thanks to the very young Jashodhara, Devopriya and Shudeep. Shudeep, you're still young. And not so young Dipankar, Orijit and Kalpana. Keep on doing this, make it better every day. All the best wishes. Do well. Thank you.
I now request our esteemed guests to kindly light the lamp and mark the inauguration. I request all our senior pediatricians to kindly come forward for the lighting of the lamp.
तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या कुन्देन्दु तुषारहार धवला या शुभ्रवस्त्रावृता या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्कर प्रभृतिभिर्देवैः सदा वन्दिता सा मां पातु सरस्वती सरस्वती भगवती We will now have the e-souvenir launch.
This is our e-souvenir which will be given in the group for everyone. And we have a book launch. I would request Orijit sir, Shashmita madam, Tridip sir and Vinit to release a book launch by one of our pediatric neurologists, Indrashis. Ma'am, sir, Shukanta sir. Dipankata chole shono pore. Kalpana ma'am. Thank you everyone for attending this conference. Thank you the trade partners. Thank you PAR. Thank you my East Zone team, my European team for giving us the opportunity for doing this conference. I hope you all enjoy the cultural evening after this. And I would request Ashmita ma'am, we can have the GB meeting ma'am in the boardroom beside this room.
Thank you, Shudeep and Joshodhara and all the team members for all your hard work. Thank you.
Thank you for very successful conference. Our local team. Thank you for day one, definitely. But the beginning shows the day. Thank you very much.